ಆರ ಕಾಣ್ತದ
Hello to everyone. Welcome to Disha Year-End Summit. That short snippet shows what Disha is. We're actually a bunch of friends and few of my very close friends on and off medical field. We joined together and we thought we'll do certain activities, not just the medical related activities. As you could see in the video, some social work we do and some photography, wildlife related events are there. And all of my friends are in the team, and I'm glad to have you all on board on a Sunday. And I think we are on time, and let us keep up with the time. Welcome to the Disha Year-End 2020 CME. We call it as coronacrinology. I don't think that COVIDology or coronacrinology word ever existed. Unfortunate pandemic situation has given us some opportunities also. Digital was never there or very hardly there, and I think it will stay. There are a lot of advantages of digital CME programs also, especially in a place like Bangalore. By the time you reach the venue, you could have finished your talk or you could have finished with your attending the sessions. So we have an elite panel today. The first topic is SGLT2 inhibitors, the wonder drugs of the decade. No two things about the statement there. And our extreme panelist, if you could play the introductory slides. Yes, Dr. GB Sattur, who doesn't know him, doesn't need any introduction at all. Not really one of the very good, terrific orators, more than 35 years of medical practice, a lot of camps he does, and a lot of educational. Recently, we interact in all platforms. He's there, whether it be API, RSSDI, and he's a big boss of Lipid Association of India. Innumerable papers, and he also keeps up company with the public a lot. And he's the awardee of Dr. B.C. Roy Award in 2018. Suvarna Karnataka Rajyotsav Award in 2005. He was chairman Karnataka Chapter Association of Physicians of India and is president of IMA Hubballi. And we are glad to have you, sir. I think you need to unmute yourself, sir.
Yeah, thanks, Manohar. Thanks a lot.
And the other panelists are Dr. R.K. Sahai. I think he will join us later, and then we'll move on to the next. He's Dr. Manjunath Shetty, the professor and HOD of nephrology, JSS Medical College and Hospital. Hello, sir. Welcome to our program. We're glad to have you. He's the one who was instrumental in starting DM nephrology, a prestigious thing at JSS Medical College, and his innumerable publications, both nationally and internationally. And he has won the MK Money Honor Oration, which is a very prestigious thing in the field of nephrology, as I understand. Welcome, sir. Moving on to the next panelist, a very famous personality across Karnataka and very good friend of ours, Dr. Girish Navasundi, cardiologist at Apollo Hospital, Bangalore. From his MBBS from JSS Medical College, Mysore, and he's done his MD from JNMC Belgaum, and he's done DNB cardiology at Hyderabad. He's a very, very well-known personality in the field of interventional cardiology and a very good speaker, and he's been part of a lot of Disha programs. Welcome to you, Dr. Girish Navasundi.
Thank you, Manohar, and wish you all the best for all the great work you do.
Thank you so much. Dr. R.K. Sahai is with us. Thank you, sir. Thank you for joining. Sorry, I missed you in the screen.
Yeah, good morning. Good morning. Nice to see you. Thank you for the invitation.
Thank you, sir. Thank you. I tried calling you. I couldn't reach many times. I'm sorry for that if I disturbed you sometime, but we are glad to have you back. And over to Dr. Sattur, who would sort of navigate through this topic, very interesting topic. I always tell SGLT2 inhibitor started as a diabetology molecule, and it has opened the doors of cardio, diabeto, nephrology. So in every perspective, we have all the specialists to interact and have a great learning experience. Over to you, Dr. Sattur, and welcome to all the panelists and all the delegates who have joined in, and all our co-speakers and chairpersons. Thanks for joining.
Thanks. At the outset, thanks, Manohar. It's a great experience to be with you all. I have heard about many of them, but meeting them for the first time on the stage, Dr. Girish, and Rakesh, of course, has always been there with me. Dr. Pradeep has been there. Dr. Vijay Kumar is not on often. Manjunath, of course, is always there in conferences. Dr. Shekhar also is there. So nice to meet you all, friends. And Manohar is somebody. Manohar, you have written there, I'll take 1 minute. Unsung. It was unsung when it was on the first year of Disha. Now it is sung so beautifully. We're all hearing a beautiful music from Disha. So let it be a sung. Thank you.
Unsung was actually a documentary. We'll come to that later sometime. Yes, sir.
No, I'm just kidding. So with all this, we will not take much time because Dr. Manohar says it is to be followed by some other program. All attendees know what we are talking about. So I'll cut short everything. I've been asked to ask a few questions to all the panelists, and just a couple of words on the SGLT2 inhibitors. We know that many of you may not be aware, when we were PGs, it was Inderal called propranolol, which was introduced by ICI, invented by Dr. Black, who was honored by the Queen of England and was called Sir later on. Right from then, you know that there is one molecule that hits each decade. Then, for example, if you remember ranitidine, that hit the screen. So, and then you remember about the metformin, although used in India, but never hit the screen in a big way, although metformin is a gold standard in the treatment of diabetes. Then came DPP-4 inhibitors with a tremendous rush and are still dominating the scene. And SGLT2 have almost arrived like a revenge molecule on a DPP-4, but they said, let us be together. And now we get molecules that are combination of DPP-4 and SGLT2 inhibitors. Both of them are extremely synergistic and complementary to each other because the mode of action is different. SGLT2 inhibitor, we all know, we are now going on to octet, and I'm told we are now on to around 12 spots, and maybe by the time 2021 ends, there could be around 18 to 20 target areas for anti-diabetic molecules. With this, we know that excellent 4 trials that have been there for SGLT2 inhibitors, mainly acting on the SGLT2 receptors. Now, kidney, who would have thought of that kidney molecule? But did you all know that in 1933 was the first ever molecule that was to act on SGLT2 for inhibition was being detected, and it laid very low. All other like liver, pancreas, peripheral tissues, they all came into action, and kidney was ignored. Only now in the last, say around 2013 onwards, this has picked up. And now we know with the 4 trials, mega trials, impressive trials, mainly the EMPEREG, the CANVAS, the Declare TIMI 58 and Credence, the last one mainly associated with the renal outcomes. And Dr. Manohar already puts it, it is not just across the diabetic, and we need to really take this point to the public that they think blood sugar is equal to diabetes. This is not. Blood sugar is only the makeup that we make out, whereas there are internal organs that are damaged, and SGLT2 molecule discussion now is probably an excellent area for discussion. We know that currently available in India, although some more molecules are coming up, the popular molecules have been EMPA, DAPA, and CANA, although EMPA, DAPA are definitely leading them. So with all this, manufacturing, we know initially the molecule costed around 26, 28 rupees, and now probably it's available for around 14, 15 rupees, and still come down also. So hopefully many patients, middle class at least, should afford the SGLT2 inhibitors. Having said this, I'll just go on to the questions that I have been asked to point out to all the eminent faculty. Now, I would request now that since the cardiologists claim that the SGLT2 inhibitors are our molecule with its usage on an array, although heart failure remains to be an important, but you never know. Like PCSK9 inhibitors, this may be one of the drugs in the ACS also. So could we start with our cardiologist friend from Bangalore? Would you please give your opinion on what do you think of the SGLT2 inhibitors, Dr. Girish? Let us start with you. Why do you think it's a cardiac molecule?
I think, anything you say would still be less about SGLT2 when it comes to heart failure. It's been such a fabulous molecule that whatever we had so far in the management of either diabetes, hypertension, or mainly heart failure was all working through neuroendocrine system, be it beta blockers, be it ACE inhibitors, ARNI. But then you have a molecule which has opened a door and a total different mechanism working on the primarily renal system and working at a cellular level rather than at a neuroendocrine system. And for a cardiologist, if you really ask me for starting any therapy, the cardiovascular outcome is the primary thing of a choice. When you look at all the drugs that are available to reduce morbidity and mortality and hospitalization for heart failure, when you look at it, it's so profound with an SGLT2 inhibitor that the mortality is reduced to an extent of relative reduction is up to extent of about 30%. I mean, if you take an ARNI, you take a mineralocorticoid receptor antagonist beta blocker, none of them have shown as much mortality reduction as SGLT2 inhibitors. I mean, this is on top of guideline directed therapy. That means someone who's already been on a beta blocker, ARNI, and mineralocorticoid receptor antagonist, and you add an SGLT2 on top of it too, and gain such a benefit is mind blowing, honestly speaking. So, if you ask me, anybody who's a drug of choice, and we look first opportunity to initiate. The primary reason is we all know the mechanism of action. How does it act? What does it do? But eventually, what matters to us is the reduction in hospitalization, reduction in mortality, and reduction in events. And another thing, if why is it important, is every hospitalization eventually reduce the lifespan of the patient by reducing, by increasing the mortality. So preventing one hospitalization for heart failure is a great benefit because it eventually reduces mortality. And this molecule reduces hospitalization by close to about 40 to 50%. So
Yeah.
these reasons, it's
Yeah.
become
Fine.
a choice for a cardiologist.
Yeah, fine, Girish. Dr. Rakesh, could you please tell us where would you place this newest molecule in the armamentarium against diabetes in diabetic practice?
Well, while we are discussing about the cardiovascular renal benefits of this molecule, let me also highlight that this molecule has got very good glycemic potential, glucose lowering potential, and it works. It is probably, you could say that it has got better efficacy than the DPP4 inhibitors if you are putting them in the category of moderately effective molecules. It has got very good efficacy as a glycemic efficacy, and then it has got additional BP lowering effects and weight lowering effects. So these are things that you're looking at even in patients without cardiovascular disease who are likely to, I mean, we know that all diabetics have a very high propensity to develop cardiovascular disease, at least 3 to 4 fold higher risk of developing cardiovascular disease and renal disease. And even when they do not have this, while the guidelines clearly state that in patients who have these issues, then they should be the molecules of choice. But even in those who do not have manifest cardiovascular disease, there is a significant burden of subclinical cardiovascular disease and a very high risk of cardiovascular disease developing in these patients. And I think because of the glycemic efficacy, the efficacy in terms of weight reduction and the BP lowering efficacy, and all the other metabolic benefits that these molecules offer, I think they are molecules which are preferred in managing patients with diabetes, unless there is a sort of contraindication to use, or unless there's a problem in using these molecules, as may happen in a very few subsets of patients where you may not want to use these molecules. But otherwise, I think these molecules are becoming the molecule of choice for managing patients with diabetes.
Yeah, thank you. Dr. Manjunath, would you please tell us how would you place SGLT2 inhibitors in renal practice?
Renal wise, actually, we are pretty excited because, as Manohar has put it, it is a wonder drug, and definitely something which we are much more excited after. I think AC and ARBs came around. This is something we are really excited about. As you know, nephrology, we hardly get much newer drugs. Like cardiology, every other day, or diabetology, every decade there is few new drugs popping up. But nephrology, it's all the same. So I think it's the one of the best things that has happened to kidney disease patients after AC and ARBs came in. So quite right, we are excited. And now that with all the studies coming in, especially the Credence study and DAPA CKD study, which were done basically keeping in mind the CKD patients. So the Canvas study and all, it was an offshoot of Canvas study where they found that it definitely had better renal outcomes. But Credence study was done on patients with diabetes and CKD, whereas DAPA was done on patients with diabetes, CKD, and non-diabetic CKD also. And it has shown the same benefit in non-diabetic CKD. So it's got actions apart from lowering blood sugar and helping the kidney. It has got other actions like reduces inflammation, reduces the interstitial edema, It is supposed to reduce the fibrosis and tubular atrophy in the kidney. So a lot of other actions. So we are quite excited, especially after the DAPA CKD study has come out. It's phenomenal, as Girish said, that all these patients are already on ACARB maximal tolerating doses and all the other drugs. So maximally maintained. On top of that, when you add this, you are getting benefits which are astounding, like 37% reduction in renal endpoints, which is quite exciting.
Yeah, thank you. I think the two main considerations for management are how these blood glucose lowering drugs would affect the heart and the kidney. I think coming to CKD and heart failure, definitely this, at least DAPA needs to be noted, although all have almost more or less equal effect. Dr. Rakesh, with metformin remaining constant at around 1000 milligram, where it is not used more than that in any of the manufactured tablets, would DAPA 5 or 10 make a difference? Do you suggest that they start with 5, or when you are really adding maybe for a PPG control or overall control, would you say straight away go ahead with DAPA 10, or do you say it's wise to start with 5?
Well, I would look at using only DAPA 10 and 1000. I mean, I would not look at using DAPA 5. The use of DAPA 5 was a little different. I mean, in the sense that, when we had molecules from the innovators, they were priced at a lower price or something like that was there. So that was the reason why I think DAPA 5 was used by many people. But I don't really see a great use of having DAPA 5 plus 1000, but I think I would certainly use DAPA 10 as the molecule and stick with the 10 milligrams dose there than go with 5 milligrams. I would not like to use 5 milligrams.
Yeah, that's very true. Because by the time you decide to use SGLT2, either you put them in a good ASCVD risk category or in the non-ASCVD risk where you really want to bring down HbA1c properly. So 10 milligram makes sense. Thank you. Now, Dr. Girish, what about
Yes,
its
sir.
use in atherosclerotic heart disease as a big spectrum? Where would you put it?
Okay. Thank you, Satur sir. I think, first, when you initiate a drug, you go by the clinical, the trial scenarios and use it because it's a class 1 indication. But then you slightly expand the indication looking at the clinical scenario of the patient that you're treating. As you know, this is such a wonderful drug that it reduces the weight. It reduces the most of the lipids are improved, except that there's a marginal elevation in LDL. Then blood pressure reduction is seen, and then it acts on the heart, it acts on the kidney. So when you look at that, this has got a very wide spectrum. But if you look at the atherosclerosis versus heart failure, at this point, it is primarily a heart failure related medication than focused on atherosclerotic, because whatever the evidence that we have is on all heart failure patients. Also, this has got a benefit independent of diabetes. So those patients who have established cardiovascular disease and heart failure, the benefit, DAPA-HF study shows the benefit is as much as in those who do not have diabetes. But if you are primarily looking at reduction of myocardial infarction or stroke, which is the atherosclerosis, I think the GLP-1 agonists have become the class 1 indication. Probably next would be a SGLT2 inhibitor. That's how I would probably position.
Yeah, and very fortunately from year next, we'll have oral GLP-1 receptors, hopefully. So that would really take us much nearer. Dr. Rakesh, in a newly diagnosed diabetic patient, where would you put DAPA in a routine diabetic practice? Unmute.
Yeah, sorry. So basically, what we are seeing is that when these molecules came in, about 5 years back. If you look back 5 years back, when we just had the introduction of EMPA and DAPA into the market, and we didn't have the EMPA-REG study at that time, we were a little skeptical. I mean, although we were very happy about the different mechanism of action and the glycemic lowering potential, along with the blood pressure lowering and the weight lowering efficacy of this molecule, but we were skeptical about the risks of euglycemic ketoacidosis that was there, and we were all worried about using them routinely in many of our patients. But over the years, with the several benefits being identified, the cardiorenal benefits, and also the fact that the euglycemic ketoacidosis, which was spoken of very often earlier, is now understood that it is a very rare scenario that we are seeing, particularly when using it in a very inappropriate manner. So we have learned to use these molecules, and I think with that confidence, I think we are using them more and more as second line molecules after metformin, and in many instances, maybe along with the DPP-4 inhibitors, metformin DPP-4 inhibitors, this molecule. This is how commonly.
Yeah, Dr. Rakesh, right from day one, if you have got a non-osmotic patient with a blood glucose of around 400, and for whatever reason he refuses to take insulin, or you are keen on insulin to begin with, some studies have shown that, as you know, to preserve beta cells, and he says, give me oral. Would you add that consideration without an ASCVD risk, patient who doesn't have osmotic symptoms, 400 milligram blood glucose, would you like to add this drug, unlike, say, for example, glimepiride with metformin? Would you take this to that level and start on day one?
Well, that's precisely what I was saying, is that is one scenario where we will be little cautious about using these molecules immediately at that point of time, where we see that there is severe hyperglycemia, even though you don't have very severe osmotic symptoms. But definitely we would be cautious of using these molecules. DPP-4 inhibitors, by the way, I mean, in that context, fit in very well. They are molecules which fit in very well in that context. They don't cause hypoglycemia. They can bring down the glucose appropriately, and also they do not have this risk of causing a ketoacidosis. So that is, that is one scenario which you have very clearly spelled out, is where we would be a little cautious about starting off with the SGLT2 inhibitor, and once such a patient stabilizes for a while and his blood glucose levels come in the 200s, and then that's the time when we would think of SGLT2 inhibitor.
Yeah, just one interesting question to all the participants, unrelated to SGLT2. If this patient of 400 odd blood glucose had significant osmotic symptoms, would you insist on insulin, or any other ideas you have, like using oral in case it doesn't work?
So if I can start off, I would say,
would you insist, is my question.
Yes, I would insist on insulin. Yes, I would insist on insulin.
Great. Thank you.
If I may add, SGLT2 inhibitor works only when there is a background insulin availability is there. In an insulinopenic situation, it is not the safest drug to be introduced. So maybe you can use either insulin, the one like a glimepiride or a DPP-4 inhibitor to get the insulin going, and then add SGLT2 inhibitor. Insulinopenic situation, I think this is not the right drug.
Yeah, and from nephrology point of view, definitely I would not use, because guidelines and the experience and the literature says that see that the patient doesn't get into even mild dehydration if they are on SGL2 inhibitor. So already if he is having osmotic diuresis, the chances of becoming volume depleted or going into dehydration is high. So
I think
insulin should be used.
Yeah, I think extremely important take-home message, although unrelated to SGLT2 inhibitors, would be that osmotic symptoms, very high glucose levels, insist, Dr. Rakesh, I entirely agree with your statement, insist on insulin. Otherwise, refuse to treat him. You are not doing justice at all. Let him go where he wants to. Okay, now to Dr. Girish. In post-op cardiac patients with diabetes, any cardiac related post-op, that's what the question means. If there's anything specific, we'll come to that later on. Would you think of using these molecules, say, right from the next post-operative day that you are allowed orally or whatever? Or you think you should hang on for time until the volumes are adjusted? Or what, you have any other, sort of points to consider?
Thank you. I may restrict myself to a heart failure patient who's already been on SGLT2 inhibitor. Otherwise, it will be an endocrine, genre. My take has been ICU setup or immediate post-operative time SGLT2 inhibitors not to be introduced, because you want a patient to be active, ambulated, eating, and having a certain level of his blood glucose to be settled, and certain
Absolutely.
predictability about hydration, certain predictability about stabilization of his renal condition is important. It's not a drug that it'll make wonders in a few days, but it is something which will work very effectively over a period of time. So in my opinion, immediate post-op not to be used. It is to be introduced in a stable patient down the line.
Yeah, that's very true. I think the one would definitely, whether cardio or a nephro expert, nephro or endo expert present here, would definitely agree with that point, because volume is an extremely important factor in the thinking of SGLT2 inhibitors at all. Otherwise, you could really push into problems. This question is to Dr. Manjunath. If the patient had one or two incidences of urinary tract infection, as we know, it is one of the commonest ways of presentation with diabetes. So he had one or two, definitely with chills and rigors. You have isolated maybe gram-negative organism from the urine culture. Do you think in such patients, now that he may be having the DKD, what about the SGLT2? Where do you put them with a background of DKD, with a background of urinary tract infection, something like gram-negative maybe, for example?
First thing I would like to state here is the studies have shown not a significant increase in UTIs. It's just a small percentage of increase in UTIs. And studies like EMPA-REG have not shown any increase in UTI incidences at all. And most of them quote that if one or two incidences of UTI is there, you can still go ahead using the SGLT2 inhibitors. But if somebody has got already severe infection like pyelonephritis, infection of the parenchyma, then I would be very hesitant in starting them. And especially if somebody has got obstructive symptoms, so you should not venture around to start SGLT2 inhibitors. So if somebody has just had cystitis or urethritis, one or two incidences, still you can start SGLT2 inhibitors. And just by following uh, personal hygiene, good personal hygiene, you can prevent most of the UTIs, because most of it occurs around the periurethral region. You get fungal infections, but just by washing your genitals regularly in a proper way, keeping personal hygiene, you will do wonders. And another recommendation is to keep your bladder empty as much as possible, not to hold the urine, so that once the urine stays for a long, because of the sugar level in the urine, it becomes a culture media. So other important thing is to keep emptying your bladder. Otherwise, if there is no obstructive this one, if he doesn't have bladder outlet obstruction or any strictures or anything, and parenchyma has not been infected, just one or two episodes of cystitis or urethritis should not preclude us or avoid us from using SGLT2 inhibitors.
Yeah, because very true, ruling out obstructive uropathy and emphysematous pyelonephritis, you never know, because of very high diabetic state when they be pushed into. That's a good take-home point. One more question for you on this.
Yes, sir.
In CKD, which of the three SGLT2 inhibitors would be your preference? Not that the micro with the DAPA has called this. What would you like to say?
No, for me, the preferences would be canagliflozin and DAPA. Cana and DAPA, why I'm saying is because studies have already implemented them. In Canvas study and Credence study, it's been proven. And Credence and DAPA are two studies which are directed towards the renal endpoints. And Credence also has proven both the studies were actually in fact stopped in between because the benefit to the patient was so high. Abruptly they were stopped. So I'd like to have CANA and DAPA. DAPA not because micro are coming out, but because DAPA CKD has been just recently published about 2 months back, and astounding improvement. And the exciting thing is that even in non-diabetic CKDs, there was same amount of this one benefit in renal endpoints compared to diabetic CKD. So these two molecules have been already established in CKD patients, and DAPA they went on to take patients with GFR up to 25 ml. So, and they saw that at least more than half the patients had a GFR of less than 60. So that was the important thing. So I would prefer
Okay.
DAPA and
Okay.
CANA.
Sir, time
Yeah,
constraint.
I know. With the appearance of Manohar, there will be only one last question to all the three panelists. Which study? We're starting with Dr. Rakesh. Which study influenced you maximum? Was it DAPA HF, DAPA CKD, EMPA-REG, Canvas, Declare TIMI 58? Dr. Rakesh. Unmute.
Yeah, sorry, all of the studies are very unique. All of the studies have given different insights because they had different populations enrolled. But I would say that if you look at it, one study which keeps giving you a lot of information, keeps reminding you about this thing is probably the EMPA-REG study, which was the most initial thing, and that has actually changed our thinking about the SGLT2 molecules. And although every study is unique, the DAPA CKD has given useful information, Canvas has given useful information, the Credence study has actually made us start thinking about it as a renal molecule. So I think every study has given new insights, has given additional insights, but I think the EMPA-REG, which was the first one, I think still remains as a very useful study, which will always be remembered. I think that actually made a change in our all thinking about these molecules.
Absolutely. Dr. Manjunath.
Sir, as a nephrologist, for me it is Credence and DAPA CKD. DAPA CKD we are very excited because it is with non-diabetic CKDs. So something for us to use for non-diabetic CKDs also. So I'd go with DAPA CKD.
Okay. Dr. Girish, what would you prefer?
Girish, unmute.
Unmute.
As a specialist, you would go by your domain study. I think DAPA HF, it's such a fabulous study, and Emperor reduced. You have shown benefits in independent of diabetes. So that means to say, this is a molecule for a cardiovascular purpose. I think that's where the profoundness of this molecule comes to us.
Yeah, thank you very much. And just to conclude my last statement, asking the difference between CANA, DAPA, and EMPA, which one would you use? Is like probably asking who is more beautiful. Is it Madhuri Dixit or is it Aishwarya Rai? Or also asking, is Salman Khan a better actor or a Shah Rukh Khan? So I think each one of you have preferred your own field, but since all of us treat the same patient with different organ involvements, I think we really zero in on the opinion that the molecule that suits you best, that the molecule you think you are used to would be the best choice. Thanks, Dr. Manohar. Thanks, Girish. First time I met Girish, very nice and impressive talk by you. Amit always talked about you. So it was nice to see you. Rakesh, as usual, has with me on many platforms. Manjunath, as usual, has been a great speaker and well-knowledged person in nephrology. Thanks a lot, Manohar. As usual, I wish Disha a tremendous direction and Disha to go along, spread in all directions. According to Veda, there are 8 directions. Let your name, let the good work spread into 8 directions. Thanks a lot for involving.
Thank you, sir.
Thank you, sir, for being
so
such
much
a
to all the
fabulous,
panelists. It is said that well begun is half done. So I think it was a very impressive start to our program, and I would like to thank everyone. Thank you. So we'll move on to the next topic.
Thank you for the opportunity.
Thank you. It was my pleasure. Thank you, sir. So multifactorial approach for diabetes management and where do GLP-1 receptor agonists fit in. I think when it comes to injectable, we always talk about insulins, but now it is time for GLP-1 receptor agonist therapy, injectable, but has tremendous benefits of late. It has been showing, and Dr. Sattur also was alluding to the oral component of it being hitting the market shortly. So to chair this session, I have a good friend, Tirthankar. He was my colleague at Ramaya Medical College, a very bright fellow. He has done his MRCP, UK from Royal College of Physicians, and he's currently working at KIMS as an associate professor. And welcome to you, Tirthankar. And to speak on this, we have Dr. Suresh Damodaran from Coimbatore. He's a consultant endocrinologist at Sri Ramakrishna Hospital, honorary consultant in Derriford University Hospital, Plymouth, UK, and he's affiliated to innumerable bodies, a lot of awards and honors. To name a few, it's the Donald D. Eswiller International Scholar Award presented by the International Diabetes Center, Minneapolis, Diabetes Awareness Initiative Award in 2014, and he was the organizing secretary of International Diabetes and Endocrine Conference, DECON, what they call it as, and he has quite a few publications. We are very, very happy to have you, Suresh, on board. Over to you.
Thanks for kind words. It's my privilege to invite Dr. Suresh. So without wasting much time, I think over to Dr. Suresh.
Good morning, everyone. Am I audible?
Yes, Dr. Suresh.
And am I visible? Great. Thank you. Thanks very much for the wonderful opportunity. Good morning to everyone. I think it's fascinating to see the start, and it is like a group discussion that enlightened us with the SGLT2. Now, when we come to the molecules that is being currently discussed in the world, which has got much more, priority in the guidelines. The next one to SGLT2 comes in the GLP-1. And we are going to see for next decade or so, these two molecules are going to be the key thing in the management of diabetes with the evidence pouring in. I think it's fascinating to see Rakesh and the troop was discussing about the evidences what the SGLT2 had. And the GLP-1 sector also, the amazing amount of evidence has come in, even the primary prevention, secondary prevention, and as Dr. Manogar was alluding to, the oral treatment of GLP-1. It is a fascinating area to watch in. And as you know, the combination of insulin along with the GLP-1 has come in. So it is an area where I think the more focus will be for the pharma companies in the next decade or so. So with that introduction, I would like to start, and it is like need of the hour. The chairperson for the previous session, he was alluding to about the whole lot of approach what the diabetes is all about, the omniscience octatet and other thing. So it is very important that we not only cover the mechanism of diabetes, along with that multifactorial approach has to be there. So today's objective for, if I can, in the next 20 minutes or so, can understand, make you to understand about multifactorial approach, and also discuss about the GLP-1, where does it fit in? And it is a sponsored talk of Eli Lilly. So this is my agenda. I want to focus mainly on type 2 and CV risk and possible therapies as a GLP-1 as an option, and the real world data, and also how to choose as a patient. So it's always good to start with a case study. And if you look at it, it is a routine patient of ours, as a 60-year-old female, hypertensive, shortness of breath, but she takes a dog for the walk. But apart from that, not much of physical activity, metformin 1.5 gram along with a gliptin, and also SGLT2 is there as well. So A1C 7.2 in spite of that, and I think EGFR 62, that shows mild renal impairment, but heart-wise, the echo showed EF of 55% with angiogram showing mild 3-vessel disease, which is not unusual for our Indian population. So no PCI is performed. We know it is a high risk with all this data, what we got, but in the real world, when you see, I'll ask you a question that whether this patient is a clinical concern of cardiovascular disease. I think the answer is probably yes, because of diabetes itself is a cardiovascular disease. With the patient has got so many background thing, and also angio showing significant disease. So the cardiovascular risk event in next 10 years, what is the chances of it? I'll come to that later, but I think it, it is quite high. That much you should say. So we know that the diabetes is just growing as a disease, and that projection of 2030 and 2045, India is going to be one of the major player along with China. So looking at it, that the Asian, we being an Asian, what is the challenges that we got? We got a high risk of diabetes in Indians due to low risk of threshold factors. So we got a lean guys with the BMI of less than 23, and the waist circumference is lower. But however, I think we know how much cardiovascular disease they are prevalent of. So increased body fat, especially the visceral fat, is in the high level, and high rates of type 2s. I mean, I'm seeing in my clinic, the youngest one I got a type 2 is about 10-year-old. So insufficient beta cell response to the normal body weight and type 2. And we don't know what the environmental factors are doing, what are the chemicals that is being used, the fertilizers that has been in our food chain. I don't know. There's so much things to discuss, but I think as a nation, we are high risk of getting the disease. So if you look at the asymptomatic evidence of Indian patients, less than 5 years, 5 to 10 years, uh, 15 to 20 years, and later. I just bring this down. So okay, so that is the 10-year risk will be very high when the duration of diabetes gets older. So 10-year CVD according to duration is very high. So this is the multifactorial. So if I want you to remember 2-3 slides in my talk, this is one of them. So it is a multifactorial approach. We have to manage the lipids, we have to manage the blood pressure, we have to manage the lifestyle, and also glycemic control and platelet inhibition. So the 4 things that we could manage, but the patient, however, has to manage the lifestyle. So if you look at the benefit of different intervention per 200 diabetic population treated for 5 years, you can see the blood pressure, LDL, and A1C all are very, very, very important. So all-cause mortality with UKPDS proactive, advanced, and VADT. You know, VADT and Accord, both of them very, very intensive diabetic management that didn't show that much benefit. But apart from that, all that has got all-cause mortality as benefit with the UKPDS proactive with pioglitazone. So evolution of type 2 diabetes after the metformin. So healthy behavior intervention, multi-risk factors, modifications. So if you add on, next one is adding on sulfonylurea along with metformin, and the A1C was the target. TZDs, A1C lower is the plan. That was around 2000 after the rosiglitazone fiasco. And then when it comes to 2010, now GLP-1 and SGLT2, as I mentioned earlier, we are talking about MACE, heart failure, CKD. There was an excellent discussion prior to my talk. So these are all the areas that needs to be focused with the current way of 2010. So it is a multifactorial, not it should be glucocentric that is needed. Glucocentric is the one that has been there for ages, but that is not the one we should plan for. We should plan for the whole lot, which is the multifactorial: hypertension, glucose, microalbuminuria, renal protection, inflammation. With COVID coming in, the inflammation plays a big role, and then the lipids. So of course, we have to address all this along with the glucocentric attitude. Then I think we'll reap the benefit. That is why the molecules, what we're talking about, SGLT2 and GLP-1, has got much more value or much more benefit when it comes to the cardiovascular endpoint or the death or whatever, 3-point MACE. So these are the additional things that has made these molecules much more different than the molecules that we've been using. It is not that the new molecules, we are just talking about it, but it's got the proper science to it along with that. So if all the guidelines has brought in the ASCVD, this you might have seen in so many meetings, ASCVD predominates. But the challenge in India or anywhere in the world is to find out asymptomatic cardiovascular disease patients. How do you identify? And that is the biggest challenge. But if you approach multifactorially, you might address the whole lot. So the GLP-1, you might have seen in past 10 years or so, how the GLP-1 acts, release, metabolism, and effect on GLP on body organs. So it acts on the multiple organs in the liver, heart, and brain, and pancreas. So that is why this is very, very unique in the way. This is published in 2019. It shows amazing after 10 years of launch. I remember using liraglutide or exenatide for that, Byetta for that matter, about 2007-8. That's the time it's been launched. But it's almost 12 to 13 years of drugs being used, and we know exactly what the mechanisms are. So if you, the pertinent questions we'll be choosing on GLP-1, how good is the molecule? What are the things that we look for is the comorbidities, weight, glucocentric effect, and hypoglycemia avoidance and precautions. So if you look at it, as I mentioned, exenatide, the Byetta was the drug that has been launched earlier, but it's a short-acting one. It is not available in India. Sun Pharma used to do it, but I think it's not available in India. Lixisenatide, Sanofi has got it, and liraglutide, dulaglutide, and albiglutide are very long-acting one. And as Dr. Manohar was mentioning, semaglutide oral is going to be there next year or so. So if you look at the GLP-1 as a molecule efficacy, any drug has to have an efficacy. If you look at exenatide, liraglutide, exenatide LAR, albiglutide, dulaglutide, semaglutide, and semaglutide oral with all the colors as it's been described in the chart. So you can see with the multiples, this is what I was mentioning about amazing amount of data has come in with cardiovascular endpoints with the lead 6 to pioneer 4. Amazing amount of data is available in GLP. We got no doubt with these molecules being so effective, and practical experience as well. You and me been using it for a very long while. I'll show you a real world data as well. So the difference in A1C efficacy is seen in Asians and non-Asians. So this is a meta-analysis that showed whenever you go for a conference and you talk about it, and then people come up and saying, where is the Asian data? But if you look at the Asian dominant studies, it's more than 4, along with 431, and a lot of real world data is there. But the favors treatment, the skewing of the curve is in this side to show there is a definite favors, there is a benefit in favoring the treatment in Asian patients. So how about the weight? The weight is also fascinating, reduction of weight with these molecules. With or without obesity, this is all for Asian patients. So you can see normal BMI, overweight, and the difference. So it is relevant of it. There is a good benefit with the GLP-1 molecule. So again, just to show optimal, what is the normal optimal with the studies that has been involved in Asians, that is about 6 studies with normal BMI and 15 with overweight BMI in Asians, and it shows clearly a benefit with GLP-1. So there's no doubt with these studies that with or without obesity, the favors GLP-1, as you can see here as well with 5 and 15 trials, shows the favors of GLP-1. So doctor, you are saying this molecule is efficacious with all this data with Asians and non-Asians you have shown me, but what is the side effects of this molecule? Most of the patients say vomiting and nausea, but what is the side effect? You're right. I think most of the things what you see is given as a molecular chart is the same in the practical usage, and that has been the same in real world data, for the randomized controlled trials. So dulaglutide, semaglutide, all the GLP-1s, nausea, vomiting, and diarrhea with GLP-1s are the common side effects. So now coming to specific molecule, we are going to talk about dulaglutide. So I've just given you a brief picture how to approach multifactorially. And then the second aspect of my talk is about the GLP-1, how good is this molecule and what are the studies that has been done so far. And now I'm going to focus on a molecule called dulaglutide, which is a weekly once molecule, offers a A1C reduction following mechanism of the patients with type 2. So it is only when the food goes in, the insulin release will be there. That is an insulin glucose dependent insulin release and hepatic output. So that is the one that decides pouring in of blood sugar overnight and in the daytime, the hepatic glucose output, and then the gastric emptying. That is an amazing way to work to slow down the absorption, thereby the blood sugar peak, like for an Asian, doesn't go up postprandially. So dulaglutide, in addition to A1C, it offers multiple other helps. Probably I will prove that with the data that is going to come in with the Rewind study. Very, very fascinating study. It shows the lower risk of cardiovascular events, which much of the data is not been there for the people who has got no established cardiovascular disease. That is the beauty about it. And patient may also experience of weight loss. It is not a primarily weight loss molecule. However, the additional benefit of weight loss is there, which will be of real use. So if you look at the dulaglutide clinical trial programs, it has been like what when liraglutide has been launched, it is like that. In fact, more than that, during the launch itself, now the data is available as a monotherapy, 2-drug therapy, 3-drug therapy, along with complex insulin regimes, even with basal bolus and stuff. So if you look at the award 3 program, award 5, award 6, award 5, 6, and 8 is the key thing for me, because these are the practical patients that would really benefit from GLP-1 if you start appropriately. It doesn't mean to say that a 3-drug combination or 4-drug combination doesn't work, but the 2-drug combination with liraglutide and along with dulaglutide along with metformin or any other drugs will be very, very useful. So more than 6,700 patients, so huge data is available with this molecule. So dulaglutide as a molecule showed A1C reduction more than 1.6 across the range of head-to-head clinical trials. So if you look at any molecule, the normal A1C reduction is 0.7 to 0.8, like that. But I think when you compare with the whole range of head-to-head clinical trial, there is around 1.6 of A1C reduction. So dulaglutide versus liraglutide, dulaglutide versus glargine, dulaglutide with biata, dulaglutide with gliptin, sitagliptin especially, and then metformin and glargine as the maximum studied molecule. So it is got significant A1C reduction with a subset of patients. So the treatment naive patient, for example, the A1C is more than 8.5. The benefit of A1C reduction is quite significant, almost like 2%. But if it is less than 8.5, less than 1.3%. So we know that how effective it is and how sustained it is. It's almost like a 2-year, even with the randomized control trial RCT for 2 years, dulaglutide showing the A1C reduction of 7. If you see the A1C was 8.2, it reduced to 6.8, and it's been maintained for 2 years with 7. And that is the personal experience as well. If you can be able to make the patient to take it. In India, the challenge is to make the patient to take it because they have to pay from their own pocket. But if you give a valid data, and if you see if they see the result themselves with the weight reduction and A1C reduction, they tend to continue it. So again, just to compare with the insulin glargine, if you look at for past 20 years or so, the best discovery in diabetes world will be insulin glargine, no doubt about it. So it is like a gold dust. And if you compare something of a molecule of dulaglutide with glargine, you can see the A1C reduction is 1.1%. Along with the insulin, the injection rate is very, very less compared to the insulin glargine. So, and then there will be a 2 years weight loss. The weight loss, what happens, is also sustained for 2 years. Yes, there is personal experience and clinical data to show when you do stop GLP-1s, the weight loss won't happen, and then there is chance of a patient getting back to the original weight. But however, I think whatever they learned, I personally say and convince to the patient that whatever you are on during the molecule, you should have the same habits when you are off the molecule. So coming back to Rewind study, which is the fascinating study I mentioned. Um, why? Because it is like a dichotomy of SGLT2, where we can see these patients who are in front of our chair when they come to clinic. So these are all almost like a patient without CVD as well, because if you look at a lot of clinical trials, it's been done with high risk. We were talking about Emparage earlier. It is almost 100% with a previous CVD. But here, Rewind has got 9,900. One of the biggest studies showed female inclusion is better, and also non-CVD previous. There is no further CVD before CVD patients are all included, and the results are fascinating. Almost 12% of risk reduction of primary MACE. Why I'm being fascinated about is the duration. The duration of trial is almost like 5.4 years, and there is a significant reduction in the 3-point MACE, despite the majority of patient not established CVD. So if you look at the analysis, there will be CVD, there will be a very good benefit. And if you look at the non-CVD, there is a benefit, so that there will be overall 12% reduction. Hope you understand. So because we are including a cohort of patients who are not having CVD, then the results may be skewing. But however, in spite of that, there is a benefit of 12% risk reduction, which is very, very fascinating. And that is the key highlights of the Rewind trial. So if you can remember the second slide of my talk, which is the majority of patients without established CVD is there in this trial. And there's almost 12% risk reduction of MACE3. And then the major CV events are reduced in patients with type 2 with or without CVD. That's the third point. And then the fourth point is, as I mentioned earlier, that the side effect that has been in the Rewind trial is almost consistent with other dulaglutide clinical trials. Why it is very important is dulaglutide offers a significant reduction in A1C with a simple approach they want, because there is a robust A1C reduction. The device, I don't know, you have seen that it is a fascinating design of the device, where you can't see even the needle, and simply delivered, and it's a sustainable effect of, as I showed you, even the data showed 2 years of reduction of A1C and also weight loss. So a simple approach to the first injection is administration. 99% of the patient found DC, and that is very important. You can have a data fascinating signs. Some of the GLP-1 molecules are really cumbersome in the way that there will be a albiglutide, for example. There is the powder that you have to mix it with water. So those kind of things are there with the GLP-1. So no reconstitution or primary injection is necessary, or automatic delivery, just a push button and uncap it and just do it. So simple administration may give you the patients a different experience. They found it very, very easy to use. So adherence is very good. So I showed you the data that efficacy is good, sustainability is good, safety is good, and practically the adherence is good. Coming to the discontinuation rate, it's quite less when it compares to liraglutide, which is a daily injection. And if you look at any talk won't conclude nowadays. Once the RCT is being shown, the next is the real world evidence has to be shown. And if you look at the real world data, it's a retrospective multi-centric trial with 2010 to almost 8 years of data. You can see there is dulaglutide is much more superior when compared to A1C reduction in the real world study. Again, just to confirmation with the weight reduction as well, almost similar, but dulaglutide got an edge, probably because of compliance. So this is Samit Ghoshal and guys from Calcutta, Binayak, and a whole lot. They, along with the most of the studies, it showed that the dulaglutide has got edge towards liraglutide. But however, the both molecules are good, that efficacy wise, and also the sustainability of the efficacy. These are the comparative features of GLP-1s, which is available in the world now currently. I don't want to into the details of everything, but the important thing is the weekly ones play a big role now, just maintaining the A1C reduction and also the class effect of GLP-1. So if you look at the GLP-1 as a class, what are the differences? It is mainly the onset of action, gastric emptying rate, potential of A1C reduction, and potential for kidney protection, and also data for non CVD patients, proven CVD patients. So you have to consider device dosing and patient factors when it comes to it. It is very important that we do that. And dulaglutide as a molecule, I've shown you with the green ticks box. It just covers the whole lot, and it's a amazing drug. So in this past 20 minutes or so, I've just spoke about how the old days where we managed diabetes with a glucocentric approach, and how we should be managing with a multifactorial approach nowadays with controlling the blood pressure, weight, and also lipids. And then I showed you the data for the multifactorial approach will benefit with the VADT and other trials. And then I showed you about the GLP-1 as a class and a molecule, how effective it is, and the mechanism and action of GLP-1. And after that, when it comes to the uniqueness, then I've showed you the data for Asians and non-Asians, the benefit in Asians with GLP-1, and as a dulaglutide as a molecule. I touch based upon the Rewind trial, which has got an amazing benefit of 12% MACE reduction. And the key factor is this includes the non-established CVD patient, which is the fascinating thing for me. And apart from that, I've always shown that dulaglutide not only reduce the A1C, but it's just the sustainability of A1C reduction along with the weight loss, and then the sustainability of the weight loss. And also, I've shown you the safety of the drug when it comes to even the real world data along with RCT. And the main thing is as a real world data where I compared with other molecule of liraglutide, and I've shown you the very important thing, which is the patient usage and the friendliness of the pen. So that's all I got to say. So the message is multifactorial approach is better. GLP-1s are the drug along with SGLT2 to be watched on, and dulaglutide is the molecule that has got almost the complete evidence. I'll stop there. Thank you.
Thank you, Dr. Suresh, for that excellent talk. I think the house is open for discussion. Or any questions?
There is one question actually from the previous session. Can
Yeah.
SGLT2 inhibitors be used in pre-diabetics? For many diabetics have target organ involvement at diagnosis.
Yeah. Well, I think can I answer? Sorry, does anybody unless other team members are there? No.
Yes, please. Yes, please.
See, I think SGLT2 acting on primary prevention. It's not the primary. The question is pre-diabetic.
Pre-diabetic.
And the answer and the evidence is probably not. We don't have much of evidence actually. However, I think these molecules. I've been in the field almost like more than almost 23 years now. So what I'm seeing with the SGLT2, the amount of noise is made with SGLT2, I have not seen with any molecule in my career. So with these molecules, I got no doubt people will have evidence coming in with pre-diabetics as well. So you have to just wait and watch.
Okay, I don't think there are any more questions there. Thank you so much, Dr. Suresh. Thank you, Tirthankar.
Thank you so much, Dr. Manoj.
Thank you.
All the best for the conference.
Thank you. Thank you. So I think it's time to move on to the next talk. Oh, 1 second. I have to just take stage. Yeah, I think we will move on to the next topic now. The topic is distinct advantages of second generation basal insulin and its usage in elderly and CKD. Chairperson is Dr. Nagaraj. Hello, Nagaraj. Nice to see you. It's been some time since we caught up live, at least digitally. I think you need to unmute yourself, Dr. Nagaraj. Can I get his introductory slides?
Yeah.
He's consultant physician and diabetologist at InfiLife Healthcare. Good friend of ours. Has multidisciplinary talent and approach in, I think he had some stint in the aeronautical side also. Thanks for joining us.
Thank you. You can hear me?
And the speaker is Dr. Hem Kumar, a good friend, Team Disha member.
Yeah.
Good morning. Good morning.
Nagaraj, just introduce. Nagaraj, can you introduce him? And
Yeah. I'll introduce him. Good morning.
Good morning.
He has got an MBBS from VMKV Medical College, Salem. He has got his MD from Manipal. He has got the distinct MRCP from Royal College of Physicians, London. Currently working as a consultant physician and diabetologist, Jivika Hospital and Sakra Hospital, Bangalore. He's a visiting consultant at Cloud9 and Birthright Rainbow Hospital. He's a district coordinator for Type 1 diabetes as RSSDA, a member of Disha. I think he has got a long list of things which will be discussed in the further. So I think you can take over the platform and go ahead with your presentation.
Yeah, thank you. Good morning. Good morning, everybody, and thanks for joining on a Sunday morning for this exciting Disha event. We are going to see the very short presentation and talk on basal insulin, second generation basal insulin. This is a season of repurposing. COVID-19 has led to repurposing of so many things, favipiravir and remdesivir and tocilizumab and all those things, which Dr. Manohar will take it over in the afternoon. We had different basal insulins available over a period of years, decades. So we have come across a few basal insulins. The NPH was the baseline, and followed by detimir, glargine, and degludec. So here we will have a small case-based discussion on whether the newly available, the recently available in the past few years, the glargine 300, whether it is usable, whether it has a use case in a specific population, specific target population. So the topic is next generation basal insulin, hypoglycemia, glycemic variability, and elderly CKD. So I'll take you quickly through the slide set. I think most of us are using these molecules, and most of us are very well versed in how these molecules work. So a case we had an elderly senior diabetic with a high glycemic variability. He's on first generation basal insulin with and oral hypoglycemic drugs. He has minor hypoglycemic episodes. When we say minor hypoglycemic episodes, they have symptoms, but there is no neuroglycopenia. There is no syncope or seizure or other serious effects of hypoglycemia. They just have the experience the hypoglycemia, and he is having stage 2 CKD. He is managed at home. He is a businessman and he is diabetic for 20 years. He's on first generation basal insulin since 5 years. When we say first generation, it's NPH. He is diagnosed with CKD and hypertension. A few minor hypoglycemic episodes were there. So whether there is a possibility
Dr.
of
Hem, we are not able to see your slides.
We're not able to see your slides.
Please share your screen. Yeah.
Share your screen.
One moment. Yeah, sorry. It's already shared. Can you see it now?
Yeah, you can see it.
So
yes,
he's on first generation basal insulin and stage 2 CKD with a hypertension. Whether the risk of hypoglycemia, whether it can be mitigated, that's the question. So what we can do for him. So his BMI is 24, acceptable BMI, and his BP is well controlled. Systemic examination is with normal limits. The FBG, PPG is good for most of our OPD patients. The A1C is 7.6%, which is almost up to the target of 7 to 7.5, and EGFR is 64, and total cholesterol is 180. So he's currently on currently on biosimilar glargine, 18 units once daily at morning, metformin extended release OD. He's stage 2 CKD, but continued on metformin. So we usually don't reduce the metformin dosage if the patients are stable and the risk of metabolic acidosis is minimal in stage 2 CKD if the patient doesn't have any acute illnesses. So he's also on sitagliptin 100 milligram OD and ramipril 5 milligram with atorvastatin. So first thing is whether since he is 65 years, a senior citizen, whether a relaxed target of 7.5 to 8 is acceptable. So the ADA has recommended a relaxed target for senior citizens if there are multiple comorbidities and the risk of hypoglycemia is high. So we can have a relaxed target of 8 to 8.5, lesser than 8 to 8.5. If there is a single comorbidity apart from diabetes and there is no risk of hypoglycemia, we can have a target of less than 7.5. But we should also consider the acute hyperglycemic risk we can have in such patients. So we have to just balance both the ends, and should take a middle path to achieve a good glycemic target without having much hypoglycemic episodes. So we'll go through the clinical evidence how newer basal insulin analogs can offer better control with lesser hypoglycemic episodes. So these are the first generation, second generation, third generation basal insulins. The NPH was used for a very long time. As long as we remember, we had the NPH insulin, and followed by introduction of Detimer, and in 1996, and Glargine was introduced. Glargine has been around since 1992, but commercially available since mid 2000s in our country, followed by Degludec in 2010, and the Glargine has been repurposed with a concentrated formulation of 300 international units per ml in 2011, and it has been available in our market for past 5 to 6 years freely. So longer acting basal insulins in this non-peaking, we call it as non-peaking insulin. The non-peaking insulins are Detimer, Degludec, Glargine, and the Glargine 300. In this, if you see that Degludec and the 300 has a really non-peaking action, whereas the Detimer slightly goes towards the NPH, when the Glargine 100 goes more towards the 300 and Degludec. So what is the advantage of Glargine 300? It is nothing but the same Glargine what we are getting. It has been made into much more concentrated form. So we can have a huge, with a smaller volume of injection, a large concentration of molecule is deposited in the subcutaneous plane. And this leads to a release of the insulin in a very slow and a steady format. So this has been observed in the various studies, which we'll be seeing later. So what is the advantage of using 300 above the 100? So there is less glycemic variability, the flexible time of dosing with Glargine 300. It's a CGM data we can see with the morning injection of Glargine 300 and 100. That is, there is a variation of only 14 milligrams with the Glargine 300 and about 28 milligrams with Glargine 100. And also there is a, if we change the timing, so usually we give the Glargine 100 in the evenings, sometimes most of us in the morning if there is a hypoglycemic risk. So the changing of Glargine 300 from morning or evening, either time, so it has not shown any difference in the glycemic variability. So this gives some flexibility when we can give these injections to the patient. And also there is a 3 hours window we get with Glargine 300, where the 3 hours variation, say around 9 o'clock, if a patient has been prescribed at 7 p.m., so they can take in between 4 p.m. to 10 p.m. It should not be made as a habitual thing, but when they change it due to unavoidable circumstances, the glycemic variability is not too high. So efficacy, safety, and effectiveness in older adults with type 2 DM. So there is a senior RCT, randomized control trial, where glargine 300 was effective in older people. The efficacy has been proven. There has been lower rates of symptomatic hypoglycemia and compared with the glargine 100, particularly in patients above 75 years. It has been noted specifically. If you see, there are two forest plots here. So in patients above 65 years of age, the forest plots shows the glargine 300 much more towards the unity compared to the subgroup with more than 75 years. In that, if you see, there is a significant reduction in hypoglycemia and a significant data to favor glargine 300. So lower risk of nocturnal hypoglycemia, again, multiple forest plots. All these things are compared to glargine 300 compared to glargine 100. There has been significant data which supports glargine 300 to be better when compared to the glargine 100. So more patients achieved A1C target without nocturnal hypoglycemia. We are very, it's a very obvious fact when we don't have a dawn phenomena, when there is less hypoglycemias, the patient's adherence to the medications is more, and the patients continue the medication for a longer duration, good follow-ups, and which extrapolates into a good outcome of decreased HbA1c. So obviously, any medication which is efficacious with a lesser hypoglycemic events is going to give us much better target achievements of HbA1c. So similar glycemic control with less hypoglycemia after switching glargine 300 from other basal insulin. This is a real life older type 2 diabetes patients in real life data it is. So there has been a significant reduction of HbA1c without hypoglycemia. So the left one shows the HbA1c reduction when the patient has been shifted from the older basal insulins to the glargine 300, and the right, the graph on the right, the bar chart on the right shows us there is a reduced hypoglycemic events in the patients on glargine 300. So in patients with renal impairment, we have seen in the elderly, it is efficacious and the hypoglycemic episodes becomes minimal. And what happens in a renal impairment, the patient, the case winner, he has a stage 2 CKD patient. So what happens in a patient with CKD, renal impairment? So the renal function subgroup in this RCT, the renal function subgroup, it has been classified less than GFR less than 60, more than 60. The relative risk is favoring glargine 300. So again, the glargine 300 scores over the glargine 100. So mind it, it is the most of the comparisons are between the existing glargine 100 molecule and the glargine 300 molecule. So switching to glargine 300 from first generation basal shows comparable A1C reduction with significant lower risk of hypoglycemia. Again, what we have seen in the elderly population, the similar effects has been seen in the population with renal dysfunction too. So, do you agree with switching this patient to second generation basal insulin in the view of current situation to minimize risk of hypoglycemia? Are there more similarities or more differences between second generation basal insulins? So we'll explore the clinical evidence which can answer these two questions. So again, we have seen the same graph before. The glycemic variability is minimal. We have seen the difference between the extremes of this thing is 14 milligrams with the glargine 300 and 28 milligrams with the glargine 400. That is significantly lower glycemic variability, 20% lower glycemic variability with the glargine 300. So comparable A1C reduction with the glargine 300 with the IDEG, it is the same IDEG and efficacy. As we see, the IDEG is the longest acting insulin as of now we are having. So the glargine 100, the duration of action is lesser than 24 hours. So there was a concern the IDEG 100 might be more effective than glargine 100. So the glargine 300 bridges that gap between the glargine 100 and the IDEG, which can give a better, which gives a very good HbA1c control. So better safety profile with the glargine 300 when compared to IDEG 100 in this BRIGHT trial. So almost it is similar. The forest plot is slightly favors glargine 300. As the previous speaker has told, glargine is the gold standard for the basal insulin, and in this the glargine 300 scores much above the glargine 100, and in this comparison it scores slightly better than the IDEC-2. So there is a greater reduction in HbA1c, though there is a very small, the differentiation is very small. From the baseline of 8.7, the HbA1c has reduced to 7% at week 24, and in glargine it has reduced from 8.8 to 7.1. The excursion is 1.7 in both. If you see in the patients with EGFR less than 60, the rightmost plot, if you see the glargine 100 scores much better than the IDEC. So that's where this patient fits in, and glargine scores better than the IDEC here. So significant better safety profile with the glargine 300 when compared to IDEC in patients with hypoalbuminemia. Again, hypoalbuminemia is a concern with the patients with huge albuminuria, and low albumin levels have a strong positive correlation with the diabetes or high HbA1c. The low albumin itself may correlate into high HbA1c due to the errors in measurement of the HbA1c, and it is compounded by choosing a earlier generation basal insulin where hypoglycemia risk is also very high. So the greater reduction in HbA1c, again, we have seen in elderly, and also the earlier slide was with the renal dysfunction, and here in the elderly, when we compare this to the IDEC, there is a better HbA1c reduction with glargine 300. So time below range. So we have come into the concept, the newer glycemic indices, HbA1c, and followed by now newer terminology which we are seeing in past few years is time in range. So how much time with the CGM we can get this data very easily, how much time the patient remains in the range, and how much time when there is a risk of hypoglycemia in patients like elderly and people with renal dysfunction, how much time the patient is having time below range. So reducing the time below range or time above range and increasing the time in range is the target of any new anti-diabetic drug, which is going to be a challenge for any new anti-diabetic drug, unless the drug proves itself to keep the patient in time in range without having excursions. So we are not going to go to the new drugs that easily. So if we see that the comparable time in range for glargine 300 with degludec, and time below range is markedly lower for glargine 300. There was a forest plot there is another graph which I showed the HbA1c reduction was 1.7 with lesser hypoglycemic episodes. So significantly lower nocturnal hypoglycemia with the glargine 300 compared to the IDEC. So the percentage time of nocturnal hypoglycemia has been significantly lower than the IDEC in glargine 300. So effectiveness and safety of glargine 300 evaluated with the continuous glucose monitoring profile is shown in one care study which was done in Spain, which has shown it to benefit, which to favor glargine 300. In the study design, there was a patient who are on first generation basal insulin. They were switched to the newer basal insulin, and the treatment period was the follow-up was done at third month, and after 1 month of switching between the glargine 300 and IDEC, again there was a follow-up and followed by a CGM of 14 days. So in this, if we see adult type 1 diabetes switch from first generation basal insulin analog to glargine 300 or degludec within 24 months, this data has shown the secondary endpoints of time above range and time below range, which has been much lesser with the glargine 300, and the time in range has been similar to the degludec. So these differences and lack of nocturnal hypoglycemia favors glargine 300 for both keeping the time in range and reducing the time above range periods. So coming back to this gentleman, he was switched from the biosimilar glargine 100 at the dose of 18 units, the same from the previous. He was on 18 units glargine 100 biosimilar, and he has been switched to glargine 300. So he was advised to titrate his insulin based on his SMBG. So he was advised to titrate it upwards of 2 units weekly if there is without any experiencing hypoglycemia. So after 3 months, so he has uptitrated around from 18 units, he has uptitrated to 21 units. along with the similar same OADs. He was on metformin. We have seen he was on sitagliptin too. So his HbA1c has come down from 7.6 to 7.2. With a dream fasting and PPG, it can only happen in the presentations. No episode of hypoglycemia was reported. He was better quality of life with the lack of hypoglycemia, and he's happy with the medication. So when we are using Glargine 300, what is a practical consideration? So we can initiate, if the patient just presents to us, we can start at 0.2 units. The upward titration can go up to 0.5 units if we do that. Sometimes we can have our own, most of us have our own guidelines. So we start around 10 to 15 units and titrate it 2 to 3 units with every visit and without any hypoglycemia. So it can be safely titrated once in 3 days or a weekly titration schedules. So what is a unique advantage? The duration is more than 24 hours, somewhat similar to the degludec with less variability in glycemic variability and slightly increased flexibility of giving the injection before or after 3 hours of the actual prescribed time, lesser hypoglycemic events and safer titration schedule. So key takeaways, Glargine 300 gives a good alternative to Glargine 100, somewhere in between the Glargine 100 and degludec, a good, safe and effective method of reducing the HbA1c, bringing it to the target without experiencing much hypoglycemic episodes, particularly in elderly and patients with renal dysfunction. Thank you. So it was a very, I know it was a very bland talk. So it's a single molecule. We are comparing with two other molecules which we have, which we had it in our armamentarium in the past. So thank you. Thanks for the opportunity.
It was definitely not a bland talk. It was just a specialized subspecialty talk in the drug generation. Don't worry. Just right one. It's open now. We are open for any question. Take some 2 minutes if there's any question for him.
Haim has done a lot of work in COVID area. Have you used U300 and do you have any opinions on that?
Extensively, I think we will have a discussion about that also in the afternoon. Yes, U300 was very helpful in this COVID patients, because we need to give very huge quantities of insulin to these patients. They were requiring anywhere above 150, 200 units per day. So giving a regular U100 insulin required a huge volume of injections. So it was better. We used U300. I have used quite a number of patients U300 who were not controlled.
Okay. Thank you. If there are no other questions, can we move on to the next topic?
Thank you, Manohar.
In the U100 or with the.
Okay. Thank you, Dr. Nagaraj. Thank you, Haim.
Thank you for the opportunity.
Yes, it's always our pleasure. And the next topic is early treatment intensification and beta cell preservation. To chair this, I have my friend from Manipal Hospital, Dr. Aditya Hegde. He's again another coronacrinologist, a lot of work in the COVID zone in Manipal Hospital. He's a consultant endocrinologist there, and he has received award of President NBE Gold Medal in the specialty of endocrinology for DNB final examination. That's a great achievement. He's still on duty there. Okay. His areas of interest is pediatric endocrinology, adrenal disorders, and newer development in diabetes. And he keeps helping me out with a lot of doubts whenever I reach to him, because he's so friendly to me there. Thank you. Welcome to Disha Year-End Summit, Aditya.
Thank you, Manohar sir. It's been an honor to be a part of this. I think this is my third year in a row. So it's been a great honor. And the new endocrinology, I think it's going to be in vogue for some time now. So thanks a lot, sir. So shall we start the session, sir?
Yeah, Dr. Shruti Chandrasekharan is our speaker.
Welcome, ma'am.
Thank you.
I'm extremely happy to welcome our honorable guest, Dr. Shruti Chandrasekharan, She's a American board certified endocrinologist and diabetologist, and presently she's working at Relas Hospital, Krompet, IIT Hospital, IIT Madras, and Srivika Center, Velacheri. And she's a member of Endocrine Society of Tamil Nadu and Puducherry, ESI India, Indo Society USA, and American College of Physicians. And we have a great achievement in the form of she was the best outgoing student of Kilpatrick Medical College and Best Endocrine Fellow Award at University of Maryland, Baltimore. We welcome you, ma'am, and we look forward to your deliberation.
Thank you so much for the introduction. Let me share my slides. Thanks for the opportunity to be here this morning. So we're going to switch gears. We had two excellent talk on GLP-1 and basal insulin, the second generation basal insulin. So what I'm going to be doing for the next 20 minutes or so is to talk on the early intensification in the management of type 2 diabetes, where we're going to be focusing on an oral drug. And a very important question, like any other online CME. Can you see my slides?
Yes, ma'am.
Okay, great.
Can
Thank
you
you
just
very
move
much.
them? Will be
Yeah. Okay.
It's moving. Thanks.
Yeah, we're going to talk on the early treatment intensification and beta cell function. And the topic for discussion today is going to be on the verified trial, which was done with vildagliptin. So my focus for discussion today will be on vildagliptin as a molecule. This is my disclosures for the talk for this morning. The outline of my talk is going to be, we're going to talk on the guideline shift and what happened from 2018 to 2020 and moving forward to 2021. What is the importance of early treatment intensification? I'll overview the verified trial. We'll talk on the beta cell functions. We'll also talk on the effect of OAD, specifically the incretin mimetics DPP4 inhibitors in Asian population. And I'll also conclude my session briefly with a verified Indian data. So moving forward, is there a standard, have we moved in the guideline as far as the guidelines are concerned? Is there a shift in the conventional management to early intensification? So before we move there, we'll start with the patient scenario. So as a 38-year-old, married, she has 2 children, no diabetes, no PCOS, has been having a regular cycle, strong family history of diabetes, but no vascular disease in the family. She's a non-smoker. She comes with a new onset type 2 diabetes routinely in her masteral checkup, right? So you see her sugars are there and A1C is about 7.8 and all the other parameters for the discussion today are normal. So we will see how this verified trial fits into our clinical practice. So whenever we read a trial, it could be a CVOT trial or a CKD trial or a heart failure trial, the important question or the important point that we need to take home is how we can apply this to our clinical practice. And that is exactly what Verified try to answer with the early combination treatment, which I'm going to be talking on for the next 15 minutes or so. So is that a guideline shift? Yes, there is. In 2018, the ADA ESD consensus guideline said there were little evidence for initial combination therapy. You fast forwarded to ADA 2020 and also the 2021 guidelines. They say the early combination therapy can be considered in some patients in treatment initiation to extend the time for treatment failure. And this primarily came from the verified trial where they used the combination therapy for patients who were newly diagnosed diabetes or naive patients with a combination of DPP4 and metformin, here specifically vildagliptin and metformin. So what is the importance of early treatment intensification? This we all know, this we have all heard in very many platforms, very many discussions. We know the early intensive control is important because we know type 2 diabetes is a progressive decline in beta cell function. And whatever we do in the first few years have this sort of legacy effect in the future. And any intervention that would preserve the beta cell function would also have a better durability. So when I start a drug to a patient, the question that I have is what will be the efficacy and what will be the durability of the molecule? How long can this drug keep the HbA1c under control and make sure that the patient do not develop complications in the future? That as a clinician is very important to me. The greatest clinical benefit is observed when the interventions are delivered early. I'm sure we all know that. We all do that for our patients and our family members as well. So this is from the UK PDS, which showed there is a decline in the type beta cell function at the presentation, even before the onset of diabetes. And it's a very gradual decline in the beta cell function, and that decides the clinical course of type 2 diabetic patient. And what we have been doing is the standard stepwise pattern where we start with the diet monotherapy and then up titrate it and had a combination therapy. What perhaps as clinician we should do is, if you look at the orange line there, if your patient presents to you with the new onset diabetes at the beginning. Sorry, can I ask the others to unmute, please? Sorry, can I ask the others to unmute? Yeah, thank you very much. Thank you. So what we should be doing as clinician is looking at the orange line here, where we need to actually start them and have more aggressive approach at the beginning so that we can actually flatten the line and keep the HbA1cs under control, right? Rather than this stepwise or the seesaw pattern where the avoidable glycemia can be prevented. Right? This is the UKPDS again, which showed that the first few years where you control, here again, they did it with metformin, sulfonylurea, and insulin. That is what was there at that point of time. Even with those classes of drug, they showed that if you could control the sugars effectively in the first few years of the diagnosis, you will reap the benefit later. You know, once the trial closed out, they saw the benefits. Even now you have the edict data coming out from the UKPDS, where it showed a reduction in the microvascular complication, all-cause mortality, and also the reduction in MI. And that shows the importance of getting your sugars under control in the first few months of your diagnosis. And I'm not going to walk you through this busy slide here, right? So this is just to show you the evolution of the guidelines, right? So from 2009 to 2020, right? So various drugs have been added and various drugs have taken the first place now with its heart failure, CKD, all the priorities put in forth, and also looking into the cost as a concern. But what is striking is, as of 2018, if you look at the last bar here, providers should engage in shared decision making. That's a very important thing. Shared decision making around initial combination therapy in new onset patients of type 2 diabetes. And we have evidence for this. And that is the reason why there is a change from the guidelines from 2018 to 2020. And this is primarily because of the verified trial. So I've told enough about the verified. So we'll move forward and see what exactly was verified trial. So verified trial was a vildagliptin efficacy in combination with metformin for early treatment of type 2 diabetes. So what will you combine? What will happen when you combine these two therapies together when you see a patient first in your clinic? And this is a very beautiful slide showing you where exactly Verify was placed. So if you look at the Verify, which is highlighted as yellow, it shows you patients who are drug naive, new onset diabetes, where you can actually catch them and treat them aggressively. And that is where the Verify trial was placed when compared to the other. This also includes the CVOT trial, which included patients at later stage of disease and population. So just to say that it addresses early diabetes, and the entire trial duration was for 5 years. And it's a multinational. What is commendable about this, I know this is a world map which you all can read. What is commendable is the verified trial included multi-countries, a lot of different ethnicity. It also included women. Probably the only trial that I've seen where the women outnumbered the men. They were about 54%. I'm not showing you the basal characteristic of these different groups, but women population was about 54% when compared to men. So the women slightly outnumbered the men. And there were people with different socioeconomic condition, different ethnicity, and different geographical location. And that was very special about the verified trial. And these are the total countries and the total number of participants who were enrolled in the trial. And this map, again, to highlight, I have two arrows there placed to show the percentage of East Asian and the Southeast Asian in the trial contributing anywhere between 8 to 9%. So we do have a significant representation from India where we could actually infer the data of what exactly happens when you combine these two modalities of treatment. So the Verify answered very simple question, right? To combine or to not to combine at the start of glucose lowering therapy. That was a very simple question that they asked. And the primary outcome was, do those patients with type 2 diabetes benefit from having a combined therapy at the beginning of the pharmacological treatment? Does it carry any benefits, right? And the secondary outcomes were, do these patients with type 2 diabetes benefit more from having a combined therapy at the beginning in terms of, they also looked into the heart outcomes and stuff. Even those were not powered, they had safety concerns. What happened when you combine two drugs, whether one was having more adverse effect to the other. And all these questions were included in the secondary outcome of the trial. So this is a trial design. So it's a randomized double-blind parallel control study, which had a 3-week run-in period where they optimized the metformin dose, and patients should tolerate a minimum metformin dose of 1000 milligrams to participate in the trial. After 3 weeks is when they were randomized either to a placebo group or they were randomized to add on to a DPP-4 inhibitor, here specifically vildagliptin. And the study was conducted for over 5 years, and treatment period during which patients were consecutively intensified if clinically indicated. And what did they assess? With the objective is to show the long-term clinical benefit for early treatment intensification with vildagliptin and metformin combination, and compared to the standard of care, which we all do as clinicians, as metformin monotherapy with lifestyle changes. And this is what the trial design looked like. I think this is very important for us to understand. So I'm just going to quickly walk you through this. Metformin for the first 3 weeks, as you see, equal representation of men and women, 2,000 people there finally randomized and took part in the study. And the period 1, they were either put on metformin on vildagliptin or metformin and placebo. And period 2, if failed metformin, they were put on vildagliptin. If they failed the combination of metformin and vildagliptin, by fail, I mean if their HbA1c increases more than 7%. So they kept 7% as target. If your HbA1c went more than 7% in 2 consecutive visits, it was called as a treatment failure, even though failure is a very sort of a very harsh word to use. You just needed to intensify the treatment, and patients were put on basal insulin. So no other oral therapy were included. And if anybody were requiring any other oral therapy apart from DPP-4 and metformin, they were excluded from the study, right? So period 2 and then period 3 was with basal insulin. And overall, these patients were followed up to a tune of about 5 years. And I'm not going to walk you through all the data. I'll tell you what is more important for our clinical translation. And this is exactly what the trial showed. If patients were on initial monotherapy, say you put them on metformin, they come back after 3 months, what they found in this trial was the initial monotherapy failure was about 36 months, right? And that is different for an Indian subgroup, which I'll be talking to you in the next few slides. The time for a primary failure to intensify to an add-on to a vildagliptin was 36 months in patients were on monotherapy. And if somebody was on a combination therapy to begin with, you catch them like how you do in hypertensive, right? So in hypertension, you start with them and bang, you just put them on combination treatment, not just start with monotherapy and intensify, right? Similarly, you do it for diabetes also. And that's why the guidelines have changed. If you do that early combination therapy, you see that median time to the initial treatment failure was almost close to 5 years, right? So you can just start the drug and just be confident that this drug would keep the sugars under control for your patients. And that's important for combination therapy. So what did they conclude? Early combination therapy halved the time to initial treatment failure versus a monotherapy strategy. And the median time to failure, the primary failure was 3 years in monotherapy when compared to 5 years in early combination therapy. And for secondary failure, when you added to have insulin, again, was much more in patients who were on monotherapy vildagliptin requiring basal insulin. Again, both the approaches were safe and well tolerated. Just because you're adding one extra drug to the patient, you're not causing any harm in terms of pancreatitis. All the committee, they had different adjudication committee for cardiovascular risk, malignancy, looking into the pancreas. And both these approaches were safe and was well tolerated by patients. And there were no safety concerns that came out of the trial. So they concluded saying that the strategy of an early treatment approach with vildagliptin plus metformin in patients who are newly diagnosed type 2 diabetes significantly and consistently improves the long-term glycemic durability compared with metformin monotherapy. And that is what exactly we need to do in our clinical practice as well. And we will talk briefly about the beta cell function. These are all subgroup analysis from the verified trial. Here they looked into, again, the 2,000 patients who were enrolled. They did a beta cell function by looking into the HOMA-B. And what they found was patients who were on the combination of DPP-4 and metformin had a better functioning. So basically they concluded it also preserves the beta cell function if you put them on early combination therapy. So how does it change to how do you translate this to your clinical practice? Perhaps the durability of the molecule. So that also was explained because it was almost close to 5 years. The durability of the molecule would be better if you could start them with combination therapy as far as the beta cell functions were concerned. So the change in HOMA-B values was consistent with the greater reduction in HbA1c, which was shown in the combination group compared to patients who were on monotherapy group, and also the durability of the drug. So the concluded from this small subgroup analysis looking into the beta cell was the early combination treatment with vildagliptin and metformin in patients with newly diagnosed type 2 diabetes showed improvement in beta cell function compared with metformin monotherapy. And this is consistent with improvement in glycemic control and the durability, a durable HbA1c response that was observed in the verified trial. And that's how you would actually, if you want to understand the science behind the durability. So we will talk about the briefly about the OADs in Asian population, and I'll also conclude by verify Indian data. So we all know this, we have all seen this, we have talked in very many meetings, including the SGLT2 inhibitors, GLP-1, and DPP-4. Asian Indian phenotype is different. We behave differently. We progress from pre-diabetes to diabetes. We have early loss of beta cell function, and all the other conditions that has been put in this cartoon here. And that is the reason why we really need to get an optimal glycemic control, especially in our Asian Indian phenotype population. And do you have any data for that as far as the incretin-based therapies are concerned? Yes, there are studies published in other Asian countries, Japan, and there are also studies published by our own Dr. Mohan from Chennai. He looked into the effect of DPP-4 inhibitor in Asian population, and they said there's a better glucose lowering effect of a DPP-4 inhibitors has been observed in Asians when compared to non-Asians, right? And there was also a very recent meta-analysis that came out in 2020. They did the question was, should we have an ethnicity-based treatment, like how you have CKD, heart failure, ASCVD in your guidelines? Should we also include ethnicity, because different ethnic groups differ with the oral hypoglycemic agents, isn't it? So the beta cell deficiency has been reported as a feature of Asian diabetes. Would a drug that could be specific for ethnicity be used early so that you would preserve the beta cell function? And that's where this meta-analysis concluded, not just DPP-4 inhibitor, even SGLT2 inhibitors were greater response in predominantly Asian ethnicity when compared to the Caucasians. And they did not find any difference in GLP-1 receptor agonist. And if you look through this, with this background, you have this OAD as far as incretins doing well in Asian population and the Asian phenotype is different. Would we do anything different for our Indian Asian patients sitting in front of us, or our family members who have type 2 diabetes at a much earlier age? How would you treat that? So what are the verified trials showed? If you look at the Indian patients out of the entire Asian representation, which I showed in the map at the beginning of my talk, you see about 163 participants were there across 13 cities, and about 47% of the Asian population came from India. So I think it's a very good representation for a RCT. And this was a baseline characteristics from India. You see, again, men and women, the mean age and the mean HbA1c, which was very similar to early combination group or the initial monotherapy group. And what they found in the Indian population, I think this is a very important take-home message, and probably the most important thing that we've also observed in our clinical practice. 50% of the patients were on monotherapy with metformin. So all of us had this, we usually do this lifestyle and metformin, failed within 1.5 years. If you remember the global data that I showed you, it was about 36 months. It was about 3 years, right? So Indian population failed the metformin monotherapy alone within 1.5 years. But if you start them bang with a combination therapy of DPP-4 and metformin, the median time to treatment failure is almost about 4.75 years, almost 5 years, right? So this is very important, and perhaps the most important take-home message from the entire presentation today, as far as the Asian, and which would probably apply to our practice. So when started on metformin monotherapy, Indian patients tend to fail earlier when compared to the global verified population of 3 years. And again, the treatment for secondary intensification, where you add them for another agent, especially here in insulin, is again much less if you put them on early combination therapy with DPP-4 and metformin versus the initial monotherapy. And you can see that the relative time for secondary treatment failure is almost 58% with an hazard ratio of 0.42. And what this bar diagram here shows is one on the light blue is the initial monotherapy, and the combination therapy is the dark blue. So what did they do was they followed up all these patients when they came for subsequent the study duration trial clinic visit, and they found that patients who were on early combination therapy, obviously you're giving them an extra drug, remain in a target HbA1c majority of the time, right? So greater proportion of your patients in the early combination treatment approach versus monotherapy consistently had an HbA1c levels of less than 7%, seen over the time throughout the study duration. So how do you conclude, or what do you take home from the Indian data of the Verify? The early combination treatment halved the risk of time for initial treatment failure. When all the patients were receiving combination therapy, the risk of secondary treatment failure is reduced by about 58%. That's pretty good. That's half of my population, right? So median time to initial treatment failure was 1.5 years in initial monotherapy strategy, compared for almost 5 years in early combination therapy. Both treatment approaches were well tolerated. Again, like the global data, no hypoglycemia or no other side effects were reported from either group in the Asian population. So the question that comes from any trial, as I began my talk, is how does this change my clinical practice? So what do you take home from any trial? It could be GLP, it could be SGLT2, heart failure trial, or any CKD trial. So how does it affect my practice, right? So here, especially with Verify, I think it has strongly changed how I approach early or drug naive patients or new onset type 2 diabetes patients in my clinic, because now I've more confidently started to use an early combination therapy to have a better durability. And most of my patients remain control when they come for a follow-up, and that's quite encouraging for me, right? And that is possible with patient engagement, education, and reassurance. So rather than the first box here, historical standard of care, I think we need to move to a new era where we really need to have early combination therapy coupled with effective support to improve our patient outcome. And this is exactly how Verified changed my practice and also the guidelines. So the 6 takeaway points, I thought this was very interesting, whether you use any treatment modality in your practice, is again, strive for early diagnosis, screen your patients more effectively. Again, engage with your patients and tell them why it's important to get your sugars under control. It could be even us, a lot of us are also getting to be diabetic. So how we would treat ourselves is how we would treat our patients, isn't it? So initiate timely combination therapy to maximize patient outcomes. Monitor your patient adherence to treatment regimen on an ongoing basis. Again, we do this, we regularly measure HbA1c, and we coordinate effectively the members of the multidisciplinary team. Again, explain to your patients about the early interventions to improve the long-term outcomes. Tell them that what you do now will have benefits in the future. So my take-home messages and some points to ponder are these. So with this, I'll be finishing my talk for today. Will I be able to control my diabetes should change to how quickly can I get this under control, right? And this applies to everyone. And if you look at the paradox, it's easy to do the stepwise pattern. This is easy to do than the stepwise pattern, rather than asking your patients coming every 3 months, where a lot of your patients would show up exactly at 3 months. Putting them on an early combination therapy, it's much easier, isn't it? Rather than just titrating it every visit. And the majority of the time, we don't do this. There is a complacency for both from our patients and physicians, because patients do not have any symptoms at the stage of early onset diabetes or even pre-diabetes. They don't really know whether they've been a diabetic. So that's where the problem comes, and that leads to a complacency from both patients and physicians. And I would reiterate the point that it's easier to do a combination therapy than the stepwise pattern which we've been traditionally doing. And true drugs with a complementary mode of action here, like the DPP-4 and metformin, could achieve a good glycemic control. I've shown you some data for the prevent or slow beta cell failure, and that translates to a better durability of glycemic control, where your patients are also quite happy with your treatment. And the beta cell function, just to reiterate it again, early combination therapy with vildagliptin and metformin in patients with newly diagnosed type 2 diabetes showed improvement in beta cell function compared with metformin monotherapy. Therefore, the Verify showed a different trajectory to the current treatment paradigm, and it's safe and it works, no doubt. Again, a lot of us could harp on the cost of the treatment. The cost of vildagliptin has come down. I don't use generic vildagliptin in my practice. It has always been an inventor vildagliptin. Even with that, the cost has come down now. The initial cost of treatment, I know this comes up in every meeting, could reduce the cost associated with the disease complication in the long term. And if you think your patients are not affordable, and you have the guidelines supporting the other agents, where socioeconomic conditions or cost is a concern, you could perhaps use the other drugs for the patients could be affording the treatment, right? So this is very strong point again. The initial cost of treatment could reduce the cost associated with the disease complication in the long-term future. And this applies to majority of the anti-diabetic drugs that we are currently using in our practice. So with this, I finish, and I thank the team Disha and Novartis for giving me this opportunity. Thank you very much.
Thank you, ma'am. That was a wonderful talk. So, as you said, a few points have to be emphasized at every point. That is, the first visit, I think, is the best time to make a lasting impression on the patient. So, we have to drive in the point that the first few months after the diagnosis is the most critical period in this entire management of diabetes, because it is a very common scenario. Even us. If we are dealing with a diabetic, the first and most important question they'll ask is, should I start? Should I start? When should I start? I'll wait for 3 months. I'll wait for 6 months. I'll wait for 1 year. And as you told, 90% of them usually don't follow up or they get lost. So first time when they meet you, we have to drive the point that all the trials and all the evidence is showing that first few months is most critical after diagnosis. And even the guidelines and all the trials do suggest that combination therapy works much better than a step-on therapy. Compliance is better, the HbA1c reduction is better, you have a longer durability of the drugs which are going to have an effect. So that is very well taken, and I think the floor is open for any further points and discussion.
Thank you,
Dr.
Doctor.
Shruti, I
Yeah.
have one question, Dr. Sridhar here.
Yeah.
Thanks for the wonderful talk. So I just want to know if I have to start off with a basal bolus insulin combination or using SGL2 or DPP4 inhibitors combination with metformin for the preservation of the beta cells. Which one do you recommend?
So it depends on the patient sitting in front of you, sir. I don't think there is a right answer to this question. So if you have a patient who has a higher risk for cardiovascular disease or a heart failure or a CKD, no doubt SGLT2 inhibitor. So I know I'm talking here for Novartis, but that is the science, right? But if I have a patient who's sitting in front of me who I think has a repeated urinary tract infection, who will not be a candidate for good genital hygiene, where I'm very concerned about starting an SGLT2 inhibitor, then I will definitely go for a DPP4 inhibitors. But rather than questioning between DPP4 and SGLT2 and fighting between the two or which should be the agent, I would say if I have to have a good HbA1c reduction and get the patient to a target, I would use a combination of DPP4 and SGLT2 to begin with. Again, early combination therapy with SGLT2 and DPP4 is also a phenomenal treatment in your practice. So I don't think there's a right or wrong answer to that question. And I think it depends on patients and also how much they can afford for the treatment.
I think probably what sir also wanted to address was the initial concerns about the glucolipotoxicity and all. With early insulinization, you tend to preserve, or at least there is some talk about preservation of beta cell mass, reduction of progressive beta cell decline. So probably that was one thing you wanted to address. So I think we are almost well within the time. So it was a wonderful talk, and once again I thank Team Disha for giving me this opportunity. Thank you so much, ma'am, and look for more such meetings in future.
Thank you so much. Thank you. Thank you, Dr. Manohar. Thank you. Bye.
Thank you, Dr. Shruti and Dr. Aditya.
Thank you.
I think we'll move on to the next capsule in this thing. We called it as COVIDology to represent the pandemic. And the first session on this is, like, before that, we'll have a small video of what we are going to do to the evening, something differently for the public. So the chairperson for this first session is Dr. Pradeep, my good friend.
Thank you very much, Dr. Manohar.
Yeah, he's a very good friend of mine. He's a gold medalist from the Kuvempu University for Internal Medicine. He was awarded the best paper in Apricon 1999 and Capricorn 1999, and ex-faculty associate professor in medicine at Vaidehi Medical College. He's organizing committee member for RSSDI 2014, the national one, which was held in Bangalore, and also Apricon 2018. He has numerous publications to his fore, and he's the big man of Brookfield area, the Brookfield Hospital. He does a lot of other good works. And the topic is COVIDology, life after COVID, what to watch for. And the speaker, I'm glad to have Dr. Murli Mohan, and I think Pradeep would introduce Dr. Murli Mohan.
Thank you very much, Manohar. It's always been a pleasure being a part of Disha all these years, and it continues to be a pleasure. And you've been quite innovative in bringing out newer aspects to the Disha every time that we come out with. And Panchayat that we are having this time is another new feather in your cap. So without much ado, I would like to take this pleasure to invite Dr. Murli Mohan. This August audience does not require any kind of an introduction on who Dr. Murli Mohan is. He's a man who's inspired various postgraduate students. He's been a mentor to quite a few of them. He's been my personal guide in quite a few ways, more than one. And he has been one of those rare breed who's expert clinical physician, an expert clinical research person, and at the same time keeps evidence-based medicine at the forefront of anything and everything that he does. So I would welcome Dr. Murli Mohan to talk about this hot topic of life after COVID. And I was glad recipient of one of those methods of how we would probably have to deal with COVID. And since I went through this, those tips that he gave me were the ones that I passed on to all my patients. Thank you very much, Dr. Murli. And I hand over this dais to you to guide us more on life after COVID and the various nuances that we have to deal with in this horrible pandemic that all of us are going through. Over to you, Doctor.
Thank you, Dr. Pradeep, for that very kind introduction. We've been good friends for a long time. And of course, thanks Dr. Manohar and the Disha team for inviting me to share my experience with post-COVID and the little learning that I have in this area. I'll be taking a few seconds to share my screen. I hope this is working. Is my screen visible?
Yes, Doc.
It is. Okay. And could you just tell me if it's moving also? Is my next slide on?
Yes, Doc. Yes, Doc.
Yeah, thank you. So I bring you greetings from Narayan Hridayalaya. We've established a post-COVID clinic recently, recognizing that the problem doesn't stop with recovery from COVID, but carries on well beyond that. So, you know, this is a confusing topic. There's very little. It's completely new like the rest of COVID. So whenever I'm confused about a topic, I start with this very helpful poem from Rudyard Kipling. I keep 6 tonners serving men. They taught me all I knew. Their names are what and why and when and how and where and who. And I'm trying to answer these 6 questions. What is long COVID? When does it occur? Who is more likely to suffer from it? Why does it occur? How are the organs affected? And where is our role in managing it? So I'll be taking you through these questions, but not in any particular order. And I'll be moving back and forth and hopefully giving you some evidence throughout while I'm talking about it. So when we talk about long COVID, long haul COVID or post-COVID, what are we actually talking about? We're talking about a multi-system disease and remembering that it sometimes occurs after a relatively mild acute illness. So in fact, there's this very good point that, you know, is it really mild when it can cause a lot of distress in the long run? We use the term post-acute COVID-19 when symptoms extend beyond 3 weeks from the onset of the first symptom. When it goes beyond 12 weeks, then we use the term chronic COVID-19. Now, this is arbitrary, but I tend to respect this. It comes from Disha Greenhalgh, who all of you must be familiar with, an excellent book called How to Read a Paper. And if you're not familiar, I would recommend you go back and read it. She also makes the important point that a positive test for COVID-19 is not a prerequisite for diagnosis. I have to ask myself this question because we can get very similar symptoms similar to post-COVID-19 when you have post-chikungunya, for example, or indeed many of the other viral infections. However, it seems to be more severe and carry on longer in COVID-19 than with most of the others, except chikungunya, of course. But it's also important to remember that after about 12 weeks, very often the antibody test that we use is negative, as well as the other tests. Hence, this point that a positive test is not a prerequisite for diagnosis. We know that many of the symptoms in acute COVID-19 carry on into post-COVID follow-up, and prominent among them are fatigue and dyspnea. And we don't really know when the COVID shifts into post-COVID. Is it a continuation of the same disease? Is it a different pathology that overtakes the patient? Is it a common condition? Because it's really important when it's common or when it's severe. So these are some of the data that we have. This is from the Public Health Surveillance Report that about 10% of patients who tested positive remain unwell beyond 3 weeks, so taking them into the acute post-COVID, and a smaller proportion for months. This was a UK symptom-based study where patients themselves entered data on a smartphone app. So it may be an underestimate because a lot of patients may not have entered their data, would not have bothered to go on the phone. But we know it's at least 10%. A higher percentage was cited in many of the published observational studies, though this, of course, may suffer from the bias of being a hospital-based or a specialist clinic-based study, where obviously asymptomatic patients don't reach. But when patients were followed up in the Morbidity Mortality Weekly Report, only 65% of patients had returned to their previous level of health 2 to 3 weeks after a positive test. We are talking about a third of patients still being symptomatic after 2 to 3 weeks. The 50 most common long hauler symptoms reported, as you can see, included fatigue, muscle and body aches. And I didn't want to go through this except to show that there is a huge number. This was from about 1,600 responses. You'll notice that most of them had fatigue in the long haul. And we are talking about 3 months after the reported initial symptoms. And it goes on to feeling simple things like feeling irritable. In fact, you had a very confusing set of painful symptoms, which we all can recognize, but also other great variety, including simple things like difficulty concentrating, difficulty just shopping and moving around, headaches, muscle and body aches, inability to be active. So people just feel non-specifically unwell, and this goes on for a very, very long time. So as I mentioned earlier, 2% at least continue to be very ill. We're not talking about the mild symptoms that I just spoke about at 3 months after. So we don't really know what should be the cutoff. Should it be 3 weeks, 8 weeks, or 3 months? What actually happens? This is the personal experience of an infectious diseases consultant, researcher, and a member of the, in fact, a coordinating editor of the Cochrane Infectious Diseases Group. He himself suffered from COVID-19, Paul Garner, and this is taken from his blog, his own words. He says it's a roller coaster of ill health, extreme emotions, and utter exhaustion. This was 14 weeks after he recovered. I'm unable to be out of bed for more than 3 hours at a stretch. My arms and legs are permanently fizzing as if injected with Szechuan peppercorns. I have ringing in the ears, intermittent brain fog, palpitations, and dramatic mood swings. He ends with these words: a post-viral tsunami is hitting our health service right now. And that's not just the viral tsunami, but a post-viral tsunami. And he talks about the boom and bust. You think you're getting better, and then you fall back into mental and physical exhaustion. So this is 14 weeks later. And he also ends another blog with these sentences. The aim of this piece is to get this message out. For some people, the illness goes on for a few weeks. Symptoms come and go, are strange and frightening. The exhaustion is severe, real, and part of the illness. And we all need support and love from the community around us. And that includes the medical community, which is why I was very grateful when Dr. Manohar invited me to give this talk. That support needs to come from us. So again, to define what it is, it's a multi-system disease. sometimes occurring after a relatively mild illness. And there are two sets of features. One is an organ-specific sequelae, and the other are non-specific symptoms. And we recognize four main groups. There's a post-intensive care syndrome, which can occur in virtually everyone who's been through an ICU, especially with ARDS. And nothing needs to be specific to COVID-19. There's a post-viral fatigue syndrome that follows on many viral fevers, but seems to carry on longer and more severely with COVID-19. But the two important things that seem to set COVID-19 apart are the vascular syndromes, which include acute coronary syndrome, cerebrovascular accidents, pulmonary and systemic thromboembolic disease, and pulmonary fibrosis. And the pulmonary fibrosis may be a sequel to the ARDS kind of picture or the post-COVID pneumonia kind of picture, but also seems to be related to vascular issues. Then there are symptoms which affect multiple organ systems: the GI tract, the lungs, the heart, the kidneys, the skin, and the brain. These wax and wane are unlikely to be vascular in origin and possibly represent an immune-based inflammatory syndrome. And this is Nisreen Alwan, who's an epidemiologist. She says death is not the only adverse outcome of COVID-19. And the degree of COVID-19 severity, she says quite miserably, because she was diagnosed as having mild COVID, it must be defined by the duration of ill health and not just the need for hospital admission, which unfortunately is how we define a SARI. It needs a hospital admission to become a SARI. Why does long COVID occur? So is it persistent viremia because we have a weak or an absent antibody response? Is it a relapse or a reinfection of the original COVID-19? As mentioned earlier, is it an inflammatory or other immune reaction? Is this due to deconditioning because of the long time it takes to recover during this very severe illness? Is it a PTSD, a post-traumatic stress disorder? And it may also occur because of the mechanical ventilation infections that occur secondarily, like in any other viral pneumonia. And of course, the treatment patterns that we employ. But two main factors seem to be involved. One is the widespread presence of the ACE2 enzyme, which is present across virtually every system because it importantly is in the endothelium, the vascular system, as well as in the pericytes of the vascular system. So it's the involvement of the vascular system as well as the widespread presence of ACE2 in other organs. So what really seems to happen, if you look at what SARS-CoV-2 does, it can be absorbed by the soluble ACE2 in the blood, but it also goes on to the angiotensin receptor system. It can attach to the ACE2, and what it does then is it affects ACE2 by limiting the production of angiotensin 2, the breakdown of angiotensin 2 to angiotensin 1 to 7. This is a breakdown product of angiotensin 2. And why is this important? This is because angiotensin 1 to 7 works on what is called the mass receptor system. This is still, by the way, totally hypothetical, but it seems to make a lot of sense. The mass system has various therapeutic effects. It reduces the blood pressure, it produces vasodilatation, it improves the cardiac output, it has an anti-fibrotic and an anti-proliferative response. So if it does not get stimulated, the MAS2, because the angiotensin 1 to 7 breakdown does not occur, or sorry, production does not occur, then you get the antithesis of all these. You get rises in blood pressure, vasoconstriction, which could cause some of the effects. It decreases the cardiac output, and we know that there are problems with myocarditis and decreased cardiac output. And it may be responsible for the fibrosis we see in the lung and other organs, as well as the proliferation of these tissues and these organs. Among the other things that we see are microvascular changes in COVID-19. There's inflammation of the endothelium, thrombosis within the microvasculature, and two kinds of angiogenesis, one of which is not unknown in other conditions, but one which is intussusceptive angiogenesis, where there is an ingrowth of septae within the capillaries. And this has been beautifully brought out in a very small autopsy series, which all of you must have read in the NEJM about 6 months ago. But one of the other learnings from me through the COVID crisis is that the immune and coagulation pathways are. And when you have this triad, you obviously get disturbances in all these symptoms. So what we see as coagulopathy in COVID-19 is probably multifactorial. Not going to take you through this, but just to show you that you have a hypercoagulable state, you have sepsis and disseminated coagulopathy, and you have a microangiopathy affecting virtually all systems. We also have the changes that we see in Virchow's triad, which is changes in the vessel wall, changes in blood, and changes in blood flow. And we are seeing a similar triad in COVID-19 with endothelialitis, changes in the vessel wall, changes in the blood itself with platelet activation, and something that's coming to the fore, neutrophil extracellular traps, and various changes in the coagulation factors themselves. And finally, because of the intussusceptive angiogenesis and changes in the endothelium causing dysfunction, you get altered blood flow, meeting all the factors for Virchow's triad. And this leads to a variety of complications. This was a nice paper from Siliguri, unfortunately in the Pakistan Medical Association Journal, but I think it's worth reading, though I think it deserved to be in a larger, better read journal. A variety of cardiorespiratory complications, glucometabolic complications, very central to this seminar, which is why I think Dr. Manohar chose it, and various neuropsychiatric complications, which my will be handling later. So I'll be concentrating mainly on the cardiorespiratory complications, which includes an increased risk of all kinds of cardiovascular diseases, as well as some pulmonary complications, which I shall attempt to show you. So this is one of our patients who has spent about 6 weeks, no, almost 8 weeks in various hospitals, about a month with us. And we've just got him off the ventilator in his ward. He's still extremely sick, and you can see why. He has a residual pneumothorax, he's got extensive fibrosis, and still has a lot of ground glassing within the airways. So it's not surprising that he's still very, very oxygen dependent on a tracheostomy tube, though he's off a ventilator. And these are some of the patterns that have been described in COVID-19. This is normal. And this is what usually happens, the pattern that we see, the VQ defects, which are segmental, that occur with regular pulmonary emboli or pulmonary thrombosis. But what we are seeing in COVID-19 is a small vessel angiopathy. I'm sorry, that got changed to antipathy by autocorrect, which I didn't notice. But here you're seeing peripheral, non-geometric VQ defects. So it's peripheral, it's subpleural, and seems to involve the small vessels and is related more to distance from the center in the periphery rather than a specific pulmonary embolic disease. So this is a microvascular disease. And they are using the term microclots, microvascular, COVID-19, lung vessel obstructive thromboinflammatory syndrome. And basically you get in situ small vessel pulmonary thrombosis, which can also lead to chronic thromboembolic pulmonary disease. And this can be grossly underestimated when you do a CT pulmonary angiogram. Within the heart, you have a variety of similar pathogenic mechanisms. And one of our patients, in fact, 2 of them currently seem to have an HLH kind of syndrome. But you also have, of course, stress cardiomyopathy, ACE2 dependent myocardial infarction, not infection, limited reserve, and various microvascular alterations, which lead to myocardial injury, which could be both vascular as well as myocarditis related, and myocardial edema. So you have ST segment elevation MIs, you have decompensated heart failure, person who goes into cardiogenic shock, and if heart transplant recipients get affected, they can get very, very severe disease. These are the neuropsychiatric complications that were described, and you can see there is a whole variety of neuropsychiatric complications which occur in the younger age group. But as patients grow older, you tend to get more and more of the cerebrovascular complications. So on the one hand, you have vascular complications. On the other hand, you have neuropsychiatric complications. And these include a variety of conditions. This was over a 3-week period, reported in the Lancet Psychiatry. 74% of the patients of these 153 reports had an ischemic stroke. There were intracerebral hemorrhages. There was one cerebral vasculitis, other kinds of cerebral vascular events, and we've had a couple of cortical venous thromboses, a frank encephalitis, unspecified encephalopathy, which seems to be fairly common, variety of neuropsychiatric disorders. I'm not going to go into it, but something that seems fairly peculiar to COVID-19 One of my former students, a very good friend, now a pulmonologist in the UK, told me he was having difficulty remembering names, a very, very specific memory loss, while he could remember everything else. So it didn't come in the way of his work, but embarrassing to be with colleagues. We've had a few GB syndromes. We've had a few peripheral neuropathies. We've had a couple of mononeuritis, multiplex. So a lot of other peripheral disorders. So our experience has been very similar to what we are seeing described in the literature, neuropsychiatric as well as cerebrovascular problems. So this is the breakup. I wanted to put it up in greater detail so everybody could see it. I've already read it out to you. And I'm going to stop again with Disha Greenhalgh, whom I respect a great deal, because in one diagram, the BMJ Open has covered this entire what you do in patients for the care of patients with COVID-19. Don't expect you to read this, but I've expanded bits of it. So recognize it in persons with symptoms lasting 3 or more weeks after COVID-19 onset. What do? You do a clinical assessment. You take a full history from the date of the first symptom, and you check their current symptoms, their nature and severity. You do an examination, which includes all these, which are fairly standard respiratory, vital signs, but also you do a detailed respiratory examination. Very importantly, you check the functional status. You check the pulse oximetry, and I strongly recommend that you test pulse oximetry at rest and after a 6-minute walk. The patient says they cannot walk 6 minutes, at least a 40-step test, walk test. And you still cannot do it, a sit-stand test for 1 minute. A very good colleague of mine, a friend, Dr. Partha Bhattacharya from Calcutta, has actually submitted a paper indicating how it's useful to do a sit-stand test where you sit and stand for 1 minute. He describes a variant where you sit in one chair, get up and move to another chair opposite and come back. You do that for 1 minute. You check the number of times the person can do this and what happens to the oxygen. And further clinical testing, if indicated, includes a chest X-ray, urine test, and an ECG. A variety of blood tests, which include certain inflammatory and prothrombotic parameters. But equally important, I think, even if your echo is normal and the patient is complaining of palpitations, which are a very, very common symptom. In fact, the first ex-postgraduate who's now moved to Visakhapatnam came back to us for care, and he kept complaining of palpitations, which were not really going away. He's a very anxious person. We initially put it down to anxiety. We did an echo. Echo was repeatedly normal. ECG was normal except for tachycardia. But then when we said, no, we've got to do something about this. By the way, we did a CT pulmonary angiogram, which was normal. When we said we have to do something else, we did a cardiac MRI, and that showed good evidence that he had myocarditis. It has improved over time, but even now he has episodes when he gets this problem. And we think there are 2 reasons for this. One is the myocarditis, but the other is an autonomic dysfunction that can lead to frequent episodes of what looks like fever. They have temperature variations, and they have palpitations, and they have episodes of dizziness. So apart from these, you may have to assess for comorbidities. As has been pointed out from the beginning, comorbidities worsen the outcomes. And something which I admired, social and financial circumstances. Do they need any social support, financial support, and cultural support? This is extremely important because patients sometimes spend a month or 2 months in hospital, and it's very difficult to know how much is the post-traumatic stress disorder, how much their worries about losing work, losing their salary, and how much they have spent. So we need to take those into account. You need to give them a safety net, and if they have worsening breathlessness, hypoxia, unexplained chest pain, and or focal weakness, you need to get help from respiratory, cardiology, or neurology colleagues, and consider doing pulmonary rehabilitation, which is probably the single most useful thing in the long run. Medical management, among other things, is optimizing control of the comorbidities, but listening and empathy seem important because patients throughout have complained that doctors don't listen and dismiss it as being something like chronic fatigue syndrome or fibromyalgia. Consider patients should be able to manage themselves and when to come and meet you. And very important, a lot of them ask about smoking and alcohol and caffeine. And we'll have to obviously tell them that these need to be completely quit in the case of smoking, and limiting alcohol and caffeine. Mental health, Dr. Jagdisha is going to cover, so I'm not going to go into this area. And I'm going to stop with a few key messages. Management of COVID-19 after the first 3 weeks is sadly currently based on very limited evidence. Approximately 10% of people experience a prolonged illness after COVID-19. Many such patients, and this is the silver lining, they recover spontaneously, if slowly, with holistic support, rest, symptomatic treatment, and a gradual graded paced increase in activity. Home pulse oximetry can be useful in monitoring breathlessness, and indications for specialist assessment include clinical concern, along with respiratory, cardiac, or neurological symptoms that are either new or persistent or progressive. Thank you very much. I'll stop and hand it back to Dr. Pradeep and Dr. Manohar.
Thank you so much, sir. Thank you so much. As always, it's a pleasure listening to you. You had more answers than the people who have had assembled here had questions. You have comprehensively covered the entire gamut of the length and breadth that the patient could go. And
I think there is some.
Can I go ahead, Mona?
Yeah, because your audio quality was not good. Okay.
Sorry. So I would strongly recommend the organizers to pass on this recording to all the members so that the amount of valid information that was shared by Sir could be passed on as benefit to all our people who've been a part of this audience. Thank you very much, sir. If there are any questions from the audience, we're happy to take those questions. Let's have a huge round of applause for the fantastic lecture that Dr. Murli Mohan put us through, and the amount of knowledge that is. Thank you very much, sir.
Honestly, while listening, I think I need to get back to my patients and review them is what I honestly feel now, some of the symptoms and other things. Thank you so much, sir. I can't see any questions in the chat box. Any comments from anyone else in the faculty till we get the questions? Dr. Neha, Dr. N.K. Singh, anyone else wants to talk on this or comment on it? It was a very, very comprehensive talk.
Hello. Yeah,
Yes,
Dr. Murli Mohan, I think seeing him for the first time, but already acquainted with him. He is a great help to our CME group also. So the long COVID is a really a big problem. But I will ask that in your practice, how many cases, many percentage of cases, which you are seeing at a long COVID now?
I honestly can't answer that with any accuracy, sir, because, a lot of these patients we managed at home. I am actually involved in the post-COVID care. Due to my age and underlying comorbidities, my team kept me strictly out of the COVID wards. So I've been relying on people like Dr. Manohar and Dr. Satyanarayan and all to look after my cases, apart from my own team. So I can only tell you that in follow-up, I think it's about 10 to 20% seems to be the right figure. The more you probe and the more willing you are to accept vague symptoms, this number is going to increase. But severe cases, I think, severe symptoms and severe problems occur in about 10% of patients. Remember that, of course, we are not taking into account the vast majority of asymptomatic patients, because there's just no way of getting an accurate denominator for these patients, for patients with COVID-19. But hospitalized patients, I think, is about 10 to 20% continue to have problems. And if you take the ICU cases, I think it's almost 50% of them have persistent problems.
Thank you.
And is it that only sick patients or severe COVID only have
So Dr. Murli,
complications?
I was fortunate to come across, some of the complications that I've encountered were an acute cerebrovascular accidents post-COVID, acute MI post-COVID, people who had acute and chronic kidney injury post-COVID. These were all the organ involvements that we have come across, and a whole lot of neuropsychiatric manifestations that you have enumerated were regularly encountered in our clinical practice in this post-COVID patients. And a very valid point that you brought about, giving the financial support, the psychological support, and the social support amongst the family members and the society was of paramount importance. And you made this point amply clear that this is a more holistic approach that we need to have. Thank you very much for this wonderful lecture, and thanks Manohar for bringing up this wonderful topic in today's CME program. Thank you very much, and wishing all of you a very happy new year.
Thank you.
Thank you. Can I just make a point that, renal disease is often missed, but on the plus side, its patients seem to recover. They go through this episode of acute kidney injury, but it doesn't seem, at least in my current experience, it doesn't seem to leave chronic kidney damage behind. And that's kind of reassuring. Except for the ones who already have kidney disease, of course, where it doesn't really, I don't know if it changes the outcomes, whether it aggravates or accelerates the disease progression. But all the ones I've seen who have initial acute kidney injury seem to recover reasonably well, which is not necessarily the case with the other systems. Again, on the plus side, for example, we're seeing a lot of very disturbing lung disease at about 1 month, 6 weeks. But by about 3 months, most of them seem to have recovered a fair deal of lung function if you just leave them alone, whether or not you use the antifibrotic. So that's kind of. Before I leave, I'd just like to say a warm hello to my good friend, Dr. Kashinath Dikshit, who I've not met for many years. We were postgraduates together. So hi, Dr. Kashi.
Are there any other comments from the
30 years over, I think. After MD, we have not met at all. It's a very happy, and it was an excellent lecture. Thanks to Manohar and Mohan and Pradeep for an excellent lecture. Thank you very much. We'll meet sometime. We have to meet. We have to meet. Yeah. Thank you.
So I think if there are no more comments, or we can move on to the topic, and the next topic I would only be taking, and it's about COVID diabetology. We would like to thank all our sponsors for this event also. And the chairperson, of course, is our good friend and well-wisher, Dr. Kashinath Dikshit. He doesn't require any introduction. He's a consultant physician and diabetologist in Gauri Kuranga Diabetes Center and Krupa Diabetes Center. Very active member in social activities or academic activities. He's always there. And he's also known for all his camps and walkathons, what he arranges. Welcome, sir.
Yeah. Thank you, entire Disha team, for giving me an opportunity for this Disha Year-End Digital Summit 2020. Each and every member, Dr. Shekhar, Dr. Manohar. And to introduce Manohar, just one sentence I'll say. He's only one of the few persons with triple FRC, CP. That's the only one sentence. Only few people in India we are having 3 FRCPs, and he is one among them. And the topic he is going to talk today about COVID and diabetes. COVID is just 1 year, 1 month old, whereas diabetes is more than 2000 years old. More than 2000 years old. Because our man Sushruta in 2000 years back, he explained about Madhumeha, that he is going to combine this 2000-year-old disease with COVID. Yeah, that's one thing. Then second thing is COVID and diabetes, more questions and than answers. What are the questions? Does diabetic patients, they are more prone to COVID? This is one important question each and every patient will ask. And diabetic patients with comorbidities, are they more prone to mortalities? If I'm correct, it's about 3 to 4 times more in diabetic patients with comorbidities, mortalities and morbidity. And then, does COVID cause diabetes? Will it damage the beta cells? Then the treatment of COVID. We know many of the COVID patients, they will be on steroids. The treatment itself for COVID, does it cause diabetes? Like this, hundreds of questions we'll be having. This COVID and diabetes combination, we can't cover in 30 or 40 minutes. It may take a lot of hours. But I request my good friend, Dr. Manohar, to enlighten us about this COVID diabetology. So I'll hand over to Manohar.
Thank you, sir. I think you almost summarized the talk in toto. Well, I'll not talk about this. I think everyone knows about the novel coronavirus. Only the SARS-CoV, MERS-CoV, and SARS-CoV-2 cause severe diseases. The remaining 4 didn't cause much of a severe disease among humans, thankfully. And again, a typical progress of COVID-19. This is keeping in mind we are dealing with an ideal world where everyone is getting treatment. So 50% or more are asymptomatic. Less nowadays we are seeing would require hospitalization. 15% of them become critical, and that's where the problem comes. Once that happens, 50 to 65% would be the mortality in such people. So coming to the questions, what our honorable chair was asking, are diabetics at higher risk of contracting COVID? Why does sugar soar so much in COVID? What differences in management of diabetes in COVID is to be done? New onset diabetes, we are seeing quite a few of them. Do diabetic patients have poorer outcomes? And what about the post-discharge COVID complications, which Dr. Mohan has clearly told us? Diabetes is one of the high-risk groups to develop severe illnesses, apart from elderly, chronic lung disease, and CKD and other illnesses. Diabetes is the forerunner, but if you look at the Indian context, diabetes is a bigger killer among COVID patients than any other illness, is what the data says. And type 1 versus type 2 is the first comparison what we always make. It was surprising that type 1 diabetics are 3.5 times as likely to have mortality, and type 2 diabetes are approximately twice as likely as opposed to the normal population who are non-diabetic. Why did the type 1 have more mortality? Because this question started in our mind because type 2 diabetics have other complications generally with old age, possible target organ damage, and obesity, which itself is an individual risk factor for higher mortality in COVID cases. So type 1 also could be, diabetics could be faring worse than type 2 diabetics is the message there. So if you look at the mortality and comorbidities of COVID-19, COVID-19 mortality in patients with previous comorbidities, cardiovascular disease ranks first and diabetes comes second. And with respect to the age group, we all know less than 14 is very less likely mortality, and with age, it increases, and more than 80, it could be still about 15%. That's why the Swedish people did this funny quarantine of only the elderly and left alone the young people to go and get COVID, and then that also backfired actually. So COVID and gender bias, yeah, we are always gender biased. Even COVID is showing some gender bias in the way it is affecting us. Outcomes, including lethality, appears less frequently in women. This could probably due to sex-based immunological responses driven by estrogens, progesterones, and allopregnanolone. There could be some discrepancy in smoking habits, even though they're catching up with smoking. Prevalence of hypertension is much higher in men, that could explain, and specific multimorbidity combinations in each individual could change that. And I alluded that COVID-19 is much less severe in children. So if you start looking at the answer, the nasal ACE2 inhibitor, the first binding point, ACE2 gene, the first binding point of SARS-CoV-2 are ACE dependently expressed. And with lesser ACE, the ACE2 gene is less expressed, so lesser complications and lesser viral load on the people, especially the children. Children are exposed to a greater variety of viruses. Nowadays, we also do enhanced hygiene could be a negative impact on it, but usually there are greater variety of viruses they are exposed to, and that this increases the immune response. There is higher frequency of decay and severe decay in children and youth with new onset type 1 diabetes, and this was observed during COVID-19 pandemic, which was not seen before. So diabetes definitely made a worse outcome if they are in children. Otherwise, non-diabetic children definitely fare very, very well and recover without much of an issue. So diabetes and COVID-19, a collision and collusion of diseases. If you look at to the left and the right, both are displayed, and the common soil is the inflammation. Diabetics always have a chronic low-grade inflammation, and insulin resistance is there to add on to make things worse. And there is a slowly progressive tissue damage and multi-organ involvement. And add to this, increased trigger by COVID-19 and susceptibility to acute cytokine storm by the inflammatory response. And this worsens, and the target organ involvement could be much higher. And that results in hyperglycemic surges, hypercoagulability states, endothelial dysfunction, and also fibrosis. Do diabetics have a poorer outcome? Well, there are a lot of data worldwide from the Chinese, American, and European data when you look at the diabetics versus the non-diabetics, there were a higher proportion of diabetics among patients with severe COVID-19 symptoms. So if you look at the green as non-severe and the gray as the severe symptoms, there were more diabetics in the severe column as compared to the non-severe column. And similarly, the mortality or the non-survivorship was much higher in people who were diabetic as opposed to non-diabetic. Hyperglycemia with or without blood glucose in diabetes range is also an emerging finding, not uncommonly encountered in our clinical day practice. And I always make it a point, whether they are young or old, blood glucose should be checked. And even if it is normal, at least once in 2 days, one blood glucose reading has to be taken. And both of these new onset hyperglycemia or already diabetics have a higher risk factor. Our good friend Avdesh Kumar Singh has done a lot of review articles and research papers on this, showing that hyperglycemia without diabetes and new onset diabetes are both associated with poorer outcomes in COVID-19, let alone diabetics coming with severe hyperglycemia. And also it is noted that at admission hyperglycemia is consistently associated with poorer prognosis, and early intervention can improve outcomes. So why should this association be there? People with diabetes have an increased risk of infection, which we all know, because of the innate immunity defects and also glucotoxicity, which plays a good milieu for the organisms to multiply, not only for the primary, but also the secondary infections to happen. So that triggers off the inflammatory response and possibly precedes the cytokine storm. Apart from that, the interaction between SARS-CoV-2 and the renin-angiotensin-aldosterone system is very well known. At the start of the pandemic, I remember a lot of fear with the use of ACE inhibitor or ARBs because the same receptor was implicated in the pathogenesis of SARS-CoV infection. But now time has come. We know that ACE2 is a common link between diabetes, hypertension, cardiovascular disease, and COVID. But ARBs, who someone is taking, should be continued, and possibly they have a protective role because of the end stage. They help in acute lung injury improvement, and it helps in myocardial remodeling, vasoconstriction, and vascular permeability. Also is protected by the ACE2 inhibition. So what are the possible mechanisms for unpredictable hyperglycemia? SARS-CoV-2, as we all know, binds to the ACE2 receptors, which are not only expressed in many tissues, not just the respiratory tissue, but also the pancreatic beta cells, adipose tissues, small intestines, and the kidneys. And this results in pleiotropic glucose metabolism defects and complex pathophysiological interactions, worsens insulin resistance. There is something called the insulitis what can happen, and this results in hyperglycemia. And as we all know, poor glycemic control or hyperglycemia correlates with morbidity and mortality. So during infection, the illness and infection and stress act as a trigger to cause release of hormones. Most of these are the counter-regulatory hormones, and this triggers hyperglycemia, hypermetabolic state, and then increases risk of life-threatening complications. And also, there is an increased propensity we have seen in quite a lot of patients with diabetic ketoacidosis or hyperosmolar non-ketotic state. I think some people should mute. Increased insulin needs in COVID-19 patients. This is very, very important. A lot of study and work has gone into this field. Just a few days back when I was trying to prepare for this slide, I just also noticed that remdesivir also worsens glycemia. So the role of remdesivir itself is in question, but when we have used quite a lot of remdesivir, but remdesivir in 10 to 12% of the people who we use, it causes hyperglycemia. And we all know that two important things which definitely work non-controversially is steroid use and anticoagulant drugs. So steroids definitely worsen hyperglycemia, and that's why there is so much of glucotoxicity. And we always keep our mind open. It's just simple hyperglycemia, or they are going into the ketotic state. What we have clearly understood in this pandemic is extreme high doses of insulin requirement. I keep discussing with my other endocrine diabetic colleagues who always say the amount of insulin what we use is phenomenal. There are three case discussions. The BMC, they had shown that how a 57-year-old man had to require a lot of insulin. Previously, if you look at it, his A1C was 6.1%, but he was requiring insulin up to 50 units per hour intravenous insulin as part. and his sugar was still about 270 or so. So this extreme requirement of insulin, even we have seen, and there is another paper publication on a very small amount of patients, like 8 patients, where they clinically correlated. If you look onto the right side of the screen, as the worsening of hyperglycemia, the complications risk become higher, and as the glucose comes down, the inflammation comes down and the patient starts recovering. So hyperglycemia could also be a marker, like how we look at ESR, CRP, ferritin. Definitely glucose itself could be a marker of worsening or deteriorating functions of the body when they are affected by COVID. And also they may say they're somewhere progressing from mild to moderate or moderate to severe. This one case is our own colleague, doctor, who was not a diabetic. He got severe COVID infection. He was placed on HFNO steroids. He really fought a hard battle. He was in the ICU, and then he required huge amount of insulin infusion pump for about 8-10 days post shifting out of the ICU. Also, he required more than 200 units of insulin, and I had discharging with premix analogs because he didn't want basal bolus to be taken. And immediately post discharge, he started having hypoglycemic symptoms. This is one point what I would like to make is, even though we are continuing sometimes tapering dose of steroids, suddenly what we should be watchful is when we discharge, we need to reduce the insulin, not about 30%, which we definitely do in other cases, but maybe more than 50% reduction. And we should always tell them to monitor the glucose and be in touch with us as frequently as we can, especially when they need at very high doses, because they come down also quite quickly. And this is one Chinese study which clearly showed about 952 participants who are in different groups. In the end, they could zero down to 250 well-controlled blood glucose and 250 poorly controlled blood glucose after matching. And they clearly showed any event, all-cause mortality, ARDS, AKI, or acute heart injury was definitely better outcome when you manage their glucose well. So glucose control is very, very important. Of course, it is much easier said than done. At least now the caseload is less, because many of the guidelines initially, when I was discussing with the national leaders in our CME groups, they always used to tell if it is consistently more than 180, put them on infusion pump. But it was honestly not very practical to do it, because initially the workload on the nurses was so much that we can't be putting everyone there on infusion pumps. At least now things are better, and we hope it stays that way. So this is the consensus recommendation for COVID-19 and diabetes for outpatient care and inpatient care, and what should be the therapeutic aims. On outpatient care, we should definitely sensitize the patients with diabetes for the importance of optimal metabolic control. Don't make too many changes in the medications. I'll come to that next, but reasonably good control should be enhanced. Enhanced hygiene and enhanced control are the two important things. And we should say the risk of getting COVID is not high in diabetics, but the risk of getting complications are higher, and that can be dealt by controlling it better. So anti-diabetic medications, patients should follow the advice of their physicians and be in touch with them. Now teleconsultation definitely is very legal and being used liberally in everyone. I'm sure they are using it. Monitoring is the key according to this ADA Diabetes UK recommendations, every 2-3 hours, but I don't think it could be possible. At least in a mild case, who is admitted, pre-meal and bedtime should be okay, and maintain the glycemic control and re-emphasize the hydration and electrolyte imbalance, which is also comes in with the glycemic control. So what happens in type 1 diabetes? If possible, or if someone is used to it, insulin pump would be ideal. Otherwise, continue the basal bolus regimen. Recommend insulin analog is what they say. Whenever it is feasible, definitely it could be done. Otherwise, even the regular insulin with good control should be all right. For type 2 diabetic patients, for patients especially with fever or treated by glucocorticoids, that is moderate to severe cases, please shift to insulin. No point continuing the COVID-19 cases on oral anti-diabetic agents, especially if they are getting worse. The mild cases, definitely the glucose fluctuation is not much. Many of the time we can continue the oral anti-diabetic agents. Glucocorticoid associated diabetes is interesting. I'll come to that in the later half of presentation. Always maintain hydration. Sometimes we keep discussing with our intensivist. Sometimes the intensivist wants the person to be dry to when they're trying to treat ARDS or impending ARDS. And that's where sometimes we get whether to hydrate him enough and what level of hydration is correct there. So what is the ADA statement on this? Definitely, they say there is no enough data to show whether people with diabetes are more likely to get COVID-19. Definitely, they experience more severe symptoms and complications. And as I showed you before, well-managed cases definitely do better. So a national strategic framework was given by Dr. Mohan. And this is what they said. In young people, and there are no comorbidities, the target of fasting should be less than 120, and 2-hour postprandial should be less than 160. And if they are older, you increase 20 units in both cases for the glucose. And you can further go up to 220 if someone is having multiple comorbidities or who is elderly. So coming to the therapeutic principles of glucose management, insulin treatment is the choice, as I explained, for moderate to severe cases, definitely critically ill. Continuous infusion could be better choice, or multiple injections we can think of when they are stabilizing. Metformin, this was the initial time they said they're not recommended in definitely severe cases, but mild cases we definitely use it. Secretagogue doesn't seem to interact with the ACE2 gene, so can be used in mild cases. TZDs were a bit controversial. Initially, they had a lot of thinking that it could be detrimental, but many studies have shown that TZD could be beneficial or at least neutral. There was a lot of work on DPP-4 inhibitors because of SARS-CoV-1 epidemic when it happened. That virus was binding to the DPP-4, and DPP-4 inhibition was said to be protective there. But when it came to SARS-CoV-2, it binds to a different gene, but definitely they are neutral and could be used. SGLT2 inhibitors was a surprise there. Everyone, by the rule of book, when someone is admitted, we definitely stop it. But then there is DARE trial with dapagliflozin, which is ongoing. They say because of the cardiometabolic, cardiorenal benefits, possibly in acute COVID cases also, SGLT2 inhibitors could be used. I never used it. I don't recommend anyone to use it. We'll wait for the DARE trial results to come, and then we'll take it up later. GLP-1 receptor agonists are neutral, but again, in sick cases, I don't think they find any place there. But if someone is mild case and if someone is on it, they can definitely continue that. There's a lot of evidence into research, like insulin could be protective, but as there is so much information pouring out, like 2 days prior this talk, I got another mail, which I will show you in the next slide, where insulin could be detrimental, as they say. So insulin possibly is protective, is what we still believe, but again, there is no choice apart from using insulin in acute severe cases. Why they say insulin could be protective is there is low pH is necessary for SARS-CoV-2 to enter the cells via the ACE2 gene. We all know that. That's why hydroxychloroquine came into play, because it was increasing the pH. So insulin stimulates sodium hydrogen exchanger and it increases the pH. So the theory here, when they say insulin could be protective, is by increasing the pH via the sodium hydrogen exchanger, insulin could be protective. So in summary, if you want to look at the anti-diabetic medications in patients with diabetes, this is what it is: uninfected but living environment with prevalent COVID-19, which is all across the globe. You continue what they are using. There were some question marks on SGLT2 inhibitors, but I'm sure we can use it. If patient is ambulatory and has mild disease, insulin, DPP-4, metformin, GLP-1 analogs are fine. There is no great protective data with respect to sulfonylurea, SGLT2 inhibitor, TZD, and alpha-glucosidase inhibitors. Hospitalized, moderate cases, same, these 4 can be continued. And if they are sick, we move on to insulin. And sometimes definitely I also have used DPP-4 inhibitors in even hospitalized, moderate to severe cases. This is the interesting part of it. What is steroid-induced hyperglycemia? If you look at the graph onto the right, I think next time I would make a colorful one. This is the triangular wave is the non-diabetic subject who are not on steroids, and the rhomboid one is non-diabetic subjects receiving prednisolone, and the squarish is the diabetic subjects receiving prednisolone. So when we look at this, at the 8th hour, I would like to draw your attention to, that is where if we traditionally give the steroids in the morning, and then at the 8th hour, the sugars start kicking up in all the group who are receiving prednisolone, whether they are diabetic or non-diabetic. So keeping this theory in mind, that's why we see many times post-lunch, the sugars are shooting up pre and post-lunch. So we always say, I don't know what he had for lunch, but there are a lot of the times the steroids effect is what is causing the hyperglycemia. So looking into this, many people argue because NPH insulin, the good old NPH insulin, also has this shouldering effect and peaking at around 8 hours. And maybe it is beneficial. And many people still believe that in steroid hyperglycemia, steroid-induced hyperglycemia, NPH could be more better insulin than the insulin analogs. However, the evidence for this recommendation is limited. We predominantly use analog insulins, but NPH has a role there, is what I would like to say. So coming back to the question, are diabetics at higher risk of contracting COVID? Mostly no. Why does sugar soar in COVID? ACE2 gene, insulitis, steroids, nowadays remdesivir also can cause it. Stress, secondary infections could all be triggered. What differences in management of diabetes in COVID, if you ask? Definitely they require a higher insulin dosing, but remember they require a quick tapering down also. And do diabetic patients have a poorer outcomes? Yes, unfortunately, but if you manage it well, definitely a lot of review articles have shown that they really do very well, but managing is not all the time easy in spite of all this knowledge we have. And post-discharge differences, quick tapering of insulin, unlike in other cases, and post-COVID complications, are they higher in diabetics? I'm not sure about it. I couldn't get any reference for that. This is what I was talking. There are more questions. Like recently I got this, glucose or insulin, which is the culprit in patients with COVID-19 and diabetes? That was a very thought-provoking question, but I still feel insulin is the answer for such hyperglycemia. So before I conclude, diabetes is a risk factor for worse outcomes. No two things about it. It's related to pleiotropic alterations of glucose metabolism via ACE2 gene, multiple pathways. ACE2 is a common link between diabetes, hypertension, cardiovascular disease. Steroid worsens hyperglycemia and increases the chance of DKA. Insulin is a drug of choice for sicker patients. Mild cases could be managed in a similar way how we manage the other cases. And dose of insulin parallel severity. That is also an important thing. And this is what I say, my 10 commandments, my experiences thus far with respect to COVID. I don't think this audience would require this. This is my usual. Thank you so much.
Thank you, Manohar, for an excellent lecture. Such a huge topic, such an excellent topic. You are able to cover most of the aspects. Just two things I want to tell you. Previous viral outbreaks like H1N1, the diabetic patients were more prone, whereas it is not so with COVID. The non-diabetic patient suffering and diabetic patient suffering, it's almost same. In one of the Chinese studies, it was about 9%. And the population of diabetic population in China is about 9 to 10%. So the diabetic patients, they're not more prone to diabetes, COVID. That's one thing. Yeah. Then second thing is, but a diabetic patient, especially with comorbidities like renal or cardiac or whatever it is, the mortality in those patients, the diabetic patients who get COVID, if the mortality is almost 4 times. In one of the Chinese studies, it is 4 times higher. So a diabetic patient has to be more careful. That's one thing. But an excellent coverage, you did in such a way that 2000-year-old diabetes and its association with 1-year-old COVID, but done an excellent job. If there are any questions, Dr. Manohar is ready to answer.
Dr. Manohar, in the post-steroid, I think the steroid-induced hyperglycemia, you told that the NPH works much better than the analogs. So do you have can you further elaborate on this?
In most cases, that's what they theory behind it. I have not used honestly much of NPH. I'm thinking of using it now and trying it out. Because of the shouldering effect, the NPH has a peak effect. That's what used to cause hypoglycemia. So we used to avoid it for late night, especially if the dosing of NPH is high. What the theory is, basal insulin works straight, but when you give a steroid, there is an increase in the glucose at around 8 hours. So if you, instead of giving basal insulin, if you had given NPH insulin also peaks around that same time, and possibly the spike in glucose can be controlled better because of this shouldering effect of NPH, which was a problem before for us. That's where insulin analogs came into being.
The shouldering effect has been always stated as a problem. with
problem.
the
Because of steroid
insulin.
use, it could be an advantage because that is the time where the glucose can be high. I'm sure this could be a topic of discussion in CME India. I'm looking forward to it.
I would like to clarify a small thing. This shouldering effect and NPH usage is seen only with oral prednisolone used once in the morning. So when the prednisolone or methylprednisolone used twice a day, or when we use dexamethasone, this shouldering effect cannot be seen. This is usually seen when we give prednisolone oral after the breakfast. The surge happens at around 4 o'clock, and there is no nocturnal surge in the sugars after the morning dose of prednisolone. That is the reason NPH has been used. I don't know exactly where I have seen. There was one presentation where we have seen the other basal insulins, non-peaking insulins, the glargine and the degludec, they act for almost 24 hours. So what happens? Patients has a surge in the afternoon, which is not covered by this basal insulin, and there is no surge in the midnight during the midnight surge, but the basal insulin keeps continuing to act. So they have a seesaw effect. They have a hyperglycemia in the afternoon and a hypoglycemia in the midnight. So this correlation is with once daily prednisolone in the morning and the NPH usage. So if we are
I
using
totally
twice a
agree
day,
with you.
Good explanation. Yeah.
Yeah.
So this is the thing, sir. So
It
couple
may
of
not
points.
happen with when we use it BD or when we use dexamethasone, but I
Yes.
think it should work with methylprednisolone when we use it once a day, because
Once
many
a
of
day,
the time
yes.
are 40 mg OD and then sometimes we make it BD also.
Yes. So a few pointers, this thing in this. So what we have done, we have seen is there is very less incidence of decay in these patients, though the sugars went very high, probably because of early usage of insulin. Though the sugars went fluctuating up to 400s, 500s, coming down to 90s and 100s at some point of the day. Very less incidence of decay in these patients, onc or decay both. So probably we were monitoring them very closely. That is the reason, and they were on high doses of insulin. What we did here is, in our hospital, is we always used a basal insulin. For every 0.5 milligram of dexamethasone or 4 milligram of methylprednisolone, we used 10 units of basal insulin, whichever it is, if the patient is insulin naive. And added the for prandial control, we used ripaglinide or linagliptin. So linagliptin more because remdesivir affects the liver, and linagliptin is hepatic safe. So we used linagliptin. So that is second thing, what observation it is. Insulin causing danger to the COVID patients, mortality is higher. I think it is a correlation rather than a causation. The article is more of a correlation, what they are saying. As our patients say, my grandmother, they put on insulin, she died. So I don't want insulin. It's something like that. I think it's more of a correlation rather than a causation.
Yeah,
Any other comments from anyone?
Yeah, Dr. Manohar, you have done an excellent job. By God's grace, COVID cases are coming down in Bangalore, Karnataka, and India. Forget about USA, we don't know. Yeah, it's coming down. But insulinitis is caused by COVID. There will be inflammation of the beta cells. Probably in 1 or 2 years, type 1 diabetes, type 2 diabetes, COVID diabetes. We may have the terminology as COVID diabetes, the diabetic patients because of COVID. Thank you for an excellent lecture. Thank you for giving me an opportunity. I thank each and every member of the Disha team. Thank you very much. Thank you.
Pleasure, sir. We'll move on to the next topic. Very, very interesting, important topic. That's about the vaccines. And the chairperson for this is Neha Mishra. Well, she's an iron lady, I should say. From the start of the pandemic, I used to, every day whenever I used to see her, I used to tell you need to take rest. That much is the amount of work she was putting in our hospital. I think she deserves a round of applause for the amount of work she has done. Always looking up for anything you ask, she's there. She's done an MBBS from Hyderabad, MD in medicine from Haryana. She had done a postdoctoral fellowship in infectious disease at CMC Vellore, and she has done a PG diploma of infectious disease at University of New South Wales. She's authored numerous chapters and publications. We are glad that you are here, Neha. And the speaker is Dr. N.K. Singh. If you could change the slide.
Yeah.
N.K. Singh, sir, is a very, very dear friend of mine. And he is a very, very dynamic person. I can't imagine the amount of knowledge he shares in every day. I don't know how he manages it. We have a group called CME India Group. And then he has there is a website by that name, and every hot topic is discussed thoroughly, very professionally in that group. And he's a very good speaker. And he is at Dhanbad, and he's also the chairman of RSSDA Jharkhand and ex-governing body member of National API. And he's always there. Any doubt, you text him, and he's there to answer. Neha, would you like to brief before we move on to the topic specific? You have to unmute yourself.
She's not audible.
Neha, you are not audible.
You unmute.
You have to unmute. You unmute. Yeah, now. I think it's unmuted now.
Dr. Neha, please increase the volume of your laptop.
Yeah, it is okay now.
Yeah, you could share your screen, sir, in the meanwhile. Yeah, you're mute.
Dr. Neha, increase the volume of your device. Or if you have earphones, you can use that and try.
Or do you think you are talking to your husband, shouting at your husband, so it will come?
Or talking to a COVID patient with your full end respirator and your hazmat suit. In the meanwhile, sir, can you share the screen, Dr. N.K. Singh?
Yeah, I can start if you allow.
Yes, sir. I think
Okay.
she has some issues. She's off screen.
Yes, she has some problems.
I'll call her after that.
So let me share my screens. Yeah. I think it is visible.
Yes,
Manohar?
sir. Yes, sir.
Yeah, so let me start in the next 25 minutes, which you have allotted to me. I am really thankful to all the Disha team and especially our good friend, Dr. Manohar. Really, I was a bit surprised. I'm not a vaccine expert or COVID expert at all. But anyway, he thought that I can do the justice with this topic. But here, when he sent the topic, this VACCIN, I was really a bit surprised. Seeing the capital I and N and two queries. So I think he is more concerned about the vaccine in India. So accordingly, we will discuss it. And at this time, in our CME India group, which we are mentioning, lots of debate is going on when the vaccine will be available to the India. And very just now, even the Dr. Sasank has shared a slide where he says that it will take more 3 months. So every day, every time, every moment, things are changing. You see this cartoon where there is a reviewer here and all these animals are here, and he asks if for a fair selection everybody has to take the same exam. Please climb that tree. So with this Pfizer, Moderna, Sputnik, Covaxin, and Oxford from the Astra, Novavax, Covishield, I think these are the main things every day, every time we are hearing. And I don't know which one is going to climb first this time at all. So we will discuss that. And this time, I think more and more people are interested in vaccine itself. So I think this is a very important talk. that this time everybody is asking for vaccine, vaccine, vaccine. So let us see what happens. So we did a story for that, which bells are ringing for the COVID vaccine. But the initial message which I would like to share is crucial to success of any COVID vaccine. You have to trust it, have confidence in it, because without that, this cannot be successful at all. Well, 2020 has been a year you will want to delete forever, but you will never will be. Even after getting 58 vaccine against severe acute respiratory syndrome coronavirus 2, which are knocking at the door, I don't think what will happen even in the 2021. But no need to be excited so far, as far as I see. At present, in the world, 3 safe, efficacious COVID-19 vaccines do exist, and a further 55 are in clinical trials. And COVID-19 treatment and prevention are in gambles. As you know, every day things are changing. Without concrete evidence, we are using many things in the treatment protocol, and I don't know whether we are doing the same for the vaccine protocol also. So we have to reason to suspect what might help and what not. But it is really a wonderful thing that in the COVID-19 vaccine results, we have getting vaccines so early, which never happened in the history of mankind. So there is some fast forward button, although this is a cartoon. So I told you that just a brief about the types of COVID-19 vaccine. We have, if you want the active immunity or passive immunity, two things are going. The DNA vaccine, where lots of, we have heard about the RNA vaccine, which is from the Pfizer, and the Oxford vaccine, that is a viral vector vaccine. And I think that they are using in the Janssen also, and this Sputnik also, the viral vector is being used. And the Novavax, that uses the viral subunit, and Indian immunological, that is using a live attenuated. And the other things are like the virus-like particles, inactivated viruses, and split virus vaccines. And also there is going to happen something with the antibody administration with the passive immunity, and they are developing it. So with that, you are well aware now that we have got nucleic acid vaccines, protein vaccines, and viral vaccines. I will go into in detail, but as far as the status of the vaccine is concerned, everyone is aware that the AstraZeneca, the vaccine in the phase 3 trial has been complete. Sputnik is complete, and the Moderna is also the phase 3 is complete, and this Pfizer BioNTech is also complete. So this is an important happening which has we are witnessing. And basically this is a simple immunology, that why you need 2 dosage from the primary immune response to the secondary immune response. So what happens in the mRNA vaccine? This is very important to understand that the Moderna has developed the RNA vaccine mRNA, that is the 1273 encapsulated in the lipid nanoparticles, and the RNA used in the viral RNA isolated and spliced to give the exact gene. So you can see here how this is happening. It is not possible to go in details, but these things are happening with the DNA, RNA, and protein vaccines. Then you are also using the live attenuated vaccines. So virus is alive, but rendered less inactive, but still able to provoke a robust immune response. So this is live attenuated corona vaccine. And what is happening in the vector vaccine, that the viral genes inserted into a harmless virus. Here, this has been, you can see here, this has been inserted into a harmless virus, and harmless viral vector carrying the coronavirus genes, and the Oxford and Sputnik are using this vector vaccines. Then also this has been used, this inactivated vaccine, where virus is killed, inactivated by the chemicals, heat or radiation, and they are the dead coronavirus, cannot replicate but provoke a host immune response. So this happens. There are lots of pros and cons with all types of virus. And there is also important is happening with the Novavax, that is the viral subunit vaccines. Viral proteins, particularly the spike proteins, are extracted, and this also is being used. And also I told you that the mRNA-induced antibody, this could be a big thing in the days to come, that this is another novel vaccine concept that is being explored. The mRNA here is not coding for the antigen of the interest. Instead, it codes for the actual antibody, and then you get the antibody against the coronavirus. So this is also a thing is going on. Most of things, as you are seeing here, they use the two dosage. Only the live attenuated virus is saying the one dose, and viral subunits, they are showing the one dose. So what are the DNA RNA vaccine challenges? As there are currently no approved DNA or RNA vaccine, it is unclear how effective they will be in vaccinating population against COVID, or how quickly they can be scaled up. I think this was a bit backslide, but today I will update it in the later slides. In addition, naked genetic material alone is unlikely to produce a strong immune responses and memory, as they can be quickly degraded outside cells and need to cross cell membrane to produce and settle the antigen on the cell surface. There are also so many safety concerns we will discuss. So actually the talk is in Indian scenario, what vaccine, how we will do it, when and why. So let us think about that. So as far as the global landscape is there, COVID-19 candidates in clinical trials, I told you. But in Indian scenario, what is happening? You can see here the Covishield manufacturer is Serum Institute of India, Pune. Collaborator is in Astra, and current Astra is 2/3 is going on. Covaxin, that is inactivated virus, Bharat Biotech International, Hyderabad. ICMR India is a collaborator, and this is also in phase 3 trial. And from the Zydus, the Zyco D DNA vaccine is going on in the phase 2 trial. Sputnik is, as you are well aware, that Dr. Reddy is concerned with here at Hyderabad, and phase 2 over. Now phase 3 to start. They have already started, and even the Serum Institute of India, that is the Novavax, it is in the news, and this is under consideration in India. And other things are also going in India. That is I will not go into details, but as these are in the preclinical animal studies here, animal studies, the only thing are the above 5 are important. And we have a national expert group on vaccine administration for COVID-19, and they are doing everything for the planning. This strategy, vaccination for the vaccination, they have formulated as per guidance of the NEGVAC. Most candidate vaccines follow a 2-dose schedule, 1 and 3-dose schedule for one candidate vaccine each. Vaccines are developed using multiple platforms. They are not interchangeable. A beneficiary must complete vaccination schedule using same vaccine product, and a storage temperature for most candidate vaccines similar to other UIP vaccines is 2 to 8 degrees, and rollout of vaccines should be done following the election model. So this is what they are planning. You can see here in the phase 1 of the COVID-19 vaccine, introduction in priority group, what this group is doing. And they have also given a list, the priority population groups for the COVID-19 vaccination, how the frontline worker will get the first. And now this COVID digital platform for COVID-19 vaccine delivery is on, and you have to go from this platform or the COVID winning over COVID, and you have to, by like this, from this app or this system, you have to register yourself, and then what will happen, that you will guiding the principles of vaccine eligibility for the beneficiaries. And after that, you have to need all these, something like Aadhaar authentication and creation of unique health ID, and then you will be registered, and then your vaccination certificate will be generated, like beneficiary vaccinated, SMS, digital certificate, like comes like this. And so this is what Government of India is doing for us. As far as the update is concerned, the phase 3 data came on from the Pfizer vaccine on the day, as you are seeing here. Sorry. So this Pfizer vaccine efficacy benefit starts 14 days after the first dose, and the known benefits among recipients of the proposed vaccine relative to the placebo are reduction in the risk of confirmed COVID-19 occurring at least 7 days after dose 2, and reduction in the risk of confirmed COVID-19 after dose 1 and before dose 2, and reduction in the risk of confirmed severe COVID-19 any time after dose 1. So it takes about 2 weeks for the immune system to make sufficient antibody protection after vaccination. This came. And we are well aware that the efficacy-wise, after second dose, we are showing 95%. No meaningfully differ if you efficacy by see by age, race, ethnicity, and comorbidities. There is no meaningfully difference. So this looks quite good, and from the graph also. But as far as lots of news about the adverse effects of this Pfizer, you can see these things happen with almost all vaccines: injection site reactions, fatigue, headache, muscle pain, chills. And I don't think we should be concerned about this. I then it only says to you that your vaccine is working. So there is no need to be in panic mode for all these things which we are showing here. But what we do not know is important. Like the Trump, you can see here vaccine and the electrolyte, and the duration of protection at present is not known. Effectiveness against transmission is not known. Vaccine effectiveness against asymptomatic infection is in query, and data is limited to assess the effect of vaccine against asymptomatic infection as measured by detection of the virus or detection of antibodies against non-vaccine antigens that would indicate infection rather than an immune response induced by the vaccine. We also do not know effectiveness or safety among certain high-risk populations, such as children less than 16 years of age, pregnant and lactating individuals, and immunocompromised individuals. And benefits of individuals with prior COVID-19 infection, what should we give or not, but given there is a documented reinfection, the FDA stated that previously infected by people could benefit from vaccination. So this should be crystal clear in your mind. We still do not know the vaccine effectiveness against long-term effects. We don't know. And demonstrated high efficacy against symptomatic COVID-19 should translate to overall protection. This is an important point. It is possible that asymptomatic infection may not be prevented as effectively as symptomatic infections and may be associated with a sequelae that are either late onset or undetected at the time of infection, like myocarditis. So next is your very important vaccine, that is AstraZeneca vaccine. And this trial has been also published on December 8, as you are seeing here. And after phase 1 trial, they supported a 2-dose regimen. The trial protocols were amended where necessary to require 2 standard doses. So what to do, 1 dose or 2 dose here? The update is that Oxford's COVID-19 vaccine candidate has a better immune response when a 2 full dose regimen is used rather than a full dose followed by a half dose booster as per the university. And the vaccine candidate, which has been licensed to Astra, previously published interim late stage trials results showing higher efficacy when a half dose was followed by a full dose compared to a 2 full dose regimen, though more work needs to be done to affirm the result. So I think this again, this has been, although here they are showing that the subgroup details from this clinical trials released on this last Thursday made no difference to the half dose, full dose regimen, which Oxford has said there's been unplanned, but that has been still approved by the regulators. Remember, this has been approved by the regulator. Although the overall efficacy is 70% is lower than what was reported 90 to 95% from the mRNA vaccine from the Pfizer, even from the Moderna and from the Russian Sputnik, that is an adenoviral vector vaccine. So here efficacy is lower as far if you compare with the mRNA, Pfizer, Moderna, and the Sputnik. It should be clear. And again, though no serious adverse effects or deaths occurred, the transverse myelitis cases did happen, but resulted in temporarily pausing the trial, and all participants have recovered or are recovering. So editorial in Lancet wrote that disparity between the immunogenicity and efficacy findings could imply that clear-cut immunological correlates of clinical protection might not exist for COVID-19 vaccines, meaning efficacy cannot be extrapolated to other unevaluated ages or populations. Remember. So take home from this very important and very, I think, important vaccine candidate that it is a good promise for affordable compared with the high cost of the 2 mRNA vaccines, which have reported more than 90% efficacy. It has got a acceptable safety profile. It has been found to be efficacious against symptomatic COVID-19, and this can also use routine refrigerated cold chain, which is important since the ultra low temperature freezers required for mRNA vaccine, as you are well aware. Again, the FDA panel now has just endorsed on December 17, the Moderna, the wins key vote in the path to emergency use. So this has been efficacy again very good, 94.5%. So this has been again by FDA panel has been endorsed because the Moderna vaccine meets its primary efficacy endpoint in the first interim analysis of the phase 3. The study is known as the COVE study. Initially, it was a press release, but now you can see what is happening with this. So this study was the COVE study, and this vaccine is told to be the most promising vaccine. No much side effects again. So this question was asked by Dr. AKS in our CME group, if all vaccines are provided to you free of cost, which you will take and why? Pfizer, Moderna, Covaxin, that is, or the Sputnik. So what do you think about that? In Indian scenario, what we will say that active cases show a clear-cut declining trend, which we are finding now, and government of India is expecting 2 vaccines against COVID-19 now. That is, one is, remember, the Covaxin, that is from the Bharat Biotech, and Astra Covishield. So Covaxin and Covishield, both are initially they told 1 week before that they are going to be available by January 4, but now the news is coming that it will take time. So I have just written here that any time after January 4, maybe it maybe not come in the January itself, but I think in the 2 weeks you can expect that this will hit the market. So as you are well aware, this Covishield is Pune-based Serum Institute of India has sought up the application version of the vaccine developed by the Oxford. So this is in the news. Then the Covaxin I told about the Hyderabad-based company, and this Pfizer. This is a vaccine is the first one to receive regulatory approval from the US. This is also important to understand that this Sputnik vaccine is a human adenovirus vaccine, and in India, the Dr. Reddy at Hyderabad, the things are going on, and they have already, India has purchased 100 million doses of candidate vaccine from the Russia, and this vaccine shows 92% efficacy. And already you are seeing here a double-blind trial is showing 40,000 volunteers. The findings of it are not yet viewed. So I think this could be also a hope in our country too. And this is showing how the government of India, they have applied this for the approval. So I think even as far as Chinese vaccine is concerned, already being used in the UAE, but in India it is not going to come. Johnson & Johnson vaccine update is that they have again started the trial after the initial halt. So this can also come. So to end my talk, a story so far is don't forget your COVID-19 vaccine whenever it comes. And you make sure you keep a record card as they are keeping in the UK. Many people say, well, there is no need of vaccine now, with this hypothesis, which I am showing you, that the country may still reach herd immunity without getting the vaccine, because this I don't think that because if your country, this is what to ponder this hypothesis, that an ineffective vaccine could also give false security to those receiving it. So crystal clear facts are that COVID-19 vaccines have received so much public attention, causing more confusion than helping. We never check the efficacy of the current vaccines before taking them, remember, and we should try to tell the public that it is not going to be less efficacious than most vaccines available today. And serious side effects are rarer than death on table in a surgery, and mild to moderate side effects are common with the most of the vaccines. And these vaccines could play a very important role in increasing population immunity, preventing severe disease, remember, and this is the most important point and the most important message to tell the public. So which vaccine is on platform on time, how to vote? I think I told you about that, and I will update later just in the last slide. So I have already told these points. Now this question that post-COVID patient needs vaccine or not, I think the answer is at this time we do not know how long someone is protected from getting sick again after recovering from COVID-19, and some early evidence suggests natural immunity may not last very long. So we want to know how long immunity produced by vaccination lasts until you have a vaccine and more data on how well it works. So both natural immunity and vaccine-induced immunity are important in COVID-19, remember. So getting vaccinated can help people getting sick with COVID-19, while many people with COVID-19 have only a mild illness, others may get a severe illness. So it is very, very important to get it. There are lots of controversies. Every day you are seeing on the net, on your WhatsApp group. What you are saying? Sometimes this patient of Brazil now told कि COVID vaccine लोगों को बना सकती है मगरमच्छ और महिलाओं को उग जाएगी दाढ़ी. Just told yesterday by the Brazil राष्ट्रपति. So COVID and science looks like a story like Bikram and Betal to me. And even some case was done after AstraZeneca. Corona vaccine is undergoing trials in India by a volunteer. And these things are happening. And later on how they have also replied this. And see this, Bill Gates caught on video admitting vaccine will change our DNA. Do you think?
Is promising is called the RNA vaccine. With RNA and DNA, instead of putting that shape in, you put instructions in the code to make that shape.
This is not happening. This COVID vaccine will not happen because no need to for vaccine. COVID pandemic is over. This was said by a vice president of the Pfizer. So, but the fact is, mRNA vaccines do not use the live virus that cause COVID-19, and they do not affect or interact with our DNA in any way. And mRNA never enters the nucleus of the cell, which is where our DNA or genetic material is kept. The cell breaks down and gets rid of the mRNA soon after it is finished using the instructions. And one person told that Dr. Manohar sent to me that the head of the Pfizer research that COVID vaccine is causing female sterilization. And when I searched on the net, this page was removed. Then this was a fake claim of the female sterilization. So सीधी बात, no bakwas. Get the earliest available vaccine when you get it. So this is the most important message. And as far as other rare possibilities are there, remember a plane is always safe on the ground, but it is not made for that. Or it takes some meaningful risk in the life to achieve the greater heights. So whatever it may be, the Guillain-Barré syndrome, disseminated encephalitis, transverse myelitis, these things can happen with so many. We have also seen many cases with the rabies vaccine. Even about the Bell's palsy, lots of controversies are going on. I don't think this is a very important issue as far as the vaccine is concerned, because still we do not know. There have been cases with both this Pfizer and the Moderna, but neither product has been definitely linked to this risk that I will finish here. And just in that the COVID-19 vaccines should not be withheld from people who are pregnant or lactating and want to be vaccinated despite lack of safety data in this population. This has been said by CDC and ACOG, remember. So concluding lastly, only one slide. All facts are shared with you, and only line of conclusion is apply your own wisdom. And this just went in our CME group where Dr. AKS updated that Indian Covaxin is midway of the phase 3 trial. And unless this, so this just he updated. So last point which I would like to say you, this appeared in the self-praise, when there is a corona cases, this one, not immunized, so what you are getting with herd immunity and with vaccination, the message is quite clear here that population level herd immunity is critical for long-term control of SARS-CoV-2. तो लास्टली हम लोग थक गए हैं कोविड-19 से, इसलिए जगजीत सिंह की एक गजल बड़ी इंपॉर्टेंट है कि धूप में निकलो, घटाओं में नहाकर देखो, जिंदगी क्या है किताबों को हटाकर देखो, तो जब वैक्सीन आएगी तो इसे लीजिए और बिना शक के लीजिए. थैंक यू वेरी मच.
Am I audible?
Yeah.
Okay. So I'm sorry for the technical glitch that has happened in the beginning. So with this, I would want to thank Dr. N.K. Singh. That was a very elaborate and very nice presentation with a lot of humor attached to it. And I would also, I'm sure he has answered most of the question. I would re-emphasize on what he said. See, vaccines so far have been, it has proved to be the only way to deal with any epidemic, any pandemic that has happened so far. You can take our success stories from past, be it smallpox, be it polio. The only way we could eradicate these things was vaccine. So I see no reason that why this time it will not work. I think the excess availability of media, excess availability of WhatsApp, communications and technology actually has made the work of researchers, all the scientists, all the doctors who are working in the front line more difficult. So I think whenever it is available, please go ahead and take it. 0.6% is the risk of severe complication that can occur with mRNA vaccines. So that is very lesser risk. Even if somebody is walking on a road, the risk of him getting hit by a car will be more than that. So I think, please go ahead. Whosoever is reaching out through this Disha team, I'm sure all the doctors also have had these kind of doubts whether we should or whether we shouldn't take the vaccine. I'm sure they will set up the proper guidelines. India will work and come out of this particular pandemic. But whenever it is available, please take the vaccine is the message I would want to give. And thank you, Dr. N.K. Singh. That was really, really very nice presentation.
Thank you, Dr.
Thank you. So we can take up whatever questions if somebody wants to ask. We are happy to answer everything.
Someone has asked vaccination advice in long COVID and no antibodies.
See, antibodies.
Dr. Neha.
No, sir. I'm sure sir will be. So I just would want to see the antibodies do not depict the infection or non-infectivity of the patient. And these antibodies which are produced post natural infection of COVID, they might, the titers might decline and they might just vanish after some time. If you read through the paper that Pfizer vaccine has come up with, if you read through that trial, they have actually said even the post-COVID people can take the vaccine after 90 days. They can actually take it earlier also if they think that they had a very mild disease or something like that. And the titers of your antibodies do not determine, and they should not be checked. You should not check the titers prior to giving this kind of vaccination. So I don't think anybody, even post-COVID patients, should be deprived from the benefit of the vaccine whenever available.
Exactly.
Thank you.
Can I ask you, Dr. Singh, it's very nice to listen, Sarji, your lecture. Really, I enjoyed. Just in the newspaper, there was some news that few fatality happened in the vaccine trial, but your presentation was very clear. There is no fatality.
No, there was that yesterday. There was a WhatsApp. One post was viral that one nurse took it, she fainted, and then the story went on that she died. But later the writer news came, and that was a fake story. See,
no,
just
not this one. Before around 15-20 days back, some Times of India there was.
I think there's lots of such fake news are coming. So you will be very careful, and you recheck it on the Google from the reliable source. That will be a better answer for that.
Thank you, N.K. Singh sir, and thank you, Neha, for being there. I think we'll move on to the next presentation. There is a slight change.
I think we'll request Dr. Arpandev Bhattacharya's talk to be scheduled next. That's the scientific saga of GLP-1 receptor agonist from glycemic control to CV outcome. To chair this, we have my good friend Anantharaman.
Hi, everyone.
Dr. Anantharaman is the co-founder and consultant endocrinologist at Magna Clinics for Obesity, Diabetes, and Endocrinology. He was working previously at St. John's Medical College. Areas of interest include comprehensive management of diabetic food, pediatric diabetes, diabetic nephropathy, everything related to diabetes had to be, and has a lot of publications to his credit. Over to you.
Hello, it's my pleasure to introduce Dr. Arpandev today. So he's an illustrious colleague in Manipal Hospital, senior endocrinologist at Manipal Hospital. He's done his MD and DM from PGH Chandigarh and also an MRCP and CCST from UK. So over to you, Arpan sir, for the presentation.
Yes, thanks very much. Good afternoon, everybody. Thanks Anantharaman, thanks Manohar and the Disha team. It's usually stated that once you follow a great talk in any meeting, it has some positive and negative impact. So after a great talk, your platform may be good, but I think I need to talk in that standard so that I can keep up to pace with Dr. Singh, which is actually very, very difficult. Next, around 16 to 18 minutes, I would like to talk on this topic given to me, that is a scientific saga of GLP-1 receptor agonist from glycemic control to cardiovascular outcome. Now, this is the way situation are changing. Since are changing, initially we are concerned about the glucocentric approach, about the glycemic efficacy, and the later we know that it is important of the cardiorenal protection. So for the atherosclerotic cardiovascular disease, so for the heart failure, and so for the kidney disease concern, because these have a tremendous impact on our morbidity and mortality. And if you see the new coining of these abbreviations, this HbA1cV. So basically, we are talking both glucocentric and organ protection centric one. These days, it is very important to put a disclosure medical legal reason. So I did participate with RCT's randomized clinical trials of the GLP-1 receptor analog and the cardiovascular outcome trial. I am a board member of some pharmaceutical company, but I do not have any share on them, and I take the responsibility of the text of this slide set. And these are the three headings I've decided to talk today. One is the decades of learning. What is the relationship between type 2 diabetes and the cardiovascular disease? Second thing, paradigm shift from the glucocentric to glucocardiocentric. And thirdly, the redefining the horizons of diabetes management, and in the new guideline, what is the place of the GLP-1 receptor analog. So this slide you must have seen a number of times. So basically, some of the landmark trials like an UKPDS, Accord, Advance, and VADT, they are the recruited type 2 diabetes. And we have two categories. One is the initial result and one is the open label was. There's a long-term follow-up. So same people participated in the trial 3 or 5 years, and then after the trial finished, they have been observed as a follow-up of them. So as it clearly showed that microvascular benefit for good glycemic control is uniform, but not macrovascular disease. And then we came to know that if you continue this good control over long term, and we do see the improvement in the cardiovascular outcome, and that's very, very important. That's very, very important. And the mortality, in case of mortality, also come down. Other than one trial, which Accord, which tried a very tight glycemic control, and it worsened the cardiovascular mortality. But the fact remains is that once we try to get a tighter and tighter glycemic controls, for example, in this slide, the light blue is the standard treatment, deep blue is the intensive treatment. So once you get a tighter and the tighter control, your chance of severe hypoglycemia worsen. And this is probably a reason why we get more cardiovascular illness or death from some of the trial. And this actually is a trial from the advanced trial. But the fact remains is that whether it is an unstable angina or a myocardial infarction or a heart failure or a stroke or a peripheral vascular arterial vascular disease, so the risk of all these atherosclerotic cardiovascular disease is more in people with type 2 diabetes than in the general population. So once we are treating a patient of the type 2 diabetes along with glucocentric approach, we need to do something to prevent the atherosclerotic cardiovascular disease. And this is what sort of a landmark. If you see some of them, it's pretty scary. In year 2000, 4.6% people adults with a 32% cardiovascular disease. Now here 2017, it became 424 million. And obviously the projection of the 2045 is very scary. Also, but one particular study, the CAPTCHA study, which was quite clear to find out that 1 in 3 people with the type 2 diabetes has cardiovascular disease. And of these, 9 out of 10 are atherosclerotic cardiovascular disease. And 2 out of 10 are only on glucose lowering agent, the treatment of diabetes with a proven cardiovascular benefit. That means 80% of the people, despite they have atherosclerotic cardiovascular disease, they are not on a diabetes medication, which is a proven benefit of the cardiovascular system. That's what we are trying to take the glucocentricity to organ protection centricity to go. And despite we know very clearly the different guideline, as I will be telling some of the slides, that GLP-1 receptor agonists, they are preferred in the people with the type 2 diabetes with atherosclerosis. Now, if you move towards our changing the focus, so what we see from the LEADER trial, which is liraglutide, once in a day injection of a GLP-1 receptor agonist, which showed a wonderful benefit so far the glycemic, so far the cardiovascular protection is concerned. Though any of these trials obviously will have to show the glycemic benefit because they are diabetes molecule, and it is very clear comparing from exenatide, lixisenatide, liraglutide, dulaglutide, albiglutide, semaglutide is a good amount of HbA1c control, probably even up to the extent of 1.5% by meta-analysis of the different trial. And also, other than glycemic benefit, they uniformly does 2 things, this group of things. One is that they reduce the systolic blood pressure. It may sound that 4 millimeter, 2 millimeter systolic, diastolic, what is the great about that? But the fact remains that even if a little bit reduction of the systolic and diastolic blood pressure has a tremendous impact on atherosclerotic cardiovascular disease. That's our GLP-1 trial and the SGLT2 inhibitor trial showed. Also, they do something good for the postprandial lipids. We know their role for the atherosclerosis. And this is the same thing coming about cumulative benefits. So if you reduce 4 millimeter of blood pressure, you prevent 12.5 cardiovascular event. If you reduce 1 millimole of LDL cholesterol, that is around 28 milligram, you prevent 8.2 cardiovascular event. If you reduce your HbA1c 0.9%, you prevent 2.9 cardiovascular event. You see that out of these 3 parameters, reduction of the HbA1c, reduction of the LDL cholesterol, reduction of the BP. So BP has a tremendous impact to prevent the cardiovascular disease, and we should all be very aggressive in the people with a risk factor or cardiovascular disease to control the BP as tightly as possible. We all know inflammation plays a big role in having this all cardiovascular event, and our sensitive markers are there for different inflammation, or the reactive oxygen species, macrophages, and all these factors are responsible to obstruction or prevention of these are responsible for benefit from the atherosclerotic cardiovascular disease. And here we see that anti-inflammatory effect, sort of a bench to bedside, if you want to tell. That's liraglutide, semaglutide. These 2 important molecules for the GLP-1 receptor analog are causing the reduction of the inflammatory pathway. Reduction of the body weight, reduction of the plaque, the cardiovascular risk, reduction of the triglyceride, and so on. We have a marker. This marker is highly sensitive C-reactive protein for the inflammation. And the trials over the showed very clearly whether it is a liraglutide whether it is semaglutide or exenatide, there is a reduction of hsCRP. And also with all the diabetes molecule, the reduction may be a bit modest, but with the liraglutide, a good amount reduction is there. But interestingly, you see rosiglitazone, which has been withdrawn, is also reduces the high sensitivity CRP count. So at the end of the day, the benefits can be by the direct effect like a nitric oxide, ICAM, BCAM type of pathway, or the vascular smooth muscle prevention, proliferation prevention, inflammation prevention, decrease in the lipid accumulation, and the indirect way by the glycemic control, by the weight reduction, and the blood pressure benefit. And that's what we believe the GLP-1 receptor analog are good. Not only that, there are proof of concept trial are there, small individual, small number of people participate in the trial showed that even if you give the GLP-1 immediately after STMI, that is STMI and non-STMI, ST elevated myocardial infarction, you see the benefit on the heart point of view. That is probably a direct action you can see. So at the end of the day, if you talk about the course of cardiovascular disease continuum, you see the benefit with increased glucose uptake by the heart, the vasodilatation, improvement of the muscle tone, reduction of the ischemic injury, reduction of the infarct size, improvement of the LV function, reduced cardiac remodeling and decrease in the heart failure, and reduction of the risk factor like BP, cholesterol, obesity, weight loss, reduction of the inflammation as interleukin-6 and hsCRP, apoptosis gets delayed, endothelial function improves, platelet aggregation reduced, and all these causes of improvement in the atherosclerotic and also increases the plaque stability. So on the whole, it's a very cardioprotective action. So what about the guidelines telling? We have different guidelines now. Every year, everybody gives a guideline, whether you are doing ADA or ESC or ESD or something. Ultimately, as you see, most of the guidelines now started telling after the LEADER trial published in 2016 that GLP-1 receptor analog has a proven benefit of the cardiovascular system. And that's what exactly the guidelines showed. Initially, you give metformin lifestyle. If there is atherosclerotic cardiovascular disease, your GLP-1s comes here. After metformin monotherapy, even before monotherapy, it comes here. So it is important that we need to consider this molecule, not only people who have atherosclerotic cardiovascular disease, but also for people with a risk factor for atherosclerotic cardiovascular disease. Okay. So two molecules have been shown the proven benefit. One is SGLT2 inhibitor, one is the GLP-1 receptor analog. 2020 ACC expert consensus, everything the same thing is telling. So we are telling that address concurrently both the glycemic status and the risk reduction from the cardiorenal continuum. That is ultimately our information to give, thinking of giving GLP-1 much early rather than leaving it for the later. Now, we are end of the 20. Now only I think 3 or 4 days back, we have the statement, the standard of care, the ADA 2021. It usually comes first week of January. This time we got it now only. So here, every time they need to make some changes. Otherwise, people will think it is a photocopy. So everywhere you see here, last time the heart failure and the chronic kidney disease are clubbed together. Now this time they have separated. Essentially, otherwise there's not much change. There is a little changes there, but not much change. So essentially, what we are taking, we are telling metformin lifestyle. If the people have a very high risk for atherosclerotic cardiovascular disease or chronic kidney disease or heart failure, even without metformin, you can choose of these two medicines. Think of choosing. One is SGLT2 inhibitor, particularly for atherosclerotic cardiovascular disease. If you have a heart failure, your first is SGLT2 inhibitor, then GLP-1 receptor analog. If you have a chronic kidney disease, you pick up SGLT2 inhibitor, which have showed the renal benefit in cardiovascular outcome trial. And now, because of say DAPA security type of data is available, then people with a proven benefit of chronic kidney disease, and then you add GLP-1 receptor analog. Obviously, if you take up the line of reduction of hypoglycemia, GLP-1 receptor analog will be there. If your weight loss is your concern, GLP-1 receptor will be there on the top on the list. And but cost, whenever the cost is an issue, it is going to be a bigger problem. So in summary, a comprehensive diabetes management needed, not only just a glycemic control, but also treatment of the atherosclerotic heart disease or people who have a risk factor, so that mortality and morbidity from the atherosclerotic cardiovascular disease comes down. And we are very clear that GLP-1 receptor analog, other than the glycemic benefit, cardiac benefit, it causes low hypoglycemia or no hypoglycemia, and it causes weight loss, and it is important for reduction of the different inflammatory parameter. And those are the things probably we think responsible for cardiovascular benefit. And very clearly, liraglutide in cardiovascular outcome trial showed a benefit for the cardiovascular system. And not surprisingly, 2016 onward, most of the guidelines, but most of the people in the world has picked up GLP-1 receptor analog is for benefit in the cardiometabolic issues. Thank you very much. As you just heard talk on the vaccine, I think as Corona has not gone, 2020 will go, but we need to all to be very safe and healthy and to continue to take our precautions as before. Thanks very much for your patient hearing.
Dr. Manohar, are there any, before the others ask question, I want to ask one question to Dr. Arpan, or rather a comment. So, sir, we usually start SGLT2 inhibitor following an MI or a angioplasty. I mean, we are always discharging patients, as physicians, endocrinologists, but we do not usually start the patients on GLP-1 analogs. I mean, that is not routine practice as of now. What is the inertia? What is it that is holding us back from doing that? I mean, would you think that that's a standard this thing? I mean, we are holding ourselves back from doing that. I mean, if you see the guidelines, we should put all MI patients, angioplasty patients 1 or 2 weeks into the treatment on a GLP-1 plus a SGLT2 at least. And of course, they are all affordable patients also, even from bigger hospitals discharges.
Perfect. Your observation, absolutely perfect. I totally agree with that. So basically, as you tell most of the meeting, we are thinking of 3 factors. One is pipes, pumps, and filter. Okay. So if there's a pipe, certainly GLP-1 receptor analog will come over SGLT2 inhibitor. If the pump, heart failure is an issue, SGLT2 receptor analog, SGLT receptor blocker will be above GLP-1 receptor analog. And if you are taking kidney, again also SGLT2 probably will come before GLP-1, although both of showed benefit. But according to me, the main reason most of the time after MI, which is basically pipes, atherosclerotic cardiovascular disease, people are getting SGLT inhibitor because GLP-1 receptor at this point is available on only an injection, and it requires some time and to convince the people that this is what is benefit. But certainly, so for the evidence is concerned, if there is an atherosclerotic cardiovascular disease like an MI, after discussion, GLP-1 receptor analog should come before SGLT inhibitor. Absolutely right. I believe injection is an important factor. First one. Second thing is the cost is also an important factor.
ಏನಾಯ್ತಲ್ಲ ಹೊಟ್ಟೈತಾ?
Dr. Manohar, you
have to mute.
You are not muted, Dr. Manohar.
Yeah. So if there are no other questions, shall we proceed to the next talk? Actually, we need to get back Dr. Jagdish. The next talk, the psyche and the soma are inseparable. So to complete the COVIDology capsule, we have this talk by Dr. A. Jagdish. The chairperson is our clinical psychiatrist, psychologist, Satish Kumar. And the topic is unlocking the depression in this pandemic. Very, very important topic. I don't know if Satish is around.
Yes, sir.
Yes, sir. So, Dr. Satish, if you could introduce Dr. A. Jagdish. Sure. Before that, Satish has been working closely with us, and in fact, he was instrumental in. We did a large study. I think it should be the largest in the world of assessment of mental health status during the pandemic with respect to healthcare professionals. So he was a great help, and I think it's in print. I hope we get it soon. And he has always been helpful for many of our colleagues. He had started a group, and we were helping out many of the nurses and others, even doctors, like I don't have any shame in acknowledging that even I was going through a lot of stress in this pandemic, and he was helping me out with my mindset also. We are glad to have you, Satish, and over to you.
Thank you very much, sir. So as Dr. Manohar was saying, we had this assessment, and that is because he gave me an idea about assessing, and I think that was very much in need of the hour, because we all know about the pandemic, which is definitely now even called as a mental health pandemic. There is definitely it's converting into a mental pandemic, because I think there are a lot of people who had amazing lifestyle, people who were into yoga, people who were very healthy earlier, and now are very surprised that I cannot believe I'm developing depression or even anxiety for that matter. So people are surprised to have developed psychological issues. According to them, they are like headstrong, and they never believe that they are prone to it. So it doesn't happen that way. So that is what depression or anxiety is all about. It can definitely happen to anyone, even simply because of the burnout, even with working extra hours. So on those lines, I think it made a lot of sense. So it's in the press, in the Plus One journal. And other than that, we kind of also work with nurses, especially in terms of giving them counseling, especially for those people who were quarantined, and as well as people who had positive COVID-19. Yes, sir. So Dr. Jagadish has always been one of the most eminent psychiatrists in India, and always looking forward to Dr. Jagadish. He is like a role model for all the people in the mental health professionals. Yes, sir. So if you could start, please.
Over to Dr. Jagadish. Sir, you can share the screen. I think he has a mild technical glitch. We'll give it 2 minutes. Sorry for this.
Sure.
Sir, mail ಮಾಡಿದೀನಿ ನೋಡಿ, ಅದ್ರ ಮೇಲೆ ಕ್ಲಿಕ್ ಮಾಡ್ಕೊಳ್ಳಿ. ಮೇಲ್. ಫೈನ್, ಓಕೆ. ಸತೀಶ್, Satish,
Yes,
can you
sir.
just brief on our results till then?
Sure, sir.
Yeah.
So we used a couple of assessment tools. So the first one was called as secondary traumatic stress scale. So this particular tool is built especially on the on the healthcare workers. So there are some studies which is done on the healthcare workers, but we don't have this tool being used on the on the healthcare workers, especially in any pandemic. So that's the difference between the other studies. We saw that as the baseline. I mean, we compared that with the baseline from the other studies. So our results showed that people definitely had PTS factors, especially the avoidance was very high. So the anxiety part, the PTS part was very high. Along with it, we also saw one more factor called optimism. So this study was more both ways. I mean, we were looking at the vulnerability factor as well as the adapting factor, that is the coping factor. So we saw that people who had low optimism, so there were 80% of doctors.
Share screen.
Hello, sir. There were 80% of the healthcare workers in India that the study shows have low optimism. So pessimism was very high. So the negative thoughts, the pessimism was very high, along with the secondary traumatic stress. Sure. Over to you, sir. Thank you so much. Hello, Jagdish, sir.
Share. Share ಕೊಡೋದಾ? Yeah. ಕೊಡಿ. Hello. Sir, you can share the screen. Yeah. I'm sliding now. I've already shared.
Welcome, sir, and you can proceed, sir.
Thank you.
Glad to have you on board. Yeah.
Hello.
Yes, sir. You're audible.
Yeah. Yeah. Thank you.
Sir, I think you are listening from the YouTube. You can stop it and you can proceed.
Yes. Yeah.
Yes.
Thank you very much for giving me an opportunity to Disha and team. Extremely glad. I was just following all the other speakers since morning. But today I have a special population. What is that? If everybody has focused on one area, something like on a individual. A lot of our friends have discussed about many things in today's program. But what we have to do in psychiatry is thank you. So now unlocking the depression in the pandemic is a very big topic. So I decided who are all the people who are affected with this. If we take the history, yes, all major pandemic being associated with severe environmental stress affected human way of thinking and human psychology health. Hello, am I here? Yeah. So systemic studies aimed at identifying pathogenetic mechanisms responsible for the onset of psychiatric diseases following viral epidemics began in 19th century. It is not today. When the Spanish flu started, people had psychological.
Sir, you must have opened your YouTube at the back end. So can you just close that so it won't be like two voices for you?
Can I start now?
Yes, sir, you can continue.
YouTube. You can stop the YouTube from the.
Sir, you can continue to speak, sir.
YouTube.
You can switch off the YouTube and continue to speak here.
For me? Am I? Hello? Oh, Amok, 1 minute, 1 minute. Am I having two things? Sorry. Hello?
Yes, looks like, sir. YouTube also, if you are having, you can switch it off.
Okay, okay. 1 minute. Shall I continue?
Yeah, now you can continue with this Zoom.
Okay. Amog? Amog?
Yeah, you continue, sir.
Okay.
Now we have opened the Zoom platform. Both are running.
Extremely sorry. 1 minute, 1 minute. Adya, come here. Because I am having both YouTube and this. Stop this. I want only the Zoom to go. You stop. Why it's not sharing?
Stop sharing. Huh? You want to stop sharing?
Yeah.
Stop sharing.
No. 1 minute. Just stop YouTube. YouTube stop.
YouTube. Open
1 minute.
Open in the YouTube.
Wait, Adya.
Clear.
What's not going on?
Sir, is it your phone switched on?
You are receiving something.
Now unmute yourself in the Zoom, sir. You have to unmute, sir, in the Zoom.
ಅವ್ರನ್ನ ಅನ್ಮ್ಯೂಟ್ ನಾವು ಮಾಡ್ಬೋದು ಕೂಡಿಗೆ ಅನ್ಮ್ಯೂಟ್ ಮಾಡುತ್ತೆ ನೀವು ಅನ್ಮ್ಯೂಟ್.
Can I start now? Go ahead. Now I'll share the screen. Where is it?
Yadu.
Slides. Wait.
Sir, unmute ಮಾಡಿ ನಿಮ್ದು unmute voice.
There is a notification.
Now, is it clear?
Yes, clear, sir.
Okay. So, so that shall I now? Again, double voice is coming.
Is your YouTube or any other thing is open in your laptop or maybe in your phone, which you can hear in your,
No, madam. I have switched off my phone. Laptop. I am on the laptop only.
Yeah. So you must have logged in from the delegate link as well.
Yes, yes, yes. I was earlier. Okay.
So please close that window.
How?
Just go to the Google Chrome and close that delegate window.
Can we schedule it next and we can take the next speaker? Hello. Sorry for this technical glitch. I think what we will do is we can reschedule this talk next. The next speaker also is ready. So we'll move on to the next talk and then we can take Dr. A. Jagdish sir's talk next. Or is it ready? Dr. Ganesh?
Yes, sir, I am there. I am here.
Yeah. For the next talk, this is about optimizing cardiorenal metabolic risk modification in type 2 diabetics. Learning of 5 years post-MPAREG outcome. To chair this talk, we have Surekha Shetty. She is an associate professor of Karnataka Institute of Endocrinology and Research. She has done her MD medicine from BMC in 2006, non-DM senior residency in endocrinology at Ramaya, and MSc endocrinology Southwell University. Over to you, Surekha.
Thank you so much, Dr. Manohar. I hope I'm audible.
Yes.
Okay. At the outset, I would like to congratulate the Disha team for this wonderful session. And I really appreciate the novel title, Chronology. And I must congratulate all of you for focusing on the newer drugs with focus on specific topics. And to talk now on optimizing cardiorenal metabolic risk modification in type 2 diabetes, learning post 5 years MPAREG outcome, we have with us Dr. Ganesh HK. He is an endocrinologist, MD and DM endocrinology, and he is professor and head at AJ Medical College, Mangalore. He is also part of EndoDiab Clinic. He has several publications to his credit and has received AR Seth Award for Best Research Paper, and he has been trained at BARC also. I hand over the session to you, Dr. Ganesh HK.
Thank you, Dr. Surekha. First of all, I would like to thank Dr. Manohar and his Disha team for this wonderful event. So for the next 20 minutes or so, I'll be speaking regarding this topic, optimizing cardiorenal metabolic risk modification, what we have learned in the last 5 years, that is post-MPAREG outcome trial. So MPAREG outcome trial, we know, is one of the landmark trial which showed that anti-diabetics are not only helpful in reducing blood glucose levels, also to reduce the cardiovascular mortality. So let us see what we have learned in these last 5 years after the publication of MPAREG outcome trial. So if let us go into some of the basics, the continuum of cardiorenal metabolic risk. We can see here in this beautiful slide, everything that starts with the risk factors. The risk factors like diabetes, hypertension, obesity, dyslipidemia. because of all these things, there will be endothelial dysfunction, which leads to in the microvascular front, that is the small vessels, there will be microalbuminuria initially, then there will be frank proteinuria leading to chronic kidney disease, and finally end stage renal disease. In the large vessels, big vessels, there will be atherosclerosis, which leads to coronary artery disease. Finally, the all macrovascular complications like myocardial infarction, stroke, leading to LV remodeling, and finally heart failure. So end stage renal disease and heart failure and MI are the final outcomes. So how we can modify, how we can reduce this risk factors, not only by controlling glucose, how we can achieve this reduction of this final outcome. That is the issue we have to address. So let us look into some of the data of empiric outcome trial. Empiric outcome trial has clearly shown that the antidiabetic empagliflozin, that is SGLT2 inhibitor, is very, very helpful in reducing the cardiovascular deaths. So it showed that there will be sustained around 38% relative risk reduction as far as cardiovascular death is concerned. So you can see in this graph, so the red one is being empagliflozin and the black one being placebo. So the differentiation in curves starts very, very early. So it starts in within 3 months, within 3 to 6 months, the differentiation starts. We can see the separation of curves here. So the improvement in cardiovascular outcome starts very, very early as far as SGLT2 inhibitors or empagliflozin is concerned. So it not only that, it consistently reduces the risk of CV death regardless of the cardiovascular disease manifestation. Let it be single vessel coronary artery disease, multi-vessel coronary artery disease, history of CABG or prior MI, all these set of patients, you can see meaningful reduction in the cardiovascular death. You can see in this graph from 5.5 to 4%, 6% to 3% in multi-vessel CAD. In patients who had CABG, from 5.7 it reduced to 3%. So there is significant reduction across the spectrum of cardiovascular diseases. So not only that, so in patients who had a stroke, peripheral artery disease, or a history of atrial fibrillation or prior heart failure, even in them, I'll not go into the figures. You can just glance through the figures here. So they reduce significantly across these problems like peripheral artery disease, stroke, heart failure, or atrial fibrillation. There is significant or meaningful, statistically significant reduction in the cardiovascular death. So we can say clearly that in patients who are having coronary artery disease or large vessel disease, there is significant meaningful reduction in cardiovascular death when we use empagliflozin as antidiabetic agent. So patients who are not having heart failure or not requiring loop diuretic, in patients with atherosclerotic cardiovascular disease with the type 2 diabetes, not requiring loop diuretic or not having heart failure, even them, there is significant reduction in cardiovascular death, hospitalization for heart failure, or all-cause mortality. There is significant reduction or in all these categories. People who are not having heart failure or not having loop diuretic at baseline. So even patients with atrial fibrillation, so empagliflozin consistently reduce the risk of cardiovascular events. This is also from empiric data only. So we can see here in patients with atrial fibrillation, the risk of cardiovascular death reduces here. So a significant reduction, hazard ratio 0.52, even in hospitalization for heart failure, cardiovascular death, or all-cause mortality. In set of patients who are having atrial fibrillation in the beginning, so empagliflozin reduces the cardiovascular death. So one of the very, very important point, the benefit for CV death or hospitalization for heart failure occurs early in the therapy. So you can see the graph here, separation. As early as day 27, the hospitalization for heart failure, the reduction starts as early as day 27. That is within 1 month of therapy, there will be reduction in hospitalization for heart failure. So significant benefit, it starts from 27th day. So that means if you start a patient on empagliflozin today, the chance of developing heart failure will reduce even at 1 month of therapy. So even time to CV death, the graph starts separating at day 59, that is 2 months. Time to CV death, the separation of the curves between empagliflozin and placebo starts in 2 months. Time to first hospitalization for heart failure, very early, that is half a month, 15 days, the hospitalization for heart failure, the curve starts separating. So we can see empagliflozin significantly reduced the risk of cardiovascular outcomes in patients who are already having established cardiovascular disease. Patients who already had an event like cardiovascular disease, the MI, so there is significant reduction. So you can see the forest plot here, it clearly favors empagliflozin. major adverse EV events, myocardial infarction or coronary revascularization was much better with an empagliflozin arm compared to placebo. So let us look into the numbers. If we treat 11 patients with atherosclerotic cardiovascular disease and type 2 diabetes with empagliflozin on top of standard of care, one additional cardiovascular event can be prevented over 3 years. So by 3 years, we can prevent one additional cardiovascular events by treating 11 patients. This is very, very significant number. If you just treat 11 patients, you will prevent one event by 3 years. So not only cardiovascular deaths, even the patients who are having CKD or renal problems, they also get significant benefit with empagliflozin. So this is actually KDIGO severity scoring of CKD. You can see here this left hand side. So this is based on EGFR from more than 90, G1, the G5, it's a EGFR of less than 15. You can go through the table. So G1 more than 90 EGFR, and G2 60 to 90 EGFR, and G3 between 45 to 30 EGFR, G4 15 to 30, and G5 less than 15 EGFR. Similarly, depending on the albuminuria category, we can make it to A1, A2, and A3. So A1 normal or mildly increased albuminuria, that is 30 to 300, and less than 30. A2 is moderately increased, that is 30 to 300 microgram per milligram of creatinine, and severely increased, that is frank proteinuria. We can you can see here this being the normal, and this reddish being the most severe chronic kidney disease. Why it is important for this talk. In empiric outcome trial, it is very, very clear that in patients who are having either across the spectrum, low risk of CKD risk category, or moderately increased risk, or very high risk, across the category, you can see the improvement in the CKD events. The incident of or worsening nephropathy, it's significantly reduced. You can see low risk hazard ratio is 0.67, that is 33% reduction in nephropathy or progression of nephropathy. And very high risk here also 68.68 is hazard ratio, 32% reduction in progressing of nephropathy. So overall study population, there is a 39% decrease in the risk of nephropathy, progression of nephropathy, which is supposed to be very, very significant. So let us look into some of the other cardiovascular outcome trials overall. So this is a comparison: EMPAREG, CANVAS, DECLARE, CREDENCE, and VERTIS CV. So among these outcome trials, EMPAREG outcome and VERTIS CV trials, they are already had an event. All patients in these two trials had already either MI or previous CABG or PTCA. Such patients were included. Whereas dapagliflozin, DECLARE TIMI or CANVAS, there were the cohort of patients with multiple risk factors were also involved who didn't have an actual event in the till now. So let us go into some of the results. So the MACE risk reduction, that is a primary endpoint in all the trials. The major adverse coronary events risk reduction. You can see here patients who had an atherosclerotic cardiovascular disease. The EMPAREG outcome trial, the hazard ratio significantly reduced, the 0.86, statistically significant. You can see the forest plot. The VERTIS CV trial being the neutral. There is no improvement in, it is not superior, neutral. So if you look into the I-square here, that is when we compare among the trials, ideally we are not supposed to compare the trials because their inclusion criteria, exclusion criteria, everything will be slightly different. So we are not supposed to compare across the trials, but so for our understanding purpose, we can. So, but we can't draw 100% conclusion from that, but we can use this I-square. When the I-square is 100%, that means the trials are not uniform. The results are not uniform. And the I-square is near to the 0%. 0% means very good. All trials are comparable. So less than 50% seems to be okay. So here, patients with atherosclerotic cardiovascular disease, we can see the EMPAREG outcome, significant reduction. CANVAS also significant reduction, but DECLARE TIMI and CREDENCE were okay. And patients without atherosclerotic cardiovascular disease, the CANVAS, the EMPAREG and VERTIS CV didn't have such patients. Patients all had ASCVD. So here, CANVAS, there was no significant reduction, 0.98, and only CREDENCE trial showed significant reduction. So once again, here it's not comparable because I-square is 56.5%. So Cardiovascular death risk reduction with the SGLT inhibitor in type 2 diabetes cardiovascular outcome trials. Again, the total decreased risk for cardiovascular death. So we can see here patients with atherosclerotic cardiovascular disease, the empiric outcome showing a 0.62 hazard ratio, that is approximately 38% relative risk reduction. So I square is more than 50. Substantial heterogeneity is there across the studies, showing that. So this is not comparable. So that means other trials are not that great. The results are not that great. So whatever we are getting is mainly because of the empiric outcome trial. And patients without atherosclerotic cardiovascular disease, you can see here CANVAS, declaratomy, and credence all showing declaratomy not showing a major benefit, but CANVAS and credence some benefit. Credence is showing good benefits. So this is comparable actually, I square being 0%. So let us come to all-cause mortality. Comparison of all-cause mortality across the trials. So once again, empiric outcome scoring the best here. So I square is 53%, once again showing heterogeneity, so not exactly comparable. So empiric outcome showing the best results. And patients without atherosclerotic cardiovascular disease, I square is 0%, that means comparable, and all are showing good benefits, but CANVAS showing the best benefit. Canagliflozin is being the best. So let us go into the other aspect, hospitalization for heart failure. So consistent improvement in hospitalization for heart failure was seen across the SGLT inhibitor studies. So I square being 0%, both with the atherosclerotic cardiovascular disease and without atherosclerotic cardiovascular disease, both I square being 0%. That means comparable and all showing benefit across the this one. Even Vertis CV, which was a neutral trial, that also showed benefit for ertugliflozin in Vertis CV trial. So we can say patients with atherosclerotic disease or without atherosclerotic cardiovascular disease also, SGLT2 inhibitors are very useful in reducing hospitalization for heart failure. So let us summarize. In patients with atherosclerotic cardiovascular disease and type 2 diabetes, let us go into the major like primary endpoints. Major adverse cardiovascular events. There was significant benefit in empiric outcome with empagliflozin and CANVAS, canagliflozin. Cardiovascular death, the significant benefit was seen only with empagliflozin, and hospitalization for heart failure was benefits were seen in all the 4 trials across the studies. So let us go into, from the cardiovascular point of view, we'll move on to the kidney points, kidney disease reduction, CKD reduction, how the SGLT2 inhibitors fare. So the consistent improvements in clinical kidney outcomes were seen across the SGLT2 inhibitor studies. You can see here the patients with atherosclerotic cardiovascular disease, all empiric outcome, CANVAS, DECLARE, credence, Vertis CV, all showing benefits. Some of them a little better compared to the others, but the overall hazard ratio being 0.64, that is 36% relative risk reduction, and I square being 34.4%. So we can compare the studies. The patients without atherosclerotic cardiovascular disease, once again the benefits were seen across the studies. So all studies were beneficial. So clinically meaningful kidney outcomes were seen even patients without type 2 diabetes. So till now we are seeing whether atherosclerotic cardiovascular disease is there or not. That was the point of comparison. Here now, in patients who are not having type 2 diabetes, even in them, SGLT2 inhibitors were used, and it was found that there is meaningful kidney outcomes. It is shown that they reduce the proteinuria, microalbuminuria to macroalbuminuria, or frank proteinuria is reduced with SGLT2 inhibitors. That might be the reason, or some other reasons also which are postulated. So clinically meaningful kidney outcomes are seen even in patients without type 2 diabetes, like EMPEROR reduced, DAPA CKD or DAPA heart failure, significant reductions were seen. And pooled estimate, there is a significant benefit. You can see the hazard ratio, forest plot, everything 0.5 or 0.56 or 0.7 showing significant benefit. So this is a e-poster presentation from ADA 2020, effectiveness and safety of empagliflozin in routine care patients, interim results from empiric comparative effectiveness EMPRISE study.
I have RISE.
So EMPRISE real world evidence involved more than 78,000 patients. So we can see around empagliflozin was compared with DPP4 inhibitors, and cardiovascular disease was seen in approximately 28% of the patients. Both empagliflozin arm and DPP4 arm at 28% of the patients had cardiovascular disease. So Empirics real world evidence clearly demonstrated that there is significant difference between empagliflozin and DPP-4 inhibitors as far as hospitalization for heart failure and mortality benefits are concerned. We can see here the broad hospitalization for heart failure, there is 41% decreased risk in empagliflozin arm compared to the DPP-4 inhibitors, and all-cause mortality, that is 48% decreased risk in empagliflozin compared to DPP-4 inhibitors. So in older adults, that is elderly or more than 65 years of old with the type 2 diabetes, Empirics study has demonstrated consistent benefits as far as hospitalization for heart failure or mortality is concerned. You can see here, there were 11,579 patients, large numbers in each group, and 48% of patients in each group had cardiovascular disease, and mean age was approximately 72 years. And you can see all-cause mortality was significantly reduced, hazard ratio being 0.52, that is approximately 48% relative risk reduction for all-cause mortality, and even hospitalization for heart failure, sorry. Even hospitalization for heart failure, there was significant reduction, that is approximately 33%, and it was statistically significant. So overall, empagliflozin improves kidney outcomes in patients with type 2 diabetes. We can see here major adverse kidney events, that is just like MACE, there is MAKE, major adverse kidney events over 3 years. That is composite EGFR decline by more than 50% and development of ESKD or all-cause mortality. There is 32% lower risk for major adverse kidney events with empagliflozin compared to placebo. So approximately 32% lower risk reduction for nephropathy as far as concerned. It's very good because till now we are having only AC inhibitors and ARBs as far as the reduction in nephropathy progression is concerned. Right now we are having other class of drugs, SGLT inhibitors, which looks like even better than AC inhibitors or ARBs in preventing the progression of nephropathy. So there is a real world evidence for this MAKE also. So real world evidence from the Scandinavian data. So we can see here comparison between SGLT inhibitors versus DPP-4 inhibitors. We can see here serious kidney events were much lesser in patients who are taking SGLT2 inhibitors compared to DPP-4 inhibitors. We can see the per 1,000 patient years, the development of serious kidney events is approximately 2.1 for EMPA compared to 6.2 for DPP-4 inhibitors. And we can see here dapagliflozin also showing the good results as far as serious kidney events are concerned. So this is a KDIGO executive conclusion. From the KDIGO, they have come up with the guidelines saying that after physical activity, nutrition and weight loss, we are supposed to start metformin plus SGLT inhibitor as the first line therapy. Only if the EGFR is less than 30, we are not supposed to use metformin. And if the EGFR is less than 45, we are supposed to reduce the dose of metformin. And SGLT inhibitor, if the EGFR is less than 30, we are not supposed to initiate. More than 30, we can use. And if the patient is undergoing dialysis, we can discontinue. And on top of that, if the patient is not getting HbA1c reduction, then we can go for other drugs like GLP-1 receptor agonist, DPP-4, or sulfonylureas, or something, all other class of drugs. So in patients with heart failure with reduced ejection fraction, empagliflozin reduces the risk of CV death or hospitalization for heart failure, regardless of type 2 diabetes. This is shown in Emperor reduced trial. So there is 25% relative risk reduction for cardiovascular death or heart failure hospitalization, significantly reduced. Number needed to treat is only 19 over 16 months. If we treat 19 patients over 16 months, we can reduce cardiovascular death or hospitalization for heart failure. And first and recurrent heart failure hospitalization also, there is 30% relative risk reduction, and EGFR slope also improved or significantly better in patients who are taking empagliflozin compared to placebo. So we can say SGLT2 inhibitors consistently reduce the risk of cardiovascular death or hospitalization for heart failure regardless of presence of diabetes. So Emperor reduced and DAPA heart failure significantly showed with diabetes or without diabetes, there is significant reduction in hospitalization for heart failure or cardiovascular death. So the SGLT2 inhibitors, the benefits are not seen only in diabetics, so it's seen in other categories of patients also. So it's not only the glycemic control which is involved, there are other mechanisms or other benefits are also seen there with empagliflozin. So that is the reason we see the benefits even in non-diabetics. So if we go through the development of or the chronology of development of SGLT2 inhibitors or the various various trials from September 2015 to September 2020. The EMPA-REG was published in 2015. So after that, European Society of Cardiology recommended that empagliflozin recommended in diabetes to prevent or delay the onset of heart failure. And ADA 2007, once again, empagliflozin was recommended for atherosclerotic cardiovascular disease with diabetes as a second drug from after metformin. And CANVAS, after CANVAS published in 2017, ADA came up with a statement that either EMPA or CANA can be used in atherosclerotic cardiovascular disease patients with diabetes. And after credence in 2019 and declared TIMI in 2018, patients with the heart failure with the diabetes, any SGLT2 inhibitors can be used, or in ASCVD risk in diabetes, SGLT2 inhibitor with proven benefit, that is EMPA or CANA, can be used. And in ESC/EASD guidelines 2019 say that when there is increased severe risk with diabetes, we have to use SGLT2 inhibitors for reduction of cardiovascular event. In ASCVD with the diabetes, empagliflozin to be used for the risk to reduce the risk of death. And patients who are having hospitalization for heart failure, increased risk of hospitalization for heart failure or cardiovascular death, we can use with the diabetes. We can use SGLT2 inhibitor. And after the publication of EMPEROR Reduce, Vertis CV, DAPA-CKD, DAPA heart failure, everything in 2020, the KDIGO guidelines came up saying that SGLT2 inhibitors should be used as a first line for CKD in type 2 diabetes. And ESC/HFA update in 2020, they stated that for hospitalization for heart failure prevention in type 2 diabetes, we have to use either CANA, DAPA, EMPA, or ertugliflozin. For decreased risk of hospitalization for heart failure or CV death in heart failure with reduced ejection fraction, we can use either DAPA or empagliflozin. So this, I think all of us know, this is the ADA standard of care, but the 2021 guidelines, they say that for patients with indicators of ASCVD, CKD or heart failure, consider SGLT2 inhibitor or GLP-1 receptor agonist with proven benefit independent of baseline HbA1c. Previously, it was thought that if they are not getting control with metformin, then you are supposed to use SGLT2 inhibitor. But now they say that independent of HbA1c, if they are prone for developing any of these atherosclerotic cardiovascular disease, CKD or heart failure, they are supposed to use metformin. Even ESC guidelines, they tell the same thing. I will not go into the details. In type 2 diabetes, drug naive patients who are having atherosclerotic cardiovascular disease or very high risk of cardiovascular disease, then you are supposed to start with either SGLT2 inhibitors or GLP-1 receptor agonist monotherapy. And if the patients are on metformin, irrespective of the glycemic control, even if with metformin, if they are well controlled, if they are high risk of atherosclerotic cardiovascular disease or heart failure, they are prone, then we are supposed to start SGLT2 inhibitors, whether or not their sugars are controlled. So European Society of Cardiology, they also state the same thing. EMPA, CANA or DAPA are recommended in patients with type 2 diabetes and CVD at very high risk of cardiovascular disease to reduce the cardiovascular events. Empagliflozin is recommended in patients with type 2 diabetes and cardiovascular disease to reduce the risk of death. So my last slide, Heart Failure Association of the European Society of Cardiology. There's a latest recommendation. They say that CANA, DAPA, or EMPA or ER2 have consistently demonstrated to be effective for the prevention of heart failure hospitalization in patients with type 2 diabetes and established cardiovascular disease or at high cardiovascular disease. So, for prevention of heart failure, either of these agents, EMPA, CANA, DAPA or ER2, any of these can be used to prevent heart failure. Dapagliflozin or empagliflozin are recommended to reduce the risk of combined risk of heart failure hospitalization and CV death in symptomatic patients with heart failure and reduced ejection fraction already receiving guideline medical directed medical therapy. That is, whatever they are taking. So if they are at high risk of developing cardiovascular disease or heart failure, we are supposed to start either DAPA or EMPA to reduce heart failure hospitalization as well as CV death. So thank you. Any questions? Welcome.
Thank you so much, sir, for elaborating the differences between the various trials. I have one question. Would we be right if we choose one drug over the other in these three drugs belonging to the class of SGLT2 inhibitors? Or are they all same?
This is a difficult question, madam. So
tricky question, sir.
So across the trials, we don't have the head-to-head data. But across the trials, so whatever the using that I-square statistical data, we can say that for reduction in cardiovascular death or all-cause mortality or atherosclerotic cardiovascular disease, empagliflozin is better. So, but hospitalization for heart failure, that is the only point, then anything can be used. But I also felt previously that all SGLT2 inhibitors are same, EMPA, DAPA or CANA, they are same. So I thought this is because of the inclusion criteria difference. So, but after the publication of the VERTIS CV trial, which inclusion criteria was same as EMPARIC trial, that is 100% patients had coronary artery disease or atherosclerotic cardiovascular disease. But L2-gliflozin surprisingly didn't show any benefit. It didn't show any superiority. So after that, I feel probably the empagliflozin is a better drug among this one. But 100% I can't say. This is my personal opinion.
Yes. Thank you so much, sir. I hand over this session back to Dr. Manohar
thank you.
for further talks.
Yeah. Thank you, Dr. Ganesh and Dr. Vijay Kumar. I'll be taking over from here. Thank you for an excellent talk, and Dr. Sureka, and thank you also. Before we go on to the go further, we'll go back to our Dr. A. Jagdish talk, which we missed in the previous slide. Dr. A. Jagdish, I think you are ready for this now.
Yes, sir.
Yes. So on to you, sir. Dr. Satish.
Yes, sir.
Yeah, you can take over, sir. Thank you.
Thank you. Thank you, everyone. Thank you for introducing me into this program, and thank you for the invitation. I would definitely call upon Dr. Jagdish to please start from here. And as introduction was already given, Dr. Jagdish, one of the most eminent psychiatrists in India from Abhaya Hospital. Sir, over to you.
Thank you. Without wasting much time, I would like to go on with the presentation. Extremely sorry for the delay. Unlocking the depression in the pandemic is the appropriate name, because it is not that one person who is affected. It is a group of people who are affected by this pandemic. Who are those people? Is it new? No. Historically, all major pandemic being associated with severe environmental stress affected human way of thinking and human psychological health. So systematic studies have aimed at identifying what is the main cause for this during even following viral epidemics began in 19th century, where Spanish flu was so pandemic. The eminent English doctor Henry Holland in the year 1839 proclaimed that flu was responsible for the future impairment of mental functions, almost in the same way of body. How body is affected, psyche is also affected during the pandemic. 80 years later, Carl Menninger confirmed that there is an association between viral infection and psychiatric comorbidity. So this is nothing new. It has become universally acknowledged that combination of systemic infection, viral neurotropism, and environmental stress factors or even induces development of psychopathological problems in an individual. So there is a combination of all these things. So who are the people who are affected with this? Healthcare workers who are in the front line, corona affected patients, family of corona patients, general public, and special population like migrant workers. What happened to our general public? What are the protective factors? What are the stress factors? So what the protective factors are: a good social support, financial stability, healthcare resources, having an insurance, safe workplace, wellness programs, adequate PPE, promoting diversity, and timely COVID-19 testing and health admission for if required. What are those stressors? One is severe illness, severity of the illness, hospitalization, witnessing death next to the patient, death of a loved one, extreme exposure to COVID details. When the TV channels started bombarding, we had a host of people coming, doctor, I just can't bear it. Please help me. I am not able to sleep. I'm so confused. I don't know whether I'm going to die tomorrow. Every day when I listen to news, I think tomorrow is my death day. So other than that, general stressors are COVID exposure or quarantine, especially in the initial phase, not now. When the quarantine started during the lockdown and the first phase of our treatment, there was a lot of stigma attached. Employment, income loss, working from home with kids, being a caregiver, and making difficult medical decisions, whether to shift to a ICU or not, etc., and inadequate PPE. So all these factors have contributed for the psychological problems in a common man. So what happened to our friends work from home? When the work from home started during the lockdown, it was like a honeymoon period. A lot of people felt, I have so much of time, I need not waste traveling to office, I can have more time with my family, I can be more productive. But as the days passed on, the people realize, oh God, this is not going to work. I am missing my schedule, routine, socialization, having interaction with my colleagues. And the major problem which brought in was communication problem. Especially if one spouse or one person in the family has a personality problem, the communication, so the argument is increased, the marital disharmony increased, and when both couple were working, parents were working, they had a conflict. Am I giving enough time to the child? Because child is also at home. Child also has to follow the instructions from the school online. So it was a great distress. At the end of 3 months, lot of articles published. It was not anymore a honeymoon. People had a lot of discomfort in terms of lack of exposure for exercise, socialization, time for themselves, and the companies expected, okay, you are at home, work for longer hours. And one more thing was fear of losing the job, so made them to work for longer hours and hard. So work from home brought its own baggage of communication problem and distress among people who are working at home. So next major population was the migrant population. This is exclusively special to my country. They have faced multiple hardships with financial factories closed down, workplaces shut down due to lockdown. Millions of migrants workers have to deal with loss of income, food shortages, uncertainty about their future, and with rumors they just wanted to get back to their native places. So in turn, it led to poverty. Poverty leads to worry, physical health, it affects physical health, early life conditions, violence, crime, all those things will work, and that will induce the depression, anxiety among those people. That in turn worsens productivity and their preferences, beliefs, economic decision, women empowerment, everything got affected. So migrant workers was one of the population which was tremendously affected psychologically. The very few psychological studies have been done. So at the end of the day, lack of resources and access to medical health, poverty contributed for the distress among the migrant workers. Next comes our healthcare workers. Across the globe, there was a lot of articles published. What happened to this group? Because they were the greatest, underwent a lot of stress among themselves. So same thing happened in India also. The health workers felt there's an increased workload and the stress levels went up, thus increasing the risk for mental health among the healthcare professionals. So they perceived risk and fear of getting COVID-19, because in the initial phase we were not knowing how it get affected, were positively predicted to have depression, anxiety, and stress. In addition to work stress, in India, some of the healthcare professionals have faced new problems, such as being verbally and physically assaulted by a mob. Even we have seen in Karnataka, places like Belagaum, etc. So apart from working for long hours, they have to take the abuses from the crowd also. So shortage in PPEs in the initial phase was also found to be a major concern among healthcare professionals. Improper training and guidelines also caused for this problem. So if you look at holistically, what was the cause for burnout among our mental health work professionals? Social distancing at work, wearing masks, not eating together with our colleagues, with less camaraderie and social support than we used to have in the past. So at least they used to have a cup of coffee together after rounds, after a surgery, after OPD, fighting the medical information wars, trying to correct misinformation put out there by people. So every day there used to be bombarding and we did not know what is right, what is not right. Physicians who have been on the front lines of the pandemic know how demoralizing it can be to have people negate first-hand experience. I have seen personally, I have treated personally, I know the difficulties, but always I used to get sermons from people who have never entered the ward also. Most vulnerable population in this country were meet the faceless warriors in a city's anti-COVID for 19 In the initial phase, police and others were so enthusiastic, ASHA workers, when they started getting affected or affected with COVID-19, then they realized, yes, we were warriors. Yeah, every day we see in TV, but I should also protect myself. They were also under great stress. ASHA workers, police people, TV channel people trying to cover, of course, our healthcare professionals also. So what is the pathogenesis for this COVID-19? Is it just social causes, poverty, losing job, etc.? No, there is a biological basis for this. So the neurological manifestations are seen among patients with COVID-19 because of, we have seen delirium, seizures, stroke. I'm not going to discuss because I'm focusing on only psychological problems. So COVID-19 may attack the brain through hematogenous route or neuronal dissemination. So the neuronal damage is caused either by direct virus effects or by immunopathology. So we have seen patients who had anosmia, went into severe delirium and had a serious complications. So neuroinflammation is one of the pathology. Despite having blood-brain barriers, the spinal cord communicate with the peripheral immune system, and hence every systemic inflammation affects the CNS, brain. Compromised blood-brain barriers allows an inflammatory storm to engulf CNS, leading to functional damage. So peripheral inflammatory molecules as well as inflammatory cells instigate neuroinflammation, thus perturbing homeostasis and altering neuronal networks and inducing neuronal death. So there is a relationship between those two. So COVID-19 and major depression. Major depression is one of the most frequent neuropsychiatric disorder linked to inflammatory injury to the brain. So systemic infection can itself trigger a major depression disorder, especially more so in elderly individuals. So increased serum levels of interleukin 1 beta directly correlate with emergence of late life major depression. So COVID-19 pandemic resulted in significant changes in lifestyle and interpersonal relationships, condemning many to prolonged loneliness. Psychosocial stress can also have a detrimental effect on the most fragile subjects, affecting their ability to modulate their emotions. So decreased control over their impulsivity and feelings of fear in combination with inflammatory challenges to the brain might increase the risk of suicide. This is in the initial phase of illness, we saw people committing suicide. So second thing, bipolar disorder. I have seen patients who were perfectly all right before the affliction of COVID-19, and immediately after that, coming back home within few days, couple of them had psychological breakdown without family history, without past history of mental illness. So there is an abnormal balance between the pro-inflammatory and anti-inflammatory cytokines in the CNS and in the plasma have been repeatedly observed in patients with bipolar disorder, supporting the notion that neuroimmune response may be a prominent factor contributing to etiopathogenesis of the illness. We have seen patients having this. So a wide spectrum of immune system dysregulation as well as infections together, of course, with the genetic vulnerability, abnormalities in neurotransmission, stress and exposures to environmental factors such as childhood trauma are recognized as potential psychogenetic factors for reactive psychosis. Means they don't have mental illness, they have the fear, and all the time they are preoccupied about something may happen to me, I may die, all this reactive psychosis problem. There is a growing body of literature reported that occurrence of OCD. OCD was people with OCD, already I'm washing my hands repeatedly. This made every day, wash your hands the moment you see, use that sanitizers, etc. Worsen the obsessive compulsive disorder. Patients who had recently recovered from viral encephalitis are more vulnerable for OCD. Functional neuroimaging demonstrated this obsessive compulsive disorder patient implies alterations in the striatothalamo-cortical circuits may be affected in viral infection. So possibly through interference with glutamate transmission. So even people who never had OCD had obsessive compulsive disorder after this COVID-19. So the pathogenic link between, there are many other diseases, PTSD. I have that traumatic experience, person dying next to me, having that stressful event going on in the world, getting admitted. And this is also due to increased concentrations of pro-inflammatory factors were observed both within systemic circulation and in the brain in the context of PTSD. Meta-analysis confirm a remarkable increase in pro-inflammatory molecules in subjects with PTSD. So that is why all these psychological disorders had associated psychological, there is a biological basis. Schizophrenia and viral disorders are found to be for a long time going hand in hand. So significant number of psychotic episodes aftermath of Spanish flu was seen, pandemic has highlighted the possibility of increasing incidence of schizophrenic disorders who are underwent this viral infection COVID-2. There are no direct evidence how it happens, but the risk of schizophrenia is quite high. So let us come to what happens to, what's the percentage of patients who had epidemiologically, what happened to our healthcare workers. The prevalence of moderate to severe psychiatric symptoms was seen among our healthcare workers. Anxiety around 12 to 20%. Depression is the commonest, 15 to 25%. Sleeplessness, a lot of people called up. I don't have any problem, doctor. I'm comfortable, but I wake up at 2 a.m. I'm not able to get sleep 5 a.m. So early morning awakening is one of the thing, and traumatic distress. These are that was the highest one. So what are the risk factors for these employees? The most, I told already, increased fear of getting affected, in contact with affected patients. Other consistent factors are psychiatric symptoms, disorders, or general medical illnesses having those things. Spending a prolonged time in quarantine, perceived lack of organized support, and social stigma. Initial phase, nurses, doctors faced this. The people were not allowing them to get back to their homes when they are living in an apartment or etc. So that is one. What are the protective factors? Access to personal protective PPEs. Consistent protective factors include having supportive peers, access to psychiatric intervention and infection control measures, clear communication from superiors, and adequate time off from work. These were the protective formats. So patients with COVID-19 approximately had 20 to 40, 1 in 5 had psychological, 20 to 40% of patients manifested neuropsychiatric symptoms consistent with delirium. When the patient was admitted for COVID-19, they had delirium on psychosis. For example, I want to give, a patient was brought from Hubli, patient presented with sudden onset of psychosis, hearing of voices, trying to harm, end their life, commit suicide by hanging. It was acute onset, and the patient was having some sneezing, cold. The family was denying, my wife has this problem for a long time. When we did, the test came positive, and that the psychosis was part of that infection what they had. So insomnia is very common, 42%, impaired attention and concentration, anxiety, impaired memory, depressed mood, confusion, and altered consciousness. All these things were seen in COVID patients. So in general population, adults found that clinically significant psychiatric symptoms of anxiety, depression, PTSD are seen. In children, they were also affected with this. Why? They were not able to go to school. They were not able to play with other peers. So they were most of the time held up inside the house. And especially these children also had the fear of losing the fear of contracting the illness. Recently, I had a child who refused to go out of the house, who was always crying, not allowing parents to go out to bring even the ration, and did not allow the parents to go out. Why? When we interviewed the child was so closely attached to grandmother who was staying in the house. Child has the fear, they may contract illness and my grandmother may die. That is called separation anxiety. So what are the psychosocial traumatic events which can have? One, fear of infecting family.
We have time issues.
5 minutes, I'll finish. Okay, I will go with clinical features. So exacerbation substance use disorders went up during this period. Regular drinking has gone up. Ex-drinkers started drinking again. The moment it was start, everybody relapsed. Smoking has increased, even in ex-smokers. There's an increased risk of suicide. Suicidality has increased because of economic deprivation, social isolation, and lack of reduced access to medical combination. Individuals in this thing had a problem with anger, outcome, boredom, confusion, etc. How do we approach? One is, how do we manage to overcome this? One is maintaining routines of sleep, work, getting dressed, whether I am working from home or not, maintaining structured activities such as exercise, engaging in pleasurable activities, relaxing activities, etc. Then advantages. What are the telepsychiatry? Before that, I want to tell, the current studies have shown 1 in 5 patients had psychological problem post-COVID in the first 90 days. So because of time constraint, I'm going extempore. So what are the 3 things we are seeing? Depression, anxiety, and a small percentage of patients who are elderly, above the age of 65, had symptom like dementia. I was called to see an elderly individual who is 70 plus, who was in public life throughout his 35, 40 years of career, who was, when I interviewed and examined, he was in a dementia-like state. So we have to be extremely careful. A small percentage, 1.6% of elderly people above the age of 65 are high risk for dementia-like syndrome after post-COVID this thing. So how do we manage? One is maintaining our sleep, work, getting adequately dressed, etc. Then what are the advantages of telepsychiatry? This brought in the advantage of psychiatrists seeing the patient. So improved access for patients. Also, they need not worry about infection. While some patients may feel more relaxed because they sit at home and talk to the doctors, others may find it little difficult because they can't find the trust. So the disadvantages, one, connectivity, just like what I had. Online psychotherapy also work well, and there are some software platforms which permit family members and group therapy. Today, when the lockdown and pandemic started, we used to have at least 60 to 80% of patients wanted telepsychiatry. Today, still today, now also, there is a great demand. Most of our psychiatrists, 1/3 to 2/3 of their patients, they see by on telepsychiatry. Lastly, coming to that, psychopharmacology. So psychiatrists may be asked to consult patients who are undergoing all the depression, etc. Because one of the common things is the doctor should know currently what the patient is on, like dexamethasone, which is associated with a lot of psychiatric symptoms ranging from depression to psychosis and change in personality. So the doctor should know what are the medications the patient is on. So they can use safely antidepressants like SSRI, escitalopram, etc., antipsychotics like olanzapine. When the patient has sleep deprivation, one should be a little more careful. Be careful before using long-acting benzodiazepines like clonazepam or diazepam. Better to use short-acting benzodiazepine like lorazepam. If the patient is violent, having aggression, valproate can also be safely given because it also seems not to interact with antiviral agents. So before prescribing any medication, I request our doctors to check for drug-to-drug interaction. We need to work with the family. It is just not enough. Please see that you have a thorough communication. Treatment team should provide condolences to the family in a compassionate manner that includes expressing sorrow for the loss, acknowledging their pain, and also giving their what happened in the last hour. Suicidality, I told you, it is very high. So if you find a patient complaining, I don't feel like living during the COVID or post-COVID, need to be immediately referred to a psychiatrist. So many clinicians who treat patients with COVID-19 develop moderate to severe psychiatric symptoms, including anxiety, depression, insomnia, distress. So one estimate suggests that approximately 50% of healthcare workers need psychological support. So secondary traumatic stress can be defined as emotional distress arising out of listening to what the others are going through the distress. So that is also very common among them. So the recent study says it is a bidirectional one. So it is psychiatric illnesses complement mental illness. COVID also causes a psychological problem, and pre-existing mental illness also can cause. So without taking much time, I want to tell only one thing. It is bidirectional. People with psychiatric illness are more vulnerable for COVID-19 infection. So healthcare workers have to be protected, and we should also take care of the mental health of the patients who are suffering from COVID-19 or post-COVID, especially physicians who are there today you may start getting the patients with this. If they have depressive symptoms, treat with SSRI. If they have any psychotic symptoms, being suspicious, not able to trust people, hearing of voices, either they can use olanzapine or risperidone with a safety net. And only insomnia without any underlying psychological problem, please use lorazepam and see that that is tapered off within 3 to 4 weeks. And lastly, melatonin is also very helpful. With this, I request all our doctors to take care of ourselves. Though the COVID risk has come down, but let us not be careless about the guard against the second episode. And I thank Disha people for giving me an evidence. Thanks to Sanjay, Dr. Manohar, and all the team, Dr. Vijay Kumar. Thank you very much, Dr. Manohar, Dr. Sanjay, and Dr. Vijay Kumar, and all the listeners.
Thank you very much, Dr. Jagdish, for very crisp and quick presentation. And I think in the matter of time, we'll move on to the next session. Next session is on the double distinction from the goal to event reduction, the new insights into ARB with CCB combinations. Here to talk this, I will invite Dr. Sudhindra Disle to introduce the speaker. Dr. Sudhindra Disle is a physician endocrinologist and professor and HOD from Sri Rajarajeshwari Medical College and medical director of Marigold Hospital and Marigold Clinics. Dr. Sudhindra, please take over. Dr. Sudhindra, you have to unmute, sir.
Good afternoon, everybody. Today we have Dr. Sanjay Mittal amongst us. He is a Director, Clinical and Preventive Cardiology, Heart Institute, and he is speaking on double distinctions from goal and event reduction, new insights from ARB and CCB combination. So a brief introduction about Dr. Sanjay Mittal. I think we all know about him. He did his MBS from LLRM Medical College, Meerut, and also his MD from there only, and he did his DM from Lucknow. And he's worked in various posts, I think senior residency from Lucknow, and then he moved to Escorts, and then in New Delhi, where he did his senior residency in college, and principal consultant in cardiology, and he moved to Indraprastha Apollo, and also a senior consultant cardiologist. Presently, he's in Vedanta MedCity, where he's working as a director in clinical cardiology and research. I think all of us know he's a well-known research, and besides his clinical practice, he has various publications under his kitty, and he has participated in phase 3 and phase 4 trials. Amongst the phase 4 trials, the Emperor, the Harvest, and the Anthem heart failure trials, and some as clinical principal investigator and some as co-investigator. So already we are short of time. So without much delay, I call upon Dr. Sanjay Mittal so to please come and start his presentation. Over to you, Dr. Sanjay Mittal, please.
Thank you, Dr. Disle. Good afternoon to you all. What I'm going to talk today in a diabetic forum is a little bit different, but I think it's a cousin brother of diabetes, the lifestyle diseases we are talking about. I'm going to try to cover up everything in the next 15 to 20 minutes so that we conserve some time. I'm going to talk about hypertension and management of hypertension in perspective to the ARB and CCB combinations. We know hypertension is as bad as diabetes is all over the globe. An estimated 1.13 billion people all over the globe are having hypertension at the moment. 20% of women and 25% of men in 2015 were known to have hypertension, and 31.1% adult population across the globe in 2010 were reported to be hypertensive. It's a big problem. India is not far behind, and what is important is that 17.6% patients, this is the data quoted in Indian Heart Journal in 2019, 17.6% patients hypertension globally were living in India. And that also means there is about 234 million people in adults hypertensive in India. We know that in this curve, it very clearly shows as the age advances, so does the incidence and prevalence of hypertension in our country. And again, 31% population is hypertensive. Hypertension is a big problem as far as events and complications is concerned. It is responsible for globally 10 million deaths and over 200 million disability adjusted life years. Ischemic heart disease, 4.9 million ischemic heart disease is basically attributed to hypertension alone. Hemorrhagic stroke, ischemic strokes, and in 2015, elevated systolic blood pressure was the leading preventable cause of premature death globally. This is 2017 data I have quoted from. More interestingly, it's not the sole risk factor. Other lifestyle factors and commonly diabetes, if you look at, once we have an association of hypertension along with these risk factors, the risk of events, the cardiovascular and stroke is sky high and heart failure is sky high. So if we have no other risk factors, just hypertension, when the blood pressure is high normal, the risk is low. However, in grade 2 hypertension, when the systolic blood pressure is above 160 and diastolic pressure is above 100, this is the recent data from 2020, it is high or moderate. If we have one or two risk factors, again, it is high risk if you have extreme hypertension alone. And if it is even grade 1 hypertension, that means systolic pressure of 140 to 159 and diastolic 90 to 99, it is still a moderate risk. That means about 10% immediate in 10 years' time. More than 3 risk factors, again, even in high normal pressures, you have almost a moderate risk group as compared to the other people who do not have other risk factors as compared to simple hypertension. And if you have diabetes or CKD or CVD, risk is very high, more than 15 to 20% over 10 years period of time. There has been constantly evolving criterion because of the recent data which have been pouring up. You know, if we go back to the description of what patient to call hypertension, the description or definitions have been changing for time. Going back to 1980s, where 160 systolic or 95 diastolic was considered to be hypertension, the bars have constantly been coming down. And this has been so because it has been associated and found to be associated with event rates, even though the pressures were even 140. So more data and more knowledge actually has led to better understanding and realization that what we so far considered normotensive earlier is no longer safe and we should reduce the pressures down. So we see the level of systolic as well as diastolic pressures coming down as recommendations over a period of time. And the latest ones of them all is the 2017, 18, 19, and 20 guidelines. All of them say less than 140 and less than 85 millimeters of mercury diastolic to be accepted as targets as well. All of these studies, there are certain drug versus placebo trials. There were certain comparison between the drugs, various drugs available, Accomplish, Elhart, Accord. And there are other trials which were actually comparing different blood pressure targets. On the basis of that, the recent guidelines are there, which goes beyond 2007. No much change in far of the targets is concerned is been there after 2017. Unfortunately, the awareness is hugely low. If we look at the global data, only 46% people in globally were aware that they are hypertensive. And out of them, only 40% actually were treated. And only 35% of those who were treated were actually better controlled. So it's a huge bit of gap globally between the diagnosis and treatment or management of hypertension. India is not far behind, rather worse of them all. The urban data, which is blue bars, and red data, which is rural bars, also speak for itself. That even though the person may be hypertensive, only 1/4 of the people in India understand in the rural circumstances they are hypertensive. So if they don't know hypertension, how they're going to treat? So 24% get treatment and only 11% in the rural circumstances and 20% in urban circumstances have actual control. And what could be the reasons? There could be patient-specific reasons, that is lack of awareness regarding disease and its complications, which is so much prevalent. Unfortunately, hypertension has minimal symptoms, and there is lack of focus on safety, long-term safety as far as patient is concerned. If I'm comfortable, I'm all right. Side effects of medications, polypharmacies, and the cost is major concern. And patients, besides the patient, the physicians also have a constantly changing guidelines. They are confused, too many options available. There's a lack of head-to-head comparison into various drugs. And then there is always a risk if the person has side effects, what will lose the clientele of the patients, and the other person would take it. To simplify the pharmacological agents available for the management of hypertension, there are two things which we are acting upon. One is sympathetic nervous system, and the other thing, renin-angiotensin-aldosterone axis. Sympathetic nervous system increases the heart rates and the vessel constriction because of the alpha blockages. And that's why we can use beta blockers or calcium channel blockers or alpha blockers, which act on vasoconstriction and vasodilatation, especially the arteriolar system. By reducing the arterial constriction, they lead to vasodilatation and reduction in blood pressures. The angiotensin 2 synthesis and aldosterone release, both of them lead to hypertension and vasoconstriction and salt and water retention, leading to fluid overload. ACE inhibitors, ARBs, calcium channel antagonists, diuretics, and aldosterone blockers all act on this mechanism to reduce the fluid overload as well as vasoconstriction and help in a reduction in blood pressure. So many guidelines have come. I'm just continuously mentioning about 2017 ACC/AHA guidelines, in 2018 European guidelines, in 2019 this was NICE guidelines, again defining what is hypertension and how to manage and how manipulate hypertension. And 2020 the recently published the International Society of Hypertension guidelines. All of them are universal in saying that first treatment for hypertension is a good lifestyle management, that is exercise, diet control, yoga and meditation to relax the person. But beyond that, what about the pharmacological management? The ISH 2020 guidance are very clear that at step 1, instead of just starting one drug in a small dose and stepping it up, they recommend the best outcome to be with a combination treatment. And they recommend the angiotensin receptor blockers or ACE inhibitors combination with a calcium channel blocker as the first line. Step 2, they recommend to increase the dose to the full dose if the blood pressure is not controlled. If the blood pressure is still not controlled, step 3, they recommend to add a diuretic. And step 4, to actually add a spironolactone on top of that and add other combinations to medications of that. They also said that the beta blockers are to be included, especially if the person has heart failure, myocardial infarction, ischemic heart disease, or atrial fibrillation. Learning about trials, and I would like to say here that only a few trials are there where head-to-head comparison have been there. There's Scott and Complish, which very clearly mentions the ACE inhibitors and diuretic combinations were not as good as ACE inhibitors and calcium channel blocker combination. And this trial showed that there was 21% event reduction, CVD reduction over a period of follow-up period of time. Calcium channel blockers, the fever trial, and ARBs have been found to be very effective antihypertensives, not only reducing the blood pressure, but also reducing the event rates in the follow-up period. So as a recommendation, that is the basis of the finding of or recommendation of 2020 ISH guidelines on hypertension, that renin-angiotensin and aldosterone blockers, along with calcium channel blockers at low dose, should be the first line agents, specifically for hypertension and diabetes, because RAS inhibitors and calcium channel blockers, thiazide-like diuretic could be used. For COPD, again, it's safe. For previous stroke, again, they have been found to be best combinations. With coronary artery disease, with addition of beta blockers, they are used as a first line of treatment. Various ARBs which have been approved, azilsartan, candesartan, and these are the recommended doses from the ACC guidelines. Eporisartan, irbesartan, losartan, all of these can be used, olmesartan, telmisartan, valsartan. The doses preferred is single dose. So azilsartan, candesartan, irbesartan, olmesartan, telmisartan, because they are number of pills are less, they are better compliance and better effective, and compared to the other drugs, cover the morning surges of blood pressure better. As far as calcium channel blockers, the first two, the amlodipine and azilintepine, is the ones which have the longest half-life, and single daily dose along with cilnidipine can be used. And this is something which is very important because they again reduce the number of pills. A word about the combinations of ARBs and CCB. This is a trial, with Oscar trial, which is a Japanese trial published in 2009, where the patients were actually randomized to receive olmesartan alone or olmesartan with a calcium channel blocker, which was in this case azilintepine or amlodipine, and they were followed up for 36 months. It was found that the reduction of systolic blood pressure was better in combination as compared to azilsartan alone. And the diastolic blood pressure as well as systolic blood pressure was improved in this study group over a period of 36 months. This also led to an event rate reduction in the combination arm as compared to the blue arm, which was only ARB doses. So this was 58 events as compared to 48 events. There was a statistically significant improvement in the cardiovascular disease patients also as far as event rates was concerned. So for a combination of cardiovascular disease and hypertension, this is a drug of important significance. Result trial, which was again a comparison of olmesartan and azilsartan, which showed that there was substantial improvement in the combination arm in systolic and diastolic blood pressure when there was a combination of the two as compared to the single drug treatment. So this was a better and more effective, especially the early morning surge of blood pressure, which was better controlled. So there have been certain problems with calcium channel blockers. One, short lasting. Second, reflex tachycardia and pedal edema. The reason for that is as the vasodilatation happens, the stroke volume may reduce, which is actually going to incite the counter-regulatory hormones, leading to increase in vasoconstriction and reflex tachycardia to maintain the cardiac output. And that is why one of the things, shorter acting calcium channel blockers have a problem. The other thing is because arteriolar dilatation is more as compared to venodilatation, there could be leg edema, pedal edema, especially towards the evening sides. And this can be taken away if we have a drug which is not only on the L receptors, because there are L receptor, N receptor, and T receptors of the calcium channels. If the drugs are only active on the L receptors, there are more chances of the side effects. However, the drugs which are effective on N and T receptors, as well as just like azilintepine and cilnidipine, they have lesser side effects as far as this thing is concerned. So all these things, besides the achievement of targets, goals, as well as event rate reduction, these points also help in choosing a drug better, safer, less side effect profile, single daily dose, simple dose titration, and no major interaction with concomitant classes, and cost effectiveness. I give you a few data points on azilintepine versus amlodipine, which is the commonest used calcium channel blockers today for antihypertensive purpose. It is equally effective in this particular study. If you look at 108 patient data, it was equally effective as far as systolic blood pressure, diastolic blood pressure. But if you look at the pulse rate reduction, it was more significant with azilintepine as compared to amlodipine. The other aorta study was published. This was published in 2011. Again, it was a combination of olmesartan with azilintepine or olmesartan with amlodipine. The combination with azilintepine was more effective as far as change in central aortic blood pressure was concerned. So this is more effective in reducing the event rates subsequently. If you look at the change in heart rate, azilintepine led to reduction in heart rate as well because of its effect on the T and L type receptors. There is another data which is coming, which has been published, and I quote this article from 2013, that internal memory artery, which is a common graph which is given, it shows azilintepine to be better relaxing as compared to amlodipine. Azilintepine also has better influence on the glucose and insulin metabolism. So it's something which is of interest to the endocrinologists and cardiologists, that glucose tolerance test and glucose receptive sensitivity is better altered by azilintepine as compared to amlodipine. So in these particular patients, we may choose azilintepine over amlodipine. There was another effect on the heart rate, and I would elaborate on that a few minutes from now. One more thing which I would like to mention here, a concern is the cerebral hypoperfusion when the person is on antihypertensives, especially the elderly population. In this particular study, in 24 weeks post-treatment, it was seen that azilintepine did not reduce cerebral perfusion despite reduction in adequately the blood pressure. So this is something which is of importance for elderly population as well. And another data about azilintepine versus amlodipine is, again, in diabetic population, where there was observation that urinary albumin and atherosclerosis reduced with azilintepine as compared to amlodipine. And this data was published in 2015 in September. Last but not the least, cilnidipine also is a very important and good drug. And this study, which was published in 2018, was to swap cilnidipine to azilintepine and see if there is any change in heart failure with preserved ejection fraction patients. 24 successive patients were taken and they were all assessed for all the changes. And there was no change by swapping to azilintepine as far as echocardiographic parameters of heart failure was concerned, or all the biochemical markers of heart failure and noradrenaline, adrenaline levels were concerned. What they observed in this particular study is then when cilnidipine was switched over to azilintepine in heart failure population, there was significant drop or reduction in the sympathetic nerve hyperactivity. That means the hyperactivity on MRI, on cardiac scintigraphy, MIBG scan, their washout rate of sympathetic activity was much faster as compared to cilnidipine. That means the sympathetic drive improves much better in azilintepine group. So the take-home message here, I would like to give my fellows here. Hypertension is a menacing problem in India and across the globe. The awareness among population is low, and even lower is the level of control. Regularly pouring new knowledge is leading to constantly evolving guidelines, clearing the doubts and sometimes confusing the people. Latest ISH guidelines recommend initiation of pharmacological management with low dose combination therapy. Mind it, there is no second thought. Lifestyle changes come first. And if the blood pressure is not controlled with lifestyle changes, then combination therapy is, low dose combination is a must. Ideal treatment should have a double distinction of not only achieving a target blood pressure, but also should be able to equally reduce the event rates of cardiovascular as well as cerebrovascular events. Renin, angiotensin, aldosterone blockers, along with calcium channel blockers, are advisable to be the first-line agents, especially in non-complicated and non-urgent or non-essential situations. A once-a-day dose of a fixed drug combination improves compliance by reducing pill count and cost. Finally, in calcium channel blockers, N-type calcium channels are present in peripheral neurons, and T-type channels are present in myocardium, SA nodes, and renal arterioles. By stimulating these two, blocking these two channels, there could be a heart rate reduction as well as renal improvement in perfusion, and so that the renal outcomes are better. And also the cerebral neurons perfusion is better, so that the brain perfusion is also better. Calcium channel blockers which block N and T type, apart from the L type blockages, they would lead to reduced peripheral edema and reflex tachycardia. Azilintepine is, along with cilnidipine, has this property of LNT blocking, and that is why having a better affinity to vascular endothelium. Studies have shown azilintepine brings significant reduction in 24 hours diastolic blood pressure as well as systolic blood pressure, as well as heart rate. This is something which is of importance, especially in ischemic heart disease. This is something which we have to be watching for. Cilnidipine as well as amlodipine are equally efficacious in 24 hours blood pressure and heart rate control, but heart failure and preserved ejection fraction as amlodipine supposedly reduces the cardiac sympathetic nerve activity more than cilnidipine. Thank you. Thank you for your attention.
Thank you, Dr. Sanjay, for that elaborate. Started with the treatment, then you went with the RAS and the CCB combination, then you told us what are the advantages of the new RAS and blockage and the latest treatment of CCB combination. Before I open the session for discussion, one question. See, with hypertension and the heart failure treatment, so amongst the trials, so whether when we add the ARBs and the CCBs, whether it is really worth it to add a small dose of diuretics, because what the combinations we get, we have the ARBs and the CCBs and a small amount of diuretics. So when we have the hypertension and heart failure patients, so whether it is worthwhile to add this combo treatment, so whether it neutralizes the CCB side effects eventually. So what's your take upon it?
So thanks for that question, Dr. Bisle. Two things. One is heart failure is now no longer heart failure as a syndrome. It is heart failure with reduced ejection fraction, where beta blockers and ARBs or ACE inhibitors are the first line treatment. Calcium channel blockers are only if the hypertension persists despite beta blockers and ACE inhibitors or ARBs, which is not so very frequent. In preserved ejection fraction heart failure, as was showing the data, hypertension is a predominant cause, and their beta blockers are of no significant use, specifically knowing sometimes the preserved ejection fraction heart failure may be because of chronotropic incompetence, where beta blockers can worsen the heart failure. In situations like this, calcium channel blockers and ARBs, ACE inhibitors are good. Combining with diuretics is only if the blood pressure is not controlled. Mind it, the pedal edema, which is so very frequent with calcium channel blockers, especially amlodipine, is not to be treated with diuretics in the first place. Specifically because this would lead to more renal involvement and inconveniences until and unless there is a definite sign of fluid overload where you can give loop diuretics. Otherwise, thiazide-like diuretics are better preferred for antihypertensive purposes in these situations.
Okay. So thanks for the exhaustive coverage between CCBs and ARB combination. I open with others for discussion. The session is open for any question and answer. So one more question, sir. The question for the speaker. Amongst the ARBs, only we have seen in the trials olmesartan and valsartan. So what is the other ARBs and CCB combinations?
So I think in our country, telmisartan also is very frequently used as an antihypertensive. Unfortunately, many of the people, even with heart failure, are using telmisartan, although there is no data, and they say it's a class effect. The heart failure population with reduced ejection fraction, losartan, irbesartan, candesartan are the classical drugs which have to be used. For hypertension purposes, I showed you the list. You can choose any, but we prefer to use single daily dose drugs rather than the double daily dose drugs. That's why olmesartan and telmisartan, they are more frequently used as antihypertensives.
Okay, over to you, Dr. Vijay.
Yeah, thank you, Dr. Sanjay Mittal. It was an excellent discussion here. Something very interesting to take home. Well, if there are no other questions, can we move on to the next session? The next session is about simplifying type 2 diabetes management with evidence-based conviction. So, gliptin in perspective. Yeah. To this, Dr. Sanjay will be chairing this session. Dr. Sanjay is a consultant physician and diabetologist at Shreya Medical Center and visiting Fortis Hospital in Bannerghatta Road. Dr. Sanjay, over to you.
Thanks for introducing Vijay Kumar. First of all, thanks Vijay Kumar Manor and Disha team for giving me an opportunity to chair this session. So far this has been an excellent session so far. Even the post session was very excellent. So going on by this, I call upon Dr. Sudeep to come over and take the chair. He will be talking on simplifying type 2 diabetes management with clinical based conviction, clipped in perspective. Over to you, sir.
Thank you very much, Dr. Vijay Kumar and Disha. Am I audible?
Yes.
I'll share my screen. Is my screen visible?
Yes.
Yeah, shall I go ahead?
You can go ahead, sir.
Good afternoon. We'll be discussing about some aspects of one of the drugs which has helped us in simplifying management of type 2 diabetes mellitus, linagliptin. Basically, if you see the recommendations from the management of diabetes mellitus should be always including lifestyle modification. A drug should be something which avoids weight gain, which avoids hypoglycemia, and which tries to individualize the target for that particular individual and optimizes the A1C. Make sure that the patient-centric approach is there, and the choice of therapy will be decided by the presence or absence of atherosclerotic coronary artery disease, congestive cardiac failure, and the renal status of the patient. And also, we have to take into account what will be a immediate goal and what will the long-term goal, and also the use of affordable treatment and also sustainable treatment. So basically, we are looking into something which is the key principles in type 2 diabetes management, that is use of a simple and patient-friendly drug. And we are in need of something which can simplify the management of diabetes, particularly doctors when they are having a busy clinical practice. So, do we have any group of drugs which can address this? Yes, like we have drugs which have low risk of hypoglycemia, which are at least weight neutral, and which have a good safety profile. Few interactions and no timing or dosing is required. And patient compliance can be ensured. So what we are talking about is now actually the DB4 inhibitors. Yes, they are the drugs which have a good amount of all these combination of factors which are going to consider when you are going to address a patient's requirement. So the 3 E's are efficient treatment, easy to understand for the patient and the doctor, and it should be error-free for both. For example, if you're going to write this drug, are you going to think twice about what you're going to write, or you're going to think twice after you have written? So we need some evidence for efficacy. Particularly now we are going to focus on DP4 inhibitors. Efficacy is like ability to reduce the glycemia and also produce minimal hypoglycemia. So coming to linagliptin as a monotherapy or as a combination with metformin, there is a significant reduction in HbA1c when you are using linagliptin as a monotherapy, based on the studies which have compared with the placebo, and also combining with the metformin. Do we have a good efficacy? Definitely yes. When A1C, the higher be the A1C, the greater is the reduction in the HbA1c, which is achieved when you are adding linagliptin alone or adding linagliptin plus metformin to somebody who is uncontrolled. So basically, as a startup therapy for somebody who is new with diabetes mellitus who comes to you, and you don't know what to give, and or you know that you can give metformin and no problem with metformin, but you know that metformin may not be sufficient. A good option is to consider a DB4 inhibitor plus metformin. And by the subsequent slides, I'll be able to discuss about which DB4 will we be able to choose when we are having considerable factors to be considered in the patient who is given to you. So, do we have a long-term glycemic efficacy when you are having linagliptin against the sulfonylurea? Because sulfonylurea is a traditional drug which has been used when metformin doesn't work. So studies have shown that the durability and the ability to sustain the similar effects which are achieved immediately after a few weeks of starting the therapy versus continuing the therapy over weeks. Definitely, it has been comparable to glimepiride. And when you're combining with metformin, what happens? Definitely, when you're giving metformin alone as a 500 milligram or a 1000 milligram tablet, and when you're adding metformin, linagliptin to this metformin, definitely there is a the number of people who are able to achieve a good A1C, it's 2 to 3 fold compared to metformin alone when you're adding linagliptin to metformin. So hypoglycemia, definitely yes. This anything, it's very simple as that. A pure insulin secretagogue versus a meal-dependent insulin releaser or an insulin modulator, we can call. Definitely, there will be a difference in the incidence of hypoglycemia. And in this graph, you can see that over years, when you're giving linagliptin versus glimepiride, the risk of hypoglycemia is definitely less. So you can see the incidence of any hypoglycemia or a moderate to severe hypoglycemia, which is one which are really worried about. Moderate to severe or severe hypoglycemia is what we are worried about in diabetic patients, particularly when they're having a cardiovascular risk and a cardiovascular disease. So definitely there is a lesser amount of hypoglycemia when compared to sulfonylureas, and definitely the risk of hospitalization for hypoglycemia will be less when you are using or nearly nil when you are using a DP4 inhibitor. Efficacy in Asians, do we have a difference? Yes, compared to Caucasians, you can see Southeast Asians or Asians, including Japanese, the efficacy has been better in a DP4 inhibitor use. And across the DP4 inhibitors, there are two other DP4 inhibitors which have been shown to have more advantage in the Asians compared to the Caucasians. And linagliptin is not an exception. And safety of linagliptin in Asian patients when stratified for age, obesity, and renal function. Again, the studies have clearly shown that at least on an average, 0.7% reduction in HbA1c is achieved. When you're dividing the Asians as East Asians or South Asians or Southeast Asians, the Southeast Asians have shown a better outcome in terms of glycemic reduction. And ability to sustain in patients, in Asian patients, when you're comparing with the glimepiride, the 4 variables considered: ability to maintain the glycemic control over a period of time, ability to avoid use of a rescue medication, ability to avoid hypoglycemia, and ability to avoid weight gain. When you're considering these variables, definitely there are enough evidence to show that compared to glimepiride, sulfonylurea, linagliptin has a odds ratio of 2.16 to achieve and maintain a glycemic control without producing hypoglycemia or weight gain. So now coming to the main issue of what is the CV safety and heart failure safety. That is one which is a requirement which every diabetic drug has to prove before being put in for a market use. And usually outcomes are studied in terms of MACE outcomes, that is major adverse cardiac events. And these are the landmark trials which have used individual DP4 inhibitors, which have been named here. And we can see that the commonly used sitagliptin, linagliptin, as far as the Indian market is concerned, they have their own cardiovascular safety trial, while vildagliptin doesn't have a cardiovascular outcome trial. Only cardiovascular failure trial was there, and tenligliptin doesn't have a cardiovascular outcome trial, and it has a theoretical risk of QT prolongation. So coming to Carmelina here, you can see that it has been neutral as far as a cardiovascular safety outcome is concerned. And if you see the compare the other gliptins, linagliptin and sitagliptin have been assessed for the effect of the drug on QTc, and we have to be careful about the drugs, because it's not alone the drug which is going to be a problem. The associated drugs, a cardiovascular drug, particularly given for the heart, any drug which can produce a QT prolongation, or any other non-cardiac drug which is going to prolong the QT prolongation, you have the risk of arrhythmias. And here, particularly in DP4 inhibitors, the main drug will be tenligliptin, which has been shown to have an effect on the QT prolongation, while linagliptin and sitagliptin, no clinically meaningful QTC prolongation has been shown. Next, coming to heart failure. Again, saxagliptin and alogliptin, they had alogliptin had a trend, while saxagliptin there was an increase in the heart failure, and sitagliptin was neutral. While linagliptin there was no adverse effect on the heart failure, and probably there may be a small trend towards improvement in terms of heart failure, or reduction in the heart failure in as far as the Carmelina study is concerned. Well, vildagliptin, it doesn't have a dedicated COT trial at present, and the drug had a trial for a heart failure. In that, there was an increase in the left ventricular end systolic and diastolic volume. So the possibility of having a slightly higher incidence of the cardiac dysfunction is there in vildagliptin. So in linagliptin, definitely there is no increased risk of heart failure, and there may be a small trend towards a reduction, even though statistical significance would not be proved. There may be a trend towards reduction in the heart failure. So when you are doing a subgroup analysis, as a numerically lower incidence of heart failure in a certain groups, it has been shown that in the Asian group, the advantage would be much better compared to other groups, very ethnically, or groups which have been using insulin for glycemic control. So ESD guideline in 2019 has definitely cleared linagliptin to tell that it has a neutral effect on the risk of heart failure, and may be considered for patients with diabetes mellitus and heart failure. While saxagliptin and alogliptin, they have a trend towards increased risk of heart failure, while vildagliptin doesn't show any benefit as far as the cardiac failure is concerned. So now coming to one other important aspect of managing diabetic patients is that of renal safety. That is very prime importance for us when you are going to treat with drugs on a long-term basis. So over all phases of renal impairment, either be mild, moderate, or severe, or end-stage renal disease, or a new onset diabetes after a transplant, HbA1c reduction has been consistent over all this spectra of renal impairment. And Carmelina is a trial which has been very specific in it, because all the other DP4 inhibitors, they have undergone trial as they had undergone trial where the primary endpoint and the secondary endpoint has been only cardiac, while only in the Carmelina trial it has been cardiac plus renal outcome, very specific also, and pre-specified composite renal endpoints were studied in this study. So it had both the advantage of both the cardiac and renal outcome being evaluated, and nearly more than 70% of the patient at entry itself, they had a renal impairment, either as a reduced renal function or macroalbuminuria and severely reduced renal function, even though end-stage renal diseases were excluded from this trial. So at the baseline, they had a high-risk cardiovascular patient, high-risk renal dysfunction patient, and the trial was conducted in Carmelina. So other DP4 inhibitors all had only COT outcome. This is the only COT outcome trial. Carmelina was the only trial where they had seen the renal insulin, and endpoints most have been favoring linagliptin, or a trend, even though the numbers may not be much bigger. There is definitely a trend to suggest that the Carmelina has a definite renal safety in terms of not having any adverse effect. Will it be having a beneficial effect? There are some trends that reduction in the progression of albuminuria, and there is a significant maybe risk reduction in albumin excretion rate, may be independent of the effect on the glycemic control. Now coming to one other important aspect, which we always have to question ourselves before we are going to prescribe a drug, that is hepatic safety also. So linagliptin, no dose adjustment is required as far as hepatic impairment is concerned, and the efficacy has been uniform over various grades of hepatic dysfunction, and it has been significant reduction compared to placebo in terms of glycemic control and HbA1c reduction. And in chronic liver disease, no dose adjustment is also required, similar to sitagliptin. While there are some studies where severe hepatic failure, you don't have proof to tell that you can continue the other gliptins, but linagliptin can be continued. Now, evidence of convenience of how we can use a drug when you're going to consider all the things, or when you're going to consider that what safety thing you are going to consider. So, comparing to other gliptins, it has the highest binding affinity. Dose adjustment is not required as far as renal and hepatic is concerned, and it has got a more than a good 24-hour control because it's 80% DP4 inhibition. So definitely once a day dosage is enough because the terminal half-life is more than 100 hours. Where in vildagliptin you have to give twice a day dosage. And highest potency in terms of ability to inhibit DP4, and safety as far as hepatic impairment is concerned, and high selectivity for DP4, because that is one important concern which DP4 inhibitors have all been questioned about. Are they going to have a spillover effect over other DPP enzymes, that is DPP8 and DPP9? Comparatively, linagliptin has more specificity towards DP4, which is what we want. We don't want other DPP enzymes to be inhibited because we don't know their long-term effects. So, nearly half of the patient, when we are going to see the relative contraindications or use of other DP4 inhibitors when you're having safety concerns in terms of end organ damage are concerned. It has been shown that some of the trials have shown that studies have shown that nearly 45% of those patients who are on DP4 inhibitors, they have been given the drug without considering the indication or contraindication in terms of a severe renal disease or severe hepatic disease is concerned. So, inappropriate dose adjustment may be a problem when you are going to use drug without adjusting the dose, particularly when there is a renal impairment. And this is one literature from Mayo Clinic which suggests that when you are appropriately using the drug based on the GFR, and using the DP4 inhibitor according to GFR or hepatic impairment, you may be reducing some of the adverse outcomes. So this is a summary of what we have spoken about end organ damages. Whatever be the end-stage renal disease, linagliptin doesn't require a dose adjustment, and efficacy and safety has been proven. While the other drug, teneligliptin, which doesn't require dose adjustment, still there are limitations because we don't have good studies to tell that safety is over all the spectra, even though it can be used as a drug without any modification of the dose. So now, what is the real-time effect? We have now seen that Camelina is a trial which has both the advantages of both studying the cardiovascular safety risk and renal safety. While Carolina is other study which has studied linagliptin it's a longer duration study which had a low CV and a renal risk. So we have data over wide spectrum for linagliptin compared to other gliptins where only high CV risk study patients have been studied. We have here lower CV risk and high CV risk for linagliptin. So over a spectra of cardiorenal patients, linagliptin has proven benefits in terms of outcomes, or at least not having inferiority compared to placebo. So this is a summary of Camelina and Carolina study where there was non-inferiority compared to the placebos in producing any adverse events. And it's the same thing which tells us that in a cardiac failure or MACE outcomes. Coming to the specific population which we are very worried when you are going to write a drug is a elderly population, where you need to write a drug where you're not alone targeting the glycemic variabilities, but also the adverse effects, particularly hypoglycemia. So definitely you have this graphs here showing that nearly 80% advantage of using linagliptin compared to other drugs when you're having the risk of hypoglycemia, particularly sulfonylurea. And particularly when you don't have a weight gain, particularly obese elderly individuals, where you can't be talking too much about exercise for reducing weight. So important consideration in elderly patients, very safe drug is linagliptin. And no evidence of cardiorenal benefits, and a possibility of having some say on the albuminuria progression. So when you're comparing this in Asian patients, maybe that may be compared to the general total group versus Asians, there may be a more advantage in terms of heart failure or kidney outcome or 3-point MACE, which we need more studies for that. But as a real world evidence, we have seen that from either insurance database or post-clinical, post-marketing databases, there is a definite reduction in the composite cardiovascular events and heart failure. So to summarize, linagliptin has been proven to be safe, non-inferior to placebo in terms of any types of cardiovascular event and or heart failure or any type of high-risk renal disease profile. While in other gliptins, you have to consider some of the things, or you have to consider about dose reduction when there is a change in the GFR. So my concluding slide, to simplify patient care in terms of safety for all the end organs like cardiac, renal, or liver disease, or safety in terms of not producing hypoglycemia, or efficacy, or when you are considering the efficacy of the drug in producing a glycemic reduction over various spectra, or safety in terms of comparing different ethnic populations, Asians versus non-Asians, still linagliptin stands out as one of a safe bet in terms of all these endpoints which we have considered and we have discussed today. So with this, I'll conclude my talk and like to take questions if any.
Thanks, Dr. Sudip, for this lucid talk. It was he has elaborated completely on the gliptins, where all the users, complications, where to manage, where to use the correct dose of gliptins. Any questions from the audience? Dr. Sudip will be able to take that. So, any questions so far? No. So thanks, Sudip, for this talk. I'll hand over to Dr. Manor for the next program.
Thank you, Dr. Sanjay. Thank you, Dr. Sudeep. Thanks for also swapping the slot also for the technical lag. Thank you so much. It was very informative. And we'll move on to the penultimate session. For this, I would like to invite Dr. Subrata Das, consultant physician and diabetologist from Sakra World Hospital. Hello, Subrat. How are you?
I'm good. I'm good. How are you, Manohar?
I'm fine. Thanks for joining. Subrata has done MD in General Medicine from St. John's Medical College. MBBS also from the same medical college. He's a senior consultant in internal medicine and diabetology at Sakra World Hospital. He has numerous publications and he's very active member there. And I've been told by him that he's quite active during this COVID era also. And the topic is thyroid disorders from menarche to menopause and controversies also by Dr. Faraz Farishta, my good friend from Hyderabad. I think over to Subrata to introduce the speaker and the topic.
Yes, it's my real honor to introduce Dr. Faraz Farishta. Dr. Faraz Farishta has been an eminent practitioner in the Hyderabad area. He is professor at the Medicity Institute of Medical Sciences, consultant at Tumbav Hospital, MD of FS Endocrine and Diabetes Center. He's also the program chair for Masters in Diabetes and Endocrinology by Texila American University. Is also a co-guide for PhD Medicine for Research, has got numerous publications by his name. He also has been a principal investigator in many global clinical trials, has about more than 50 national and international publications, and he's a well-known speaker in national and international conferences. He's also awarded for his knowledge and his keenness in the subject of transmitting medical education when he was across the prestigious Abdul Kalam Memorial Award by the Health Ministry of Telangana. I think over to Dr. Farishta to take us through this interesting topic of the dilemmas we face from menarche to menopause as far as thyroid dysfunctions are considered.
Thank you so much, Dr. Manohar, for inviting me for this wonderful session. And then, yes, thank you, Dr. Subrata, for that warm introduction. And then I think without wasting much time, I will just we'll just go to the presentation. So I think whenever we talk about any endocrine or metabolic disorder, what comes after diabetes is thyroid disorders. And then you will see today what I'm going to talk is that thyroid disorders affects right from the spectrum of children to the young females to the middle age and to the menopause. So coming to thyroid and woman thyroid dysfunction is quite prevalent in India, particularly in females. We all know that. And the proportion of females versus males is around 15% in females versus 5% in males. The proportion of hypothyroidism, which was seen in India. So it affects right from the menarche to the menopause. So when it affects the children, you will see there is delayed puberty as the age goes on. Once they achieve menarche, so they'll have menstrual irregularity, a weight gain. During the fertile period, when they're getting married, they'll have issues regarding fertility. If they get pregnant, there is a complication which is there for the maternal and fetal, and even at the age of menopause, still it does not spare them. There is effect on the bone health, cardiometabolic health as well. So let's see some of the physiology, what happens due to thyroid function and puberty. There is a hormonal changes which happens during puberty. There is a growth hormone secretion. So there is a spurge we all know from antipituitary, which increases the TSH, which increases the metabolic rate and promotes the tissue growth. Here we have to remember that there is increase in thyroid volume occurs as an adaptation to the body and sexual development. It is very, very important to diagnose hypothyroidism specifically in children and adolescents because it retards the growth in height and development of secondary sexual characteristics. There is delayed onset of puberty and there is incomplete isosexual precocity as well. This thing, I think you have to remember few things in my presentation, and this is one of them. Precocious puberty. So precocious puberty is an unusual presentation of hypothyroidism in children. The characteristic feature is onset is with telarchy with or without galacturia, followed by menarche with absence of hair development, which is one clue. And another clinical clue to hypothyroidism in these cases is decreased linear growth, which is exactly opposite of what which is seen in patients with true precocious puberty. So in precocious puberty, true precocious puberty, you will see a spurt of growth which is happening, which is very, very unlike when hypothyroidism is presenting as a precocious puberty. So if you are getting or if you are facing any children who are having precocious puberty, do not forget to screen for underlying hypothyroidism. Let's come to a very classical case. 20-year-old female complains of menorrhagia since 6 months, excessive bleeding since last 7 days, has taken progesterone and tranexamic acid for 3 cycles, noticed some weight gain on evaluation, having a goiter of grade 2, anemic, TSH is 44 and rest of the profile is normal. So this is very, very classical case. Menstrual irregularities, I think this is the most common in hypothyroidism, 3 times greater than the normal population. They may present with amenorrhea, oligomenorrhea, polymenorrhea, menorrhagia, abnormal uterine bleeding. So remember, yes, we do say that amenorrhea is more common in thyrotoxicosis. Menorrhagia is common in patients with hypothyroidism, but still their patients can have vice versa as well. So they may, both the conditions, hypo or hyperthyroidism, may present to you most commonly with menstrual irregularities. So let us see the menstrual abnormalities in thyroid disorders. Early studies said in thyrotoxicosis, oligomenorrhea is seen around 58%, menstrual irregularities in around 65%. In hypothyroidism, menstrual disturbances is seen around 80%. Hormonal changes in thyroid disorders, I would just like you to see the first 2 lines. The serum hormone binding globulin, that is increased in thyrotoxicosis, it is reduced in hypothyroidism. Because of increased in SHBG, there is increased in the E2 as well. There is increased in the T3 and T4, and which is reduced in hypothyroidism. Thyroid hypothyroidism is always not that simple when you see it in young females. There may be a comorbidity which might be along. So it is a hand in glove. Thyroid and PCOS go together, and they may have or they may present with features of one when the underlying may be there. So let's see the thyroid dysfunction and PCOS. Thyroid dysfunction and PCOS are the two most common endocrine disorders in general population. The etiopathogenesis of hypothyroidism and PCOS is completely different, but there are still many features in common. Let us see what happens to the ovaries in thyroid disorders. In patients with primary hypothyroidism, there is increased TRH. So that increased TRH, it stimulates the prolactin. So that causes decreased frequency of GnRH. So there is increased FSH relative to LH. There is increased adrenal DHEA, which causes follicular maturation arrest, and increased TSH. It causes spillover effect on the FSH receptors. Of thyroid disorders in PCOS, there is increased incidence of thyroid disorders in females with PCOS. And according to the Young study, it reported that there was higher frequency of subjects with subclinical hypothyroidism, autoimmune thyroiditis, and goiter in PCOS subjects compared to control subjects. So remember that if you are treating a patient with PCOS, the patient can still have an underlying hypothyroidism. So it is very, very important to screen for an underlying hypothyroidism in patients with PCOD as well. Autoimmunity in PCOS. So there are many postulates. One is hyperestrogenism has been proposed as one of the explanation for occurrence of increased autoimmune disease in females when compared to males. This is an interesting paper which says there is high prevalence of polycystic ovarian syndrome characteristics in girls with euthyroid CLT, that is chronic lymphocytic thyroiditis. So the CLT girls had a higher BMI, waist circumference, and systolic blood pressure, and they had higher prevalence of PCOD when you compare it with the normal population. Autoimmune thyroiditis is more prevalent in PCOD than in controls. PCOS patients with AIT have less severe hyperandrogenemia and hyperandrogenism, but are likely to suffer from an elevated metabolic risk. So this is my most important second slide. Autoimmune thyroiditis is more prevalent in PCOS than in controls. So if you have a PCOS patient who does not present to you clinically, where the patient is obese, but you will not find clinical features of hyperandrogenism like hirsutism, acne, or you do not have a biochemical hyperandrogenism features, do not forget to screen for an underlying hypothyroidism in these patients. Patients who do not present to you classically with PCOS may have an autoimmune thyroiditis in them. So do not forget to screen for AIT. What is the link? There is increased BMI insulin resistance, which is seen in both the conditions. Increased BMI is again an integral part of PCOS and is seen large majority of cases. And TSH is higher in patients or in people with higher BMI. Let us see the ESHRE 2018 guidelines on PCOS. What does it say? So step one, so if you have a patient who comes to you with irregular cycles and you have clinical hyperandrogenism features in the form of acne or hirsutism, if you are excluding the other causes, then the diagnosis is confirmed. Step two, irregular cycles are there, but you have no clinical features of hyperandrogenism. Then you test for the biochemical hyperandrogenism, you test for the total testosterone, you test for the others. It is there, it is increased, then the diagnosis is confirmed. Still that is not there. You have only a patient who comes to you with irregular cycles. or hyperandrogenism, either of the two. So if it is an adult, you do an ultrasound and see for the polycystic ovarian morphology in the ultrasound. And if you have an adolescent, then ultrasound is not indicated and you consider these patients at risk of PCOS. What are the other causes? Remember, this is very important. What are the other causes you have to rule out when you're diagnosing PCOS is TSH, prolactin, FSH, and other conditions like non-classical CAH, Cushing's, adrenal tumors. This itself can also mimic presentation similar to PCOS. So do not forget to look for these when you are diagnosing your patient. Coming to the most important aspect of thyroid disorders and infertility. We have seen a number of times there is a lot of ovulatory disturbances which we see in patients with hypothyroidism and pregnancy. Why does this happen? The ovulatory disturbances are there because there is decreased in SHBG pool, there is increased TSH, which is causing pseudo feedback inhibition of FSH and LH. There's impaired LH response to GnRH stimuli. High TRH stimulates prolactin. There is increased in the ovarian volume. What does the ITS and FOXY 2019 recommendations for management of thyroid dysfunction in pregnancy? Evaluation of serum TSH is recommended for all women seeking care for infertility. Because autoimmune thyroid disorders affects 5 to 20% of women of childbearing age. Just to see the effect of thyroid dysfunction and autoimmunity on fertility, this was a meta-analysis which was done. So they have come out with guidelines now which says that levothyroxine may be considered in euthyroid or thyroid autoantibody positive women who are undergoing a replacement therapy given its benefits in comparison to the minimal risk. Subclinical hypothyroidism in pregnancy. Again, this is a very nice paper which was done. This is a meta-analysis of the randomized controlled trials. So this clearly says that there is evidence that levothyroxine should be supplemented, recommended to improve clinical pregnancy outcomes in women with subclinical hypothyroidism or thyroid autoimmunity undergoing replacement therapy. Again, there is another paper which is again endorsing on the point that given its potential to reduce the miscarriage rate, levothyroxine supplementation is recommended for infertile women with subclinical hypothyroidism or patients who have antibody positives who are undergoing IVF. So levothyroxine is recommended for infertile women with overt hypothyroidism. Levothyroxine may be considered in subclinical hypothyroid women who are attempting natural conception, given its potential benefit in comparison to the minimal risk. And SCH women undergoing IVF should be treated with levothyroxine and the TSH goals should be less than 2.5. Pregnancy itself is a natural stress test for the females. It is a stress test for the thyroid gland as well. So this is the most important third slide. Remember, there is increased estrogen in pregnancy. There is 2 to 3-fold increased in the thyroid binding globulin. So there is increased in total T4 and total T3. So here the normal level of total T4 is 1.5 times the non-pregnant state. 1. HCG has a similar structure of TSH, so it stimulates release of T3 and T4, and there is a transient TSH suppression which is seen in 8 to 14 weeks. We get a lot of patients, a lot of referrals from our gynec counterparts with TSH suppressed in between 8 to 14 weeks with normal T3, normal T4, clinically euthyroid, but we do get a lot of referrals. So this is physiological. Just because of the similarity of structure of HCG and TSH, there is suppression of TSH which is happening between 8 to 14 weeks where T3 and T4 is normal. and there is non-functioning of fetal thyroid until the age of 12 weeks. So remember that thyroxine supplementation is very, very important for the first 12 weeks for the brain growth of the baby. This is again a very interesting paper which was done by my senior colleagues to see the prevalence of epidemiological prevalence of hypothyroidism in pregnancy in 11 cities and 9 states of India. You will see when the cutoff was increased, or when the cutoff was reduced from 4.5 to 2.5 or 3, the incidence or the prevalence shot up from 15 to 44%. So you will see it is almost 3 times that you'll be able to diagnose more patients when the cutoff has been shifted from 4.5 to 2.5 or 3. All pregnant females should be screened at first antenatal visit by measuring TSH levels. The trimester specific TSH goals should be first trimester 2.5, second and third trimester 3. If you do not control hypothyroidism in pregnancy, it will have deleterious effect on the mother, on the fetus, and the neonatal as well. So what does again the ITS and FOXY 2019 recommendation for management of thyroid in pregnancy? Management of overt hypothyroidism during pregnancy. All overt hypothyroidism with TSH of more than 2.5 should be treated. The dose, if you're starting somebody on a new patient detected during pregnancy, you should start with 1.6 to 2 micrograms per kg per day. Maintain target levels of TSH. We've seen that less than 2.5 in first trimester, 3 and 3 in second and third trimester. Patients with pre-existing hypothyroidism increase the levothyroxine dose by 30% as soon as pregnancy is diagnosed. So do not wait for the reports. If you get somebody who comes to you, known case of hypothyroidism on treatment, they come to you saying, I have missed my period, just increase the dose by at least 30%. When it comes to monitoring, you have to do monitoring 4 to 6 weeks until mid gestation and at least once nearly 28 weeks of gestation. This is again most important fourth slide where you should give levothyroxine. So levothyroxine is recommended for women with TSH greater than 10. So if TSH is greater than 10, there is no discussion. You are starting the patient on levothyroxine. Where TPO antibody is positive and TSH is between 4 to 10, again you are starting the treatment. So TSH more than 10, you're giving treatment. Between 4 and 10, again that is a very gray area. Antibody is positive, you are giving treatment. Levothyroxine can be considered if TPO antibody negative woman between TSH between 4 and 10. So if negative antibodies are negative, but still TSH is between 4 to 10, you give treatment. And TPO antibody positive woman between TSH of 2.5 to 4. So subclinical hypothyroidism during pregnancy is defined as TSH between 2.5 to 4, where patient is clinically euthyroid, T3 and T4 is normal. When TSH is between 2.5 to 4, TPO is positive, there you start the treatment. Again, this is a very, very gray area, but by now we are getting a lot of clarity. So 2.5 to 4, antibody is positive, start the treatment. 4 to 10, even if antibody is positive, you have to start the treatment. But if it is antibody is negative, 4 to 10, it's a precious pregnancy, a patient is having infertility, then you can give levothyroxine just because of the benefit versus the risk what your patient has. Now let's come to the most important part. Yes, we have talked about the precocious puberty, we have talked about the infertility. Now let's see the menopause. Symptoms such as fatigue, depression, mood swings, and sleep disturbances are associated with menopause. They may also be a sign of hypothyroidism. So remember, yes, the symptoms of premenopause or menopause can mimic like hypothyroidism. So if your patient are having a lot of symptoms of menopause, do screen them for an underlying hypothyroidism. because if an untreated thyroid disorders, it may exacerbate or it may increase the risk of osteoporosis and cardiovascular disease. In patients over the age of 60, cardiovascular and myopathic manifestations predominate. The most common presentations are palpitation, dyspnea on exertion, tremor, nervousness, and weight loss. So if you have any females who is complaining specifically of all these problems, do not wait. Just go ahead and screen for an underlying thyroid disorders. Thyroid abnormality in perimenopausal women with abnormal uterine bleeding. So commonly found AUB in perimenopausal women with thyroid dysfunctions are heavy menstrual bleeding, oligomenorrhea, or polymenorrhagia. So it is very important to screen for all women for thyroid abnormality who presents to you with abnormal uterine bleeding, especially with non-structural causes of AUB. So if you have a menopausal woman who comes to you with, or who a perimenopausal woman comes to you with symptoms of menstrual disturbances where there is no structural causes like fibroid, or there are no other structural causes, you have to rule out an underlying subclinical hypothyroidism or other thyroid disorders. So thank you very much for your patient listening, and I'll be happy to take any questions if there are any.
Thank you, Dr. Farishta, for this wonderful talk. I think you have answered so many of our queries in your mind. One thing comes to my mind. Say this 8 to 14 weeks is a time in which you have physiological suppression of the TSH. Now somebody is, say, is pregnant, comes with a and gets to know that she is pregnant, and with a TSH of say 5, and you increase the thyroxine by 30 to 50%. Now, in the period between 8 to 14 weeks, if you test and you get a TSH of say 0.05 there, so what does the clinician do? Does he continue with the same dose because it's expected to be a physiological suppression at that point of time?
Yeah, I think that is where we have to do monitoring by doing the free T3 and free T4 level. So most of the time we doing a free T4. If that is also normal, then we do an free T3, which could be an isolated T3 problem. But monitoring during pregnancy has to be done with a free T4 levels and a TSH. And as you rightly said, if TSH is suppressed and then you do a free T4 levels, if free T4 levels is below the normal, so the whole treatment guidelines and whole idea is to keep the TSH below the normal and free T4 above the normal, because you do not want your precious child to develop hypothyroidism or hyperthyroidism. So specifically when you're treating hypothyroidism, free T4 levels should be above the normal and TSH below the 2.5. So if you get a scenario where you're talking about if it is suppressed, you do a free T4 levels. If free T4 is normal, I think you can just continue the treatment. If free T4 is also less, then probably you can increase the dose and monitor it after 4 weeks.
I have another question. See, in the rare event, say, suppose you get a a pregnant lady actually getting symptoms of hyperthyroidism, okay? She's having tremors, weight loss, and all that. You have a TSH which is low, which you think because clinically she has symptoms of hyperthyroidism, this is probably true. The free T4 is high. In a normal circumstances, we will probably end up doing a radio technician scan, determine with this Graves or thyroiditis, and treat with beta blockers or otherwise. So what do you do in a pregnant lady if you have something like that?
See, when it comes to subclinical hyperthyroidism in pregnancy, we generally do not treat, as compared to subclinical hypothyroidism in pregnancy, where the guidelines are very clear, you treat the patient. So you do anti-TPO antibodies if your center is having facility of doing TSH receptor antibody. That is one great test which will clearly differentiate and which will give you a lot of information about the auto antibody, which is, or autoimmune condition which is happening. You can do an ultrasound of the neck as well, which will give you a lot of information of physiological changes which are happening. So these two things will help you whether you should give treatment or you should not give treatment.
Okay. Okay, doctor. Thank you very much. I think
I have one question.
Will have questions.
Yeah, imagine there is a priming in the first trimester of pregnancy, not a known hypothyroid, and when you check her TSH levels, it is seen as say 0.001. Now, how do you proceed? She is in the 12th week now.
Yeah. So see, for anything, definitely, I think clinically, history-wise is where we definitely like to take the history first. So when the TSH is suppressed and then it is around first trimester, we will definitely ask them about clinical symptoms, the weight gain, whether it is normal or the patient is not having any weight gain. And then of course we will do the free T4 levels. So here, if the scenario, if we do a free T4 levels, a free T4 is supposed is elevated, so free T4 is elevated, TSH is suppressed, then we are dealing with a case of thyrotoxicosis during with pregnancy. Our next scenario, let us consider the normal, where free T4 would be normal, TSH is suppressed, patient is clinically euthyroid. So this is condition where we are not doing anything. We are just monitoring the patient. And then if the patient is becoming symptomatic, we can also do the TSH receptor antibodies and do an ultrasound of the neck to rule out about the autoimmune status of the patient.
Okay.
Thank you.
Thank you, doctor. I think that was helpful in whatever Dr. Farishta has told us. Only thing it comes to my mind is that, see, suppose somebody is a known Graves' disease or into pregnancy, we change into propylthyrosol and move forward. So now here we have hyperthyroidism, which it can be a thyroiditis, which could be Graves. So normally in pregnancy, when you have this symptoms of hyperthyroidism with a free T4 raised, we're a little stuck because here we may not do a isotope scan. But as Dr. Farishta said, maybe doing an ultrasound, look for evidence of by normal thyroid ultrasound, looking for thyroiditis would help, and TSH receptor antibodies, as is rightfully said, would help us in deciding what we're dealing with, whether to put somebody on beta blockers or to put them on propylthyrosol is what to be decided at that time.
Yeah, if there are no further questions, I think we will end this session here. And thank you, Dr. Faraz, for a wonderful
Thank you so
insight
much.
into the thyroid and detailing of all the scenarios. So thank you very much, and thank you, Subrata Das, for your excellent guiding through the session. So the next
Thank you so
topic
much.
will
Thank
be
you.
going on to understand what are the top 10 that has been announced in the latest guidelining bodies, that is the ADA and the EASD. So for this, we have our Dr. Shekhar from Manipal Hospital, and to chair this session, I invite Dr. Karnesh Kumar. Dr. Karnesh Kumar is a senior consultant diabetologist practicing around Kormangla area, and he's got a certificate course in evidence-based diabetes management, and he believes in patient-centric treatment and managing a fine balance between the guidelines and clinical experience. There is no better person to be chairing this session. Over to you, Dr. Karnesh Kumar.
Good afternoon, everybody. So, at the outset, I congratulate Dr. Manohar, Dr. Vijay Kumar, and the entire team of Disha for conducting this beautiful summit, digital summit. It's my privilege to chair this session. Now, it's my pleasure to introduce Dr. Shekhar. He is well-known diabetologist in Bangalore. He is consultant physician and diabetologist in Manipal Hospital. He is the treasurer of RSSDI Karnataka chapter. He is treasurer of Disha India Foundation. So I welcome Dr. Shekhar to give his talk.
Thank you for the kind words, sir. Without wasting much time, without much ado, I think we should move forward because we're at the fag end of the day, and we know that there is always a 11th man or a 12th man in the team, and today I happen to be the 14th man in this whole event. So without talking much more about being a 14th man, I feel privileged and honored to be given an opportunity to talk about the best of ADA and EASD 2020. Now, let's move straight to proceedings of the ADA 2020. There have been a few landmark trials that have been discussed. So we'll go one after the other. The first one being the interrelationship between hypoglycemia and cardiovascular and mortality outcomes in the Carolina trial. Most of us have been hearing about this trial since the last 3-4 years, wherein the Carolina, wherein linagliptin was used, and it was found to be much more effective when compared to other gliptins. However, there is still much more to decide, discuss, and debate about this. Now, when we know, all of us know that hypoglycemia, which includes severe hypoglycemia, wherein the blood glucose levels drop to less than 70 levels clinically, or when someone has symptoms, then we should call it as hypoglycemia, and it is known to be associated with an increased risk of cardiovascular events and mortality. And this was noticed both in a clinical trial setting and also in population studies. Now, despite the consistent association between hypoglycemia and with CV events and mortality, there is no direct causality that has been demonstrated. So what was done is they have done a head-on trial with glimepiride in the Carolina trial, and there have been several potential mechanisms also that have been linked acute hypoglycemia events with a deleterious impact on the cardiovascular system, including the autonomic activation and hemodynamic changes. Now, the primary outcome was the 3-point MACE. All of us knows was CV death, non-fatal MI, non-fatal stroke. What they found, they wanted to see how this works out, and what was seen is that among adults with relatively early type 2 diabetes and elevated CV risk, the use of DPP-4 inhibitor linagliptin when compared with glimepiride over 6.3 years resulted in a non-inferior risk of 3-point MACE. So that means they were not able to demonstrate any much benefit with the use of glimepiride and linagliptin when they compared with to look at the 3-point MACE. And the results were, there were almost 6,014 patients, participants were there in the study, received more than one dose of the study drug. And the data showed that hypoglycemia were experienced in 646, that is approximately 10.7% of the patients, with significant between group differences in the hypoglycemia. The conclusions were that the occurrence of preceding hypoglycemia was definitely associated with a higher risk of all-cause mortality and non-cardiovascular mortality, but not with any other outcomes in a relatively early type 2 diabetes individuals at elevated CV risk following multivariable adjustments were seen. The relative effect of linagliptin versus glimepiride on any cardiovascular or mortality outcome was not influenced by the antecedent hypoglycemic events. Now, what the experts felt that the results of Carolina were disappointing to some in that there was no cardiovascular benefit that was associated with the use of DPP-4 inhibitor, especially linagliptin, as was in the Carolina trial, versus the glimepiride, despite much less hypoglycemia in the linagliptin treated patients. So, even though the number of patients who experienced hypoglycemia with the use of linagliptin was less, however, not comparable differences were seen in cardiovascular outcome, or there was not much of a cardiovascular benefit. And thus they felt that more detailed analysis of the relationship between previous or antecedent hypoglycemia and cardiovascular risk in Carolina, interestingly, did show higher all-cause and non-CV mortality, but not MI, stroke, or cardiovascular mortality in patients with prior hypoglycemia. So once again, however, this does not prove the causality. Next, going to the next one, that is the LIRA Prime trial, and I am privileged and honored to be a part of this LIRA Prime trial, which was done by Novo Nordisk. This happened almost 2 years ago. I was one of the investigators for this trial, wherein they used metformin. Patients who were on metformin only were taken into the study, and the objectives were to check the time to inadequate glycemic control, which was defined as a HbA1c of more than 7 at 2 scheduled consecutive visits after the first 26 weeks of treatment. So patients were there for 26 weeks, after which they underwent a HbA1c level, and if it remained consecutively more than 7 in 2 consecutive visits, they were out of the study. Secondary objective was to compare the efficacy and safety of liraglutide versus OAD. So one arm was metformin with liraglutide, and the other arm was metformin with any other OAD of our own choice, both as add-on, and this trial went up to 2 years, that is almost 104 weeks. So now the conclusions were, when they looked at the efficacy, so when metformin was inadequate to keep a patient with type 2 diabetes in glycemic control, so adding liraglutide compared to OAD, the time to inadequate glycemic control was significantly longer for liraglutide compared to OAD. And duration during 104 weeks duration of the study, fewer subjects discontinued due to inadequate glycemic control with liraglutide. So the number of participants who were left out of the study after 26 weeks but before the end of 38 weeks was very few in the liraglutide arm. The time to premature treatment discontinuation for any reasons, including inadequate glycemic control, was significantly longer for liraglutide, and fewer subjects discontinued prematurely with liraglutide compared to the OAD. So what this tells us is that we had the option of increasing the dose of liraglutide substantially from 0.6 we started, went up to 1.8. OADs also similarly, the dose was enhanced, but in the patients who were in the randomized to the liraglutide arm tended to be more for a more duration in the study. So safety wise, if you see, rate of serious adverse events was similar for both the treatment groups, that is the liraglutide and the OAD arm. Rate of hypoglycemia episodes were similar for both the treatment groups, and there was no apparent or unexpected safety or tolerability issues in the trial. Going to the third one, the HbA1c levels and rate of hypoglycemia with insulin degludec U200 and glargine U300. So the background was impaired renal function, as all of us know, is a common long-term complication in people with type 2 diabetes. In some cases can result in decreased insulin clearance and an increased risk of hypoglycemia in those who are treated with insulin. So the conclude trial was a randomized head-to-head trial comparing insulin degludec and insulin glargine U300. So aim was to investigate and compare between degludec and glargine U300 HbA1c and hypoglycemia endpoints stratified by estimated baseline renal function. So what was noticed here is that irrespective of renal function, degludec resulted in similar hypoglycemia rates and HbA1c, which were consistent with the primary analysis. And results, what it showed is that end of trial daily total daily insulin dose was lower with degludec versus glargine U300, with significant difference observed in the baseline EGFR between 60 to 90 group. And summary, in this hypothesis generating post hoc analysis from the conclude trial, rate ratios of hypoglycemia and A1C the primary analysis across all renal impairment groups, and irrespective of renal function, there was a trend towards a reduction in HbA1c and total daily insulin dose from baseline with degludec versus glargine U300. Going to the next one, that is the effect of dulaglutide on kidney function related outcome in type 2 diabetes. Again, rewind trial, dulaglutide was used for a medium follow-up of 5 years and was associated with reduced composite renal outcomes, defined as the first occurrence of new macroalbuminuria, sustained decline in the EGFR of more than 30%, or chronic renal replacement therapy. The objective was to evaluate the effect of dulaglutide on renal outcomes related to kidney function that are typically used in renal outcome studies, and is defined as the composite endpoint of sustained EGFR decline of more than 40%, ESRD, or all-cause death. So the conclusion was the incidence rate of the composite endpoint was significantly lower for the dulaglutide group compared with the placebo, and the treatment with dulaglutide 1.5 mg was associated with a 17% risk reduction in kidney function related outcome, and suggesting a potential delay in progression of diabetic kidney disease in patients with type 2 diabetes at severe risk. So dulaglutide was found to be beneficial in at least reducing the risk of kidney related outcomes in patients with diabetes to an approximately level of 17%. Next is the glycemic variability. So the persistent problem of diabetic kidney disease, as I told again, we know that it is a cause of increased morbidity and mortality among persons with diabetes. And all of us know that there have been a lot of medicines that have been advised, suggested over the last 2 decades, especially when it comes to use of RAS inhibition, or even use of uricosuric drugs also to a great extent. So they wanted to see this. So the goal of the Pearl study was multiple lines of evidence from animal models, epidemiological studies, and small clinical trials have implicated higher serum uric acid levels as an etiologically relevant and modifiable risk factor for CKD in general and DKD more specifically. So what they wanted to see here is that does lowering of the serum uric acid level with allopurinol slow the EGFR decline in patients with type 1 diabetes and mild to moderate DKD. So the study results showed a 10% increase in the mean cardiovascular CV was associated with a 1.4 ml per minute per body area decrease in the IGFR at the end of the study. And for those with a CV of more than 36, it was 2.56, lower compared with those with CV of less than 36. Lower blood glucose index, high blood glucose index, MG and TIR were not significantly associated with IGFR. Conclusions: in persons with type 1 diabetes and mild to moderate kidney disease, there is no evidence that glycemic variability or glucose control impacts the rate of loss of EGFR. Limitations were, it was an observational study design, it was a small sample size, variability of continuous glucose monitoring data collection, and short duration of observation. Now, next is we look at the efficacy and safety of fast-acting insulin aspart according to baseline HbA1c. So the background aim was this was called the onset 9 trial. So faster aspart provided effective overall glycemic control with improved PPG control and a lower rate of severe or BG formed hypoglycemia compared with IASP in adults with type 2 diabetes. The aim of the onset trial was to investigate the impact of glycemic control at baseline on the efficacy and safety of faster aspart in patients with type 2 diabetes. Conclusion: faster aspart provides effective overall glycemic control with improved PPG control compared with insulin aspart in adults with type 2 diabetes. For individuals with HbA1c of less than 7, faster aspart provides a similar reduction in HbA1c versus IASP, but with less hypoglycemia. And for individuals with HbA1c of more than 7, faster aspart may offer a greater reduction in HbA1c versus IASP without an increased risk of hypoglycemia. Now looking to the EAST talks. So this was the main one there, the Emperor reduced trial. So the trial design was, it was a phase 3 randomized double-blind placebo-controlled trial. The aim was to investigate the efficacy and safety of empagliflozin versus placebo on top guideline-directed medical therapy in patients with heart failure with reduced ejection fraction. Population contained people with diabetes and people who are non-diabetic more than 18 years or chronic heart failure. The study design, so they were divided into two groups. One was the empagliflozin 10 mg and the other was the placebo. And confirmatory endpoints, the composite primary endpoint was time to first event of adjudicated CV death or adjudicated hospitalization for heart failure. Secondary were first and recurrent adjudicated hospitalization for heart failure events and slope of change in EGFR from baseline. So when they did a hierarchical testing, the primary outcome was the composite of adjudicated cardiovascular death or hospitalization analyzed as the time to first event. The first secondary outcome was the occurrence of adjudicated hospitalization for heart failure, and the second secondary outcome was the rate of decline in the EGFR. So what they found is the Emperor reduced trial showed superiority for empagliflozin versus placebo for all three endpoints with high significance by hierarchical testing. The efficacy of empagliflozin was concordant to that of dapagliflozin in the DAPA-HF trial, and the benefits of SGLT2 inhibitor to slow the progression of chronic heart failure and renal disease are seen in patients with and without diabetes. So when you look at the study, this opens up the arena for not only for the diabetologists or endocrinologists in the use of SGLT2 inhibitors, but also brings in the cardiologists who can make use of it in patients who have a reduced EF or ejection fraction. So the conclusions: in patients with chronic heart failure and a reduced EF, Emperor reduced achieved all three endpoints pre-specified as key outcomes. The 25% decrease in the risk of composite of cardiovascular death and heart failure hospitalization observed was identical to that seen in DAPA-HF trial. The benefits of empagliflozin to slow the progression of chronic heart failure and development of CKD were seen in patients with and without type 2 diabetes. So taken together, we believe that the results of DAPA-HF and Emperor reduced should be sufficient to establish SGLT2 inhibitors as a new standard care for patients with heart failure and a reduced ejection fraction. Now going further, the GLP-1 semaglutide, which can be again, GLP-1 agonists, as we know, are a powerful type 2 diabetes drug that works to lower glucose levels in people with type 2 diabetes and are taken by injection. So regardless of baseline A1C, people experience reduction in the HbA1c and they decrease regardless of age, background medication, race or ethnicity, and duration of diabetes. Semaglutide was also successful for improving diabetes management in people with kidney disease and high risk of heart disease. In Pioneer 5, people with moderate kidney disease taking semaglutide showed major decreases in A1C and body weight. So semaglutide is the first approved GLP-1 RA pill and brings a very important message that addition of semaglutide on the top of standard care is able to give approximately a 20% risk reduction in 10-year risk of experiencing cardiovascular events compared to standard of care alone. In simple way, semaglutide, if added, can extend life without a cardiovascular event in patients with type 2 diabetes and high cardiovascular risk for up to 3 years, with average being 18 months. So when we look at the drug, when we look at the studies that have been done and the amount of benefit that we are able to achieve with the use of the drug, it opens up a new arena in the use of a oral GLP-1 receptor agonist, that is semaglutide. And a post-hoc analysis of the SUSTAIN 1-7 trial shows that semaglutide has the potential to improve renal function with type 2 diabetes with a marked reduction in the urinary albumin to creatinine ratio, and thus there is a reduced risk of ESKD also. And new findings in totality suggest that semaglutide has a suitable renal safety profile and has potentially renoprotective effects also, apart from reducing the risk of MACE across the continuum of baseline CV risk in broad type 2 diabetes population. Now looking at early onset type 2 diabetes has worse outcomes than usual onset. This is the PCD symposium. Again, this was present in the EASD 2020. This was done by Dr. Kamlesh Kunti, and it showed that people with early onset type 2 diabetes, that means who have been diagnosed with diabetes before the age of 40, have a 14 times greater risk of developing problems and a 30 times greater risk of stroke than people without diabetes. For these people, combinations therapy is strongly encouraged. So the old method of going by the book, wherein we say that start with lifestyle, then diet, and then go with metformin, does not hold good anymore when we see someone who is young and is diagnosed with diabetes. So we should always try to stratify patients based on the risk, looking at the whether they are at high CV risk or not, and accordingly we should decide on the treatment. So treatment recommendation for patient with ASCVD, initiating metformin plus with SGLT2 or GLP-1 RA. So the old line of again using metformin, then glimepiride, then added DPP-4 has gone now. So the second choice of drug after metformin is now SGLT2 inhibitor or a GLP-1 RA, depending on the patient's clinical status. So again, patients with heart failure, consider metformin with SGLT2 rather than stepwise. And again, metformin as first line therapy, SGLT2 as second line. And we should always remember that avoid pioglitazone in patients with heart failure. Next is for patients with CKD, consider initiating metformin plus SGLT2 rather than stepwise approach again. And GLP-1 happens to be the third line of therapy. In patients who are at high cardiovascular risk, again, it has been taken over by metformin followed by SGLT2 or GLP-1 RA or DPP-4 inhibitor. It depends on the pocket of the patient. So we can definitely take a call, but all of us should remember that we should move away from sulfonylureas from the use. I'm not saying they're bad drugs, they're definitely good drugs, cheaper drugs, but yes, we should always look at patient benefit when we prescribe any drug nowadays. And recommendations for patient with obesity, again, metformin. After that, we can add GLP-1 or an SGLT2 inhibitor as the first line of therapy, though metformin still happens to be the first line. And for elderly or frail patients, we should always avoid stringent glycemic targets that increase the risk of hypoglycemia. As we know that as age progresses, the body's response to hypoglycemia starts coming down. So someone who is elderly and frail may not be able to pursue hypoglycemia even when clinically their blood sugar levels drop less than 70. So we should not be too stringent with them and let them maintain their blood sugars at a comfortable level, not only for them but for also us. So next is the cardiovascular outcome of patients with type 2 diabetes treated with SGLT2 inhibitor versus GLP-1. Again, we are doing a head-on with SGLT2 and GLP-1 RS. So but we know that now we're seeing that both SGLT2 inhibitors and GLP-1 RS have shown benefits in each, and they are almost head-on when it comes to safety-wise. So we'll have a head-on with between SGLT2 and GLP-1 receptor agonists. What was seen is that there are better outcomes in the 3-point MACE with SGLT2 inhibitors when compared to GLP-1, and rates of hospitalization for heart failure were also lower among new users of SGLT2 than new users of GLP-1, and there are no significant differences in overall adverse events. So perspectives, consistent with the literature, SGLT2 inhibitors protect from hospitalization for heart failure than GLP-1, especially in patients without cardiovascular disease at baseline. However, the finding that better outcomes were seen in 3-point MACE with SGLT2 inhibitor compared to GLP-1 RA was unexpected. Now, these data have a moderate level of evidence to help guide clinicians in the choice of agent in new users of SGLT2 or GLP-1 RA. Next, coming to the next study that was on cardiovascular disease by clustering the risk factors in type 1 diabetes. Again, what was seen here is that all of us know that diabetes predisposes to cardiovascular problems, whether it is type 2 or type 1. So type 1 diabetes also complications will lead to cardiovascular disease. So the cardiovascular incidence of cardiovascular complications in people with type 1 diabetes is up to 8 times higher, and it increases with the risk factors. Now, type 2 diabetes, there is a greater clustering of adverse risk factors leading to excess CVD risks. Now, type 1 diabetes, why? So what was the purpose? They measured 7 risk factors. So they checked the BMI, the blood pressure, HbA1c, LDL cholesterol, and also the lifestyle habits, especially diet, physical activity, and smoking. And each risk factor value were divided into 3 groups. So they divided into association with a lower CVD risk, who is the most favorable tertile, and clustering of the favorable tertiles was done. Then what they concluded was that greater clustering of favorable cardiovascular disease risk factors led to a lower risk of incident CVD, and targeting a combination of risk factors led to more effective. It was more effective in preventing the cardiovascular risk. So the tertiles that you see were they targeted mostly HbA1c, then comes to physical activity, then blood pressure, then diet, smoking, LDL-C, and BMI. So all these factors were taken into consideration, and this is what they found. Going to the next, that is the DAPA-CKD study. So these new data extend the beneficial effect of SGLT2 inhibitors, especially dapagliflozin, from patients with type 2 diabetes to patients without diabetes. So if implemented, this data that dapagliflozin will be a long-awaited new treatment option for many patients with CKD, regardless or not they have diabetes. So conclusions: the DAPA CKD study is a well-conducted study demonstrating renal protection in CKD patients, whether their type 2 diabetes is present or not, and it is the next step in the evidence accumulating for this class of agents, that is clear effect in heart failure with reduced ejection fraction patients independent of type 2 diabetes, and clear protective effect in CKD patients independent of type 2 diabetes. So the challenge for the learned societies, that is, we should make clear guidelines, clinicians should follow the guidelines, the regulators should adopt labels, and companies, we should be wise in pricing, especially in a country like ours, is to bring these agents to those patients who will benefit on the basis of evidence available. So again, DAPA CKD study moves SGLT2 class, especially dapagliflozin, from treatment related or very limited to treatment of diabetes alone to people who have a reduced ejection fraction, or even those who have a CKD. Now looking at the VERTIS CV trial, again what was seen is that in this atogliflozin was used, and it was found that the atogliflozin reduced the risk of pre-specified exploratory renal composite, which included a sustained 40% decline in EGFR, chronic renal replacement therapy, or renal death. The relative risk reduction for the kidney composite was similar across all CKD stages and level of UACR and KDIGO CKD risk category, demonstrating consistent kidney benefits. And atogliflozin was found to significantly reduce UACR in patients with a range of albuminuria at baseline, preserve the kidney function, especially in patients with macroalbuminuria who are at greater risk of DKD progression, and EGFR declined acutely with atogliflozin and was then better preserved over time compared with the placebo. Next, intensive risk factor management on peripheral autonomic neuropathy in type 2 diabetes from the ACCORD clinical trial. Key messages were intensive blood glucose and BP interventions in type 2 diabetes reduced the risk of autonomic neuropathy by 17 and 22% respectively. Intensive glycemic control was more effective in patients without prior history of CVD, and BP lowering was more effective in patients who were more than 65 years of age. However, these benefits must be weighed against increased risk and cost, and especially the excess mortality observed with the intensive glycemic control in the ACCORD trial. So what were the findings? During follow-up, there was a 17% reduction in risk of developing CAN in those undergoing intensive glycemic control. Intensive BP control also reduced the risk of CAN by 22%, and addition of fenofibrate to statin treatment did not appear to have beneficial effects on the risk of CAN. Glycemic intervention was particularly effective in those who had no prior CVD at baseline, and BP intervention was more effective in those who were aged over 65. Now, perspectives: intensive glycemic control was effective in type 2 diabetes without prior history of CVD, and BP lowering was more effective again in who were more than 65. And these benefits must be considered with regard to the risks and costs associated with these interventions. Next is once weekly insulin efficacy similar to daily therapy in type 2 diabetes. So what they did is they used once weekly basal insulin icodec. It was found to check whether it offers comparable efficacy and safety versus once daily insulin glargine U100 in insulin naive type 2 diabetic inadequately controlled on OADs. So the summary of the key features of insulin icodec: molecular modifications underlying longer half-life. So let us understand a little about the icodec. There are the 3 amino acid substitutions prevent enzymatic degradation, ensure stability and solubility. Addition of a C20 fatty diacid imparts strong and reversible albumin binding. All modifications contribute to slower receptor-mediated clearance. Icodec interacts with insulin receptors to activate the same signaling pathways to give the same full metabolic effects as human insulin. Icodec does not demonstrate increased binding to the IGF receptor and has low mitogenic potency. So, summary: once weekly insulin icodec displayed similar glucose lowering effect and safety profile to once daily insulin glargine U100. There is no significant difference between treatments in change from baseline in A1C, fasting plasma glucose, or body weight. Improved mean of the 9-point SMBG profile with insulin icodec compared with insulin glargine U100. Rates of severe or level 3 or clinically significant hypoglycemia were low for both the insulin treatments. However, there is no statistically significant differences on the during the on-treatment period, and no new safety issues were identified in relation to insulin icodec in the study. Conclusion: insulin icodec, currently in development as the first once weekly basal insulin analog, displayed similar glucose lowering and safety profile to once daily insulin glargine in this pivotal phase 2 trial. The phase 2 data in totality showed low overall rates of hypoglycemia for both icodec insulin and glargine U100 when comparable insulin dose requirements. Based on the robustness of this data, further evidence on the role of weekly basal insulin icodec will be investigated in a comprehensive phase 3 clinical development program. Insulin icodec could potentially improve treatment acceptance as it is on once weekly and likely would facilitate management in type 2 diabetes patients needing basal insulin. This is the last study, that is the complications versus glycemic variability in people with type 1 diabetes. In type 1 diabetes, HbA1c and duration of diabetes are important risk factors for the development of chronic complications. A shorter duration is associated with severe several microvascular complications and especially retinopathy. TIR is also associated with hospitalization for hypoglycemia or ketoacidosis. Now, what they found is that using data from the Belgium rescue trial, which included approximately 515 adults with type 1 diabetes using insulin pumps, it was explained the strong correlation between time in range and several microvascular diabetic complications. Retinopathy was also strongly correlated with TIR. The rates of retinopathy for people with TIR below 40% were double the rates of retinopathy in people with TIR above 70%. Now, these are the top 10 messages from ESG 2020. In future, adding semaglutide on top of standard care can be very appropriate norm, as there is a 20% risk reduction in 10 years of getting cardiovascular events. A straight use of early combination therapy for cardiorenal risk reduction by prescribing metformin with SGLT2 and GLP-1 RA has been suggested by the PDC symposium. Emperor Reduced trial has emphasized on the efficacy of empagliflozin in reducing the risk of cardiovascular death and hospitalization for heart failure in patients with or without diabetes. Real-world study has provided a moderate level of evidence to use SGLT2 inhibitors or GLP-1 receptor agonists in new users of type 2 diabetes patients. Targeting combined risk factors appeared to be the most effective way in preventing CVD risk than targeting single factors. DAPA-CKD coins a new option for treatment for many patients of CKD, regardless whether they have diabetes or not. The ability of dapagliflozin to reduce the cardiorenal risk is spectacular. New Vertis CV showed that etugliflozin reduces risk for worsening renal function, dialysis, or renal death in comparison with placebo in patients with type 2 diabetes. New data presented from the ACCORD showed that intensive blood glucose and blood pressure interventions in type 2 diabetes reduced the risk of cardiac autonomic neuropathy. And the next is, it is a transformational news that once weekly insulin icodec has shown significant promise in phase 2 trial. This might change the way we treat insulin requiring type 2 diabetes patients. And last but not the least, rescue trial data shows that more time in range is associated with fewer microvascular complications, chronic complications in comparison with glycemic variability of type 2 diabetes. Thank you. Any questions? I think there should not be any questions. This was just a summary.
I think this was like a very big meal, you know. It's so much of information was there, and so many new updates were there.
Karunesh.
Yes, so this was so much of information was there. It's so wonderful session by Dr. Shekhar, and it was good.
Thank you, sir.
If there are any questions from anybody.
I don't think there is any further questions.
One thing about Vertis CV, only the ertugliflozin has not shown the benefits like the other SGLT2 inhibitors.
They are still in the process, sir. I think we should wait.
I can't hear them.
There is still a lot of data that is pending. So I think we should wait before we decide on ertugliflozin. Though the best part in the EASD 2020 was about DAPA-HF and also the DAPA-CKD, especially. That was really heartwarming to see.
Thank all the events.
Any comments?
If there are no further questions, I think we have come to the end of this excellent conference today, covering a lot of topics, including Corona, different scenarios in Corona, and the different difficulties with patients with diabetes. And yes, with this, I would like to thank all the speakers who have been giving us a lot of inputs, a lot of insight into these angles, and thank all the chairpersons to be available and made it a grand success.
All the delegates who have logged in throughout, we have got a very good response. Thank you so much for that. And I would like to thank all the delegates who have made this program a grand success, and also all the sponsors of our event. Yeah. I would like to thank all the delegates who have been present here to give us and been listening patiently through the day. And with the outset, I would like to thank the sponsors who have.
Sorry. So I would like to thank all the sponsors who have been helpful in making this event a grand success. I will thank you. Firstly, I would want to thank Novo Nordisk, USV, Torrent, Joester, and all other pharma company who have helped in making this a grand success. And I would like to thank RX Events for extending a wonderful platform and their kind cooperation in mitigating this conference all through this day. And with this, I would like to say that we are ending this session. And I want to remind from here, we are going to start a new session called Madhumeha Panchayati, which is a public perspective platform where patients and their family can address their questions and concerns to the group of panelists sitting, which includes a social economist, physician, diabetologist, one who can address the exercise concerns, one who can also clear the concerns on economical background of treatment of diabetes also. So we'll end this session and we'll move on. Thank you, everybody.
People have